Hello, Jai. Can you hear me?
Yes, I can hear you. Hello.
Okay, great. Yeah.
Great.
The big conference organizer. Yeah.
Thank you.
Incredible. Yeah. Yeah. Very well done.
Thank you. So all hope well. Yeah. So good. Excellent.
Hello, Jai.
Yes.
Can you hear me?
I can hear you very well.
Yes, I can hear you. Hello.
Okay, great. Yeah.
Great.
The big conference organizer. Yeah.
Thank you.
Incredible. Yeah. Yeah. Very well done.
Thank you. So all hope well. Yeah. So good. Excellent.
Hello, Jai.
Yeah.
Jay, a question. I sent you my presentation. You share screen. I think it's a little bit, maybe a lot, because we have already a lot of cases, so maybe we don't need it. But in case we need it, do I share my screen or you share your screen?
Of course, you can share your screen.
Yeah. Okay.
And yeah, we can. I think we can cover it, all the cases. I'll be on time usually. And so you have 9 minutes, so you can share it.
Okay.
That's brilliant. Thank you. And it will allow you, everyone, to share screen. I set it up. So that's
Okay.
That's great. Welcome to our fourth Scottish International Head and Neck Conference. This is my introductory talk. This is Vanakkam in Tamil. It says good morning and namaste. So welcome to the world of Head and Neck Conference. Scotland is beautiful. Food, water, excavations, particularly Highland. You can see untouchable beauty everywhere. I welcome you to Scotland. And a lot of agriculture, flowers, bridges, waters, countryside. Once again, if you have an opportunity, please visit Scotland. And this Head and Neck Conference started 4 years ago in the Royal College of Surgeons of Edinburgh in the Piffers Hall. This is a 500 years old building. But because of the COVID, we moved on to virtual. Again, it goes in a very strong manner. Initially, we started with only 90 delegates because that room accommodate only 90 delegates. Today, I think we have 1,400 delegates registered all over the world from 92 countries, including 25 institutional registrations. And I think the whole credit goes to the faculties as well as the theme of the conference. We do explore international conferences. So one, we did it with the India, the MERV academic unit. And also we have series of a theme plan for next few years as well. We start with the SEC, then salivary gland, the complications. We are now discussing emergencies in head and neck surgery. And probably the next few years, we might be discussing laryngology or other head and neck related topics. And from Dundee, we are also planning to introduce more head and neck programs, distant learning programs, MCH and MSc, and blended learning programs in partnership with Royal College of Surgeons, Edinburgh, and also University of Dundee. So all I realized the world is very small now, because you can see the last year, 758 delegates from 25 from 22 countries. And this year, it's even almost double. I'm very pleased. This is the program. This program is designed by my boss, Professor Pellery, Kimasi, and Ian Nixon. I like inquiry-based teaching method, which means we don't talk too much about the subjects, but we do talk about cases on practical level that gives you firsthand experience with the world-renowned experts who has got extensive experience in dealing in emergency cases. We have loads of faculties, almost 36 faculties meeting in one day, which is one of the another top notch for this conference. Professor Mike van den Brekkel is Amsterdam Head and Neck Unit chair. He published more than 200 publications and authored many textbooks, and he has given many lectures all around the world. Professor Pellery is a consultant Royal Marsden Hospital, heavily involved in research and academics, and authored many books, and as well as chairing important position in ENT UK, as well as British Association of Head and Neck Oncology. Professor John Fagan from South Africa, he doesn't need much introduction. And Mr. Matthew Ellis from Glasgow is a pediatric otolaryngologist. And Omar Helmi is a Glasgow ENT consultant with a special interest in thyroid and airway. He's also a chair for Royal College of Surgeons, Edinburgh, otolaryngology unit. Professor Qureshi, a consultant otolaryngologist from Doncaster, director of ENT Masterclass, has been awarded by Queen as well as other people for his extensive service with the ENT Masterclass. And Prathamesh from Tata Memorial Center is one of the largest cancer center in the world. And Farouk Rifat is from Australia. He's extensively involved in head and neck care. And Chris MacDonald from Aberdeen is a great maxillofacial surgeon with extensive experience in research as well. And Professor Kimasi from Aberdeen, again, is a consultant ENT surgeon with with vast experience in the medical education, as well as Scottish implementation of ENT services. And Ian Nixon is my counterpart at Edinburgh. He's an academic ENT surgeon with extensive experience in publications, as well as writing books and guiding PhD students. And Kishore Sekhar is my colleague from Maxillofacial Group, and he's a recent director for Northern Cancer Center. And Simon Crawley is a lead for airway anesthesia in Scotland, and my colleague, and is special interest in tubeless anesthesia. Dr. Anu is radiology head and neck from Glasgow, and also Raj Bhatt and Dr. Sudeshan, all the three of them are radiologists. Raj Bhatt is an interventional radiologist with extensive experience in dealing emergency cases. And Somaya is from Birmingham. She's a lead clinician and a lead for ENT UK Elephant Project. And Kishore Sandhu is from Switzerland. He's an airway lead in University of Lausanne, and performs many airway surgeries. And he's also giving a talk here, and a member of European Laryngological Society. And Mimi Irene is a head and neck consultant from Addenbrooke, Cambridge. She's also a president of Women in ENT Society. And Professor Stuart Winter is from Oxford. He chairs in a nice committee and holds many grant for trials. And Professor Muthukumar Ramamurthy is my ex-boss from Chennai Upgraded Institute of Otolaryngology in Madras, which treats more than 5 million people and is one of the biggest unit in South India. And Professor Alok Thakur is All India Medical Sciences, one of the largest center in India from Delhi. They have many branches all over the country, and he's also going to be giving some of his valuable experience. And Jayant Kumar is one of the another facial plastic as well as ENT surgeon from South India. And we have Carlos from Spain. He was also trained extensively with the microvascular surgery, though he's a ENT head and neck surgeon. And Cesar Pisa from Italy, again, published more than 200 articles and extensive experience in the head and neck surgery. And Cameron Davis Aspen is a Brighton and Sussex ENT head and neck consultant with a lot of fellowship experience in transferal robotic surgery. And Mirikange D is a consultant surgeon from Birmingham. So, and last but not least, Mervyn is one of my favorite medical students who has got an extensive experience in IT, who helps me in this conference. And also Professor Ghulam Nabi is my patron as well as head of my university division, who keeps motivating me to do this kind of things. And last but not least, Linda. So that's where we are. Finally, it's me. I'm a very simple, straightforward person. Try to spend most of the times with my dog and try to educate me. That's my main motivation to do this kind of work. Is not to educate you, it's actually educating myself. That's the primary goal. Thanks to the sponsors, generous sponsors from different companies. I think that's it, my introductory talk. So we will have ENT UK, Professor Nirmal Kumar has given his introductory talk. Mervyn, do you mind play that one, please? Just a few minutes.
And allied specialties is a heartening example. It gives me great collaboration between President of ENT UK Society to welcome you all in the United Kingdom, the 4th Scottish International and abroad virtual conference on head and neck emergencies. As President of ENT UK, I'm proud it is a veritable academic feast colleagues to see in that Scotland delegates from running so many countries event are participating, proving in this even more successful than it has been, with more than 1,400 delegates. We are proud to quality assure this of many and also teachers As a council member of the Royal College of Surgeons of Edinburgh, ENT, I'm very and allied specialties, Jay and his colleagues is a heartening bringing example of collaboration. There's a stellar list of speakers and all the participants societies will be enriched by participating in this conference and abroad. Today also marks the launch as President of ENT UK. I'm proud Foundation. Our colleagues, we hope, will in Scotland bring benefits running this for the betterment of our specialty event both in the United Kingdom and abroad, even more successful, sustainable basis has been with endowments, fellowships, and research grants. We hope to improve the health inception that we provide. We are and also proud to quality assure this, advance and also as a council member of the Royal College of Surgeons of Edinburgh. Well done to the organisers, pleased to Jay support in particular, Jay and his colleagues, all the colleagues who have bringing make this together. Exciting event. There's a stellar list of speakers and all the participants will be enriched by participating in this conference. Today also marks the launch of the ENT UK Foundation, which we hope will bring benefits for the betterment of our specialty both in the United Kingdom and abroad on a sustainable basis. With endowments, fellowships, and research grants, we hope to improve the healthcare that we provide and also advance our specialty going forwards. Well done to the organisers, Jay in particular, but all the colleagues who have helped make this exciting event possible. And I hope you have a good day. Bye.
That's brilliant. Sorry about the echo. We have fixed it. Thank you. And according to the program, we'll be starting our panel discussion around 9 o'clock. So we have some time. So you can have a cup of coffee or whatever you feel. It's absolutely fine because it's going to be a very busy day. I'll see you back again in another 5 to 7 minutes. Welcome back. We have Professor Ghulam Nabi is here. He's going to give a few words.
Thanks, Jay. Thanks for inviting me. It has been a year since I spoke to you last time. There have been a number of improvements in the pandemic we are going through. However, we are still railing under the shadow of this unprecedented time. I had hoped that I would speak to you face to face this time last year, but it seems that desire has been getting prolonged, and I hope the next meeting would be face to face. In these desperate times, I must congratulate Jay and his team for putting up this program together. And all of us agree that these are incredible times and these efforts need to be lauded, and these are incredible efforts. COVID-19 did bring many devastating events in the lives of many of people around us. And in fact, some of us also suffered from that. But it has taught us a number of things. It has tested our resilience. It has tested our resolve to fight back. It has reminded us that what the teamwork is, and it has also reminded us our social responsibilities. It has unveiled those scars within the society, especially how we look after communities. And some of this very obviously was glaring at us in the last few months was how the society, how the BME staffs get treated, and you must have seen that in papers. In such unprecedented times, it becomes even more important for us to share knowledge, skills, and continue to push boundaries, because that's the responsibility we carry as physicians, how we innovate in our specialties, and how these innovations then get passed on to the next generation. And without the conference like the one you're having today, it's impossible for us to take a step further. Today's meeting is going to be more scientific meeting, but I hope that there are going to be lighter moments for you to share your experiences and have some kind of arrangement that share some kind of experiences that how we looked after each other during these times. I'm sure there's plenty of stuff in terms of scientific contents which you would take back, share with your colleagues who haven't been able to attend this meeting, also take the advantage of this meeting and pass on the benefits of new technology to your patients and public. In Dundee, we have also made some incremental progress in the past year, and some of that is related to ENT, which I would like to share. We have been awarded a Tay-City deals, which would be putting up innovative center in Tayside within the School of Medicine. We have also been awarded, Scottish government has awarded 20 million investment into robotic surgery, which ENT is a part of, and Jay has been leading from Tayside in ENT. And hopefully we should have the minimally invasive surgery for headache neck surgery. We have also been awarded a big grant with the Scottish government to set up first focus ultrasound surgery center within the School of Medicine. So there have been some progresses, but we all share the grief of pandemic, which we have been through, and hope we see some light at the end of the day through the vaccine. With those comments, I don't want to stay between you and Jay to start the proceeding, and I would hand over mic back to Jay to start today's meeting. Thanks, Jay.
Thank you very much, Prof, for your kind words. And I think we are ready to start our panel. The first panel is, I'm doing this panel with Jayant and other experts. Great. We're starting a few minutes earlier, so hopefully that will help us. The panelists are Professor Mike van den Breggel from Amsterdam, Kishore Sandhu from Switzerland, and John Nash and Stuart Stati are vascular surgeons from Ninewells, UK, and Christopher MacDonald, maxillofacial consultant from Aberdeen, and last but not least, Jayant Kumar, ENT facial plastic surgeon from Chennai. What can you do for global humanity? The climate change is one of the biggest threats to the humanity globally. Flash floods, forest fire, so many things happening. And what you can do as a human being or as an individual, I will request all of you just Google and what you can do to improve global warming. That is the real treat for humanity. All I do is I do e-bikes. Last year I did my with my e-bike 5,000 miles, and my car did only 1,000 miles. So that is the simplest thing I do to improve global warming. Coming back to business, all the images are consented for teaching, should not be misused, and few images are really, really very disturbing. Okay. The outline of this talk is mainly dealing the anatomies and discussing mode of injuries and management with case experiences. And also it helps you to identify the complications related to neck trauma. Penetrating neck trauma incidence is up to 5% in traumatic injuries, most commonly caused by stab wound, gunshot wounds, and traffic accidents. The gunshot wounds are common in certain part of America, but the rest of the area, it's still a stab wound is the commonest. The mortality can go up to 6% in penetrating neck trauma, but please don't ignore the blunt neck trauma that can be very deceiving. It can be even caused by strangulations and assault in some of the countries. The classification of the zones in particularly the penetrating neck trauma, it's divided into 3. The zone 1 is in the bottom of the neck. It's below the cricoid, contains the carotid and vertebral artery and possibly the lung and thoracic structures. Zone 3 is on the top. It's above angle of the mandible, contains again carotid artery, particularly the cranial nerves 9 to 12. Zone 2 is in between, which contains carotids and still vagus nerves and recurrent laryngeal nerve. This is some guideline. It's not necessary that neck trauma which involves only one zone. It can be more than one zone. It depends upon how the knife travels or how the bullet travels. Okay. Technically speaking, zone 2 has got an easy access because it's in the middle of the neck. Zone 1 and 3 has got a challenging access because of the bony structures around it. Good. Let's go to the case. So 46-year-old patient presented with a trauma to the left side of the neck by a kitchen knife. Initially had a 200 mils of blood loss. Vital signs are stable, no active bleeding. Patient is fine, talking, conscious, and that's the clinical picture. So the question to the panelists, probably Professor Mike, what's your next step, Professor, if you see this kind of patient in the A&E?
Yeah, so is there an echo in my sound, or is it okay? Yeah, I think it's okay.
Yeah, it's fine.
So he has a stab in his neck, and you should be sure that there is what kind of vascular damage there is, even if it's not bleeding profoundly at the moment. So my step in this area of the neck would be to do an angiography. and see if we can see some damage to the arteries. An alternative could be to explore it, but I think angiography is to be preferred, CT angiography.
Right. Okay. So that's good. Once you done the CT angiography, if everything is okay, then do you take the patient to theater, or you just close it in the minor operation theater with some infiltration with a local anesthetic?
Well, I would always test the cranial nerves, of course, see if there is any nerval damage to repair. But if there is no nerve dysfunction and you don't see any damage to the vessels, I would just close it and give them antibiotics, and maybe even if it is a dirty wound, leave it open and let it heal secondarily instead of suturing it. It depends a bit on how dirty and how soon he's coming to the hospital. But then I would not explore it. No, I don't see a reason why to explore if there is no vascular or neural damage.
Okay, thanks. Coming back to the bottom questions, what the role of cervical collar? Probably you see these patients in A&E with a collar. What's your view about penetrating neck trauma with a cervical collar?
What do you mean with cervical collar? Something to support the neck?
Yeah.
Or
usually for the neck trauma patients, and the first A, B, C, D, and they put the cervical collar.
Okay, yeah. Well, I think the cervical collar is mainly, of course, for damage to the vertebral bodies to make sure that you stabilize that. If it is a car accident, like with a blunt trauma, but with a knife injury, I don't see what the cervical collar would have of a function. No.
Right. Okay. So that's I think that's absolutely fine. That's what I would do for these cases. And that patient underwent a CT angiogram, and the CT angiogram was fine, and the patient was taken to theater and gave a washout and closed without any deep exploration of the neck. So it was there was some muscle involved, but there is no other injury. So
and also the nerves were all intact. So I presume, yeah.
That's right. Mm-hmm. So always there is a debate whether to how do you deal this neck trauma patients. Okay, when coming to the advice is A, B, C, D, airway, breathing, circulation. But for a knife injury or penetrating neck trauma, many preventable deaths are due to excessive hemorrhage, which can be prevented by simple pressure. In that case, if you put a cervical spine immobilization, you may not be able to apply the pressure. So it generally, for a penetrating neck trauma, C-spine immobilization is not advocated. But exceptions are, if you think high index of spinal injury or unconscious patients, heavily intoxicated patient, or a patient is developing focal neurological deficit, you still need a C-spine immobilization. Let's move on to case 2. This is not my case. I got it from Google, and this is for discussion only. 46-year-old male patient had a kitchen knife again. Patient is talking, and vitals are stable, and the patient is in recess. Okay. These are the questions. I'm just checking. I can ask the people, the delegates, to launching the poll. What do they do? I'll check this for a moment. You can vote for what you think. The first questions are, would you advise to remove the knife in accident emergency? Yes or no? Would you advise to remove it by bedside or at home? Okay. And if the patient is alert or conscious, would you intubate in accident emergency straight away? Would you advise CT angio? Yes or no? This is very simple, straightforward, yes or no questions. I even put, I don't know as well. That's the socialism. So it's not necessary you need to know the answer for every time. Okay, so I think very good. People are voting. I'll give a couple of minutes, maybe some, not even minutes. Okay, we can share the screen. I'm just ending the poll, and we can share the results. Okay, this is what everyone has voted. I'm glad. I'll ask the other panelists their opinion. Like maybe I'll ask vascular surgeon, Professor John, Mr. John Nagy is here. What do you think? Do you advise the knife to be removed by the patient or relative or the doctor in A&E or at home or at the ambulance?
No.
No. Okay. Why not? It makes your job easier, isn't it?
You could have a vessel injury and a knife is a tamponade, and you take that knife out, you lose your tamponade, and then you've got some entertainment coming your way in an uncontrolled situation.
Right. Okay. So that's everyone is clear. I'm slightly disappointed. At the same time, it gives me enthusiasm to organize this type of teaching. So they said almost 24% of the delegates said I would remove that in A&E straight away. Yeah. So sorry, I think I'm wrong. Sorry. They said regarding the intubation, I wanted to ask. Jayant, do you think we should intubate in accident emergency when the patient is alert or conscious? And 68% of the delegates said no, we won't intubate, and only 24% they said we will intubate. What's the advantage of intubation in A&E with a knife in the neck?
Hello?
It's me, is it?
Yeah, I can hear you. Yeah.
Advantage is it's better to secure the airway, but the thing is, at least we should have a basic X-rays or something investigation. If the patient is in distress, then we need to intubate. Otherwise, I don't think it's necessary.
Right. Okay.
Initial investigation is required. Then after that, we can intubate. If there is no saturation or distress, then I don't intubate.
Okay, I see. That's interesting to hear. Chris, what's your opinion on that?
I think it's a difficult call on that one. I think it would depend on a couple of factors. I think what you don't want is this patient moving and flailing around. So if this is a patient who's very distressed, I think getting control of that and maybe intubating and sedating them might be appropriate in that setting. I think the patient needs to be intubated at some point because we're heading towards theatre. And I think that needs to be done in a safe and controlled environment. And I think it might depend on the anaesthetic support and the technical support that you've got in A&E compared to doing that in a theatre environment and how quickly you could move from A&E to theatre. So I think yes, this patient needs an airway secured, but the exact timing that needs to be fairly fast. But where that's done, I think would depend from institution to institution and the facilities in each area.
Right. Okay. So that's great. I think there's a difference of opinion even among the faculty. I respect that. In Tayside, we would intubate the patient if there is a knife in the neck. If the patient comes to A&E, the trauma call goes to ENT surgeon or maxillofacial surgeon, vascular surgeon, and anesthetist. So all the three of us will be kind of waiting for this sort of injuries. And as soon as the anesthetists get the opportunity, they intubate the patient because it keeps them calm and it prevents another collateral injuries. And they have the facility in A&E to keep them calm and sedated. That's great.
Maybe one comment, because you could intubate him in the OR with a flexible endoscope through the nose with some local anesthesia, so awake intubation. So like we do in big cancers also, where you cannot intubate through the mouth anymore. So then there is minimal movement of the neck and you can do it in a very controlled way. So that could be an alternative, I think.
That's great. So everyone agreed we need to do CT angiogram for this patient. Okay, so that's great. So the next question to the maybe Kishore, Sandhu, how would you manage this patient in theater? When you take the patient to the theater, there is a knife in the neck. What's your surgical approach?
So I think thanks for the question, Jay. It's wonderful to be here. So I would intubate this patient, and to start off with, we will typically do it with a flexible endoscope. The patient is breathing spontaneously. I think access and stabilizing and securing the airway is primordial. It is critical. The patient is in distress. He is going to move. We really don't know where this sort of injury is going. And I think it's really important to secure the airway, even if, while we are sort of going into the CT scan to do the CT angiography. So I think to answer the first question, yes, I would intubate. Once we are having the radiological investigations, we will be in the operating rooms. And then, of course, depending on the CT scan, I would take help of my vascular surgeon just in case to be on the safer side. Don't sort of, be ready for any kind of surprises. And then I would even sort of before I would remove this sort of, kitchen knife, I would actually expose, I would take an incision around, taking a horizontal incision so that, I have a larger access and I'd sort of, don't fiddle around into a smaller area. So I would, before I really remove this knife, I would have a large, big access into the neck. And then I would go ahead and remove this knife, get an access over, get a control over the vessels, and then, of course, look for other collateral damage.
Brilliant. That's I think that's a golden point. Even in theater, you don't remove the knife straight away and widen the incision around it, making sure you get the control of the vessels, then and proceed and safely. So the learning points are like, when do you take the patient to theater? Expanding hematoma, shock, air bubbling through the wound, profuse bleeding, stridor, and evolving stroke. These are all called hard signs. It's easy to make a decision to take the patient to theater. But there are soft signs like patients do have hemoptysis, dyspnea, sometimes subcutaneous air emphysema, non-expanding hematoma, and focal neurological deficit. The patients with the soft signs can be managed conservatively as well, but again, cautiously, and they need a constant monitoring. Basic investigations, chest X-ray, epilateral views, and CT angiogram is the basic point. When you explore the neck, you have something to be signposted. Do we have vascular injury, laryngeal injury, pharyngeal injury, and neurological injury? Because the neck has got all the four things. So keep that in mind while you are examining or also addressing the patient's neck. I would strongly advise to read this articles. It's evidence-based articles. It questions about mandatory surgical exploration in all the patients. And also, they put the weightage on CT angiography. If CT angiography is fine, you don't have to explore the neck extensively. That's old school teaching is, if any injury below the platysma, explore the neck. That's not the case in the current settings. Just algorithm, you have a neck injury patient after stabilization, think whether there's unstable patient with hard signs, then take the patient to the theater. If there is a stable patient, after spending enough time with the history and examination, chest X-ray, lateral view, and all these things, rule out vascular injuries and pharyngoesophageal injuries. And if there is asymptomatic patient, close monitoring for 48 hours. Okay. Let's move on to the case 3.
Can I make a comment here, Jay?
Yes, please.
So I think, if you have projectiles, if you have metallic fragments, of course, not a knife which is jutted into the neck. If you have metallic projectiles in the neck, then one needs to do an X-ray, because CT scans probably are going to give us a lot of artifacts. In a situation like this, probably the investigation of choice is going to be an arteriography, so as to actually know what exactly is happening. and that is going to be therapeutic as well as diagnostic. So one of the points is that if you have projectile fragments, metallic, which are embedded in the injury site, then it is the normal X-ray of the neck, which gives us the idea of what exactly is happening. And that will decide whether are we going to go in for a CT angio or an arteriography.
Brilliant.
Hi, Jay. Can you hear me?
Yep, we can.
This is Raj.
Yep.
So I was just going to come in with the same point, is that if there's a metallic density sitting in the neck, the CTE is required, but might give you a lot of streak artifact.
It's a good point for me as well. Thank you.
So before you go to theater, you would really like to know which vessels are involved, and doing a proper catheter angiogram in the interventional radiology theater before you explore would help to look at whether the knife has gone through the internal carotid or external carotid. A CT would also be helpful, just see the lie of the land.
Yeah.
But I think catheter angiogram, which, as Kishore said, that sometimes we can help dampen out the bleeding by putting a balloon up and helping your surgery as well.
Good. Excellent. So I think we are coming to this. This case will be useful. These comments are. So 56-year-old patient had a hand drill working 10 meter the height and had an injury. Nobody witnessed what happened, and brought by ambulance. Pulse and blood pressure was not recordable at that point of time, and trauma call has been set up, and so all we saw the patient is a 1.5 centimeter hole in the left side of the neck at level 3. When I saw the patient, there wasn't bleeding. Then after 5 minutes, there was a profuse bleeding started. Myself and the vascular surgeon, as well as anesthetist with the patient, actually, it was well before we were there in the A&E, we were waiting for the patient. The trauma team resuscitated the patient. The question we argued whether to send the patient to the angio or straight to the theater. John, what's your view? I wasn't arguing this case with you, with your colleague, actually.
Well, it depends on how profusely bleeding this patient is. I suppose if you've got exsanguinating hemorrhage, you are forced into taking this patient to theatre and getting some sort of control. If it's tolerable, safe, and resuscitatable, any imaging, if possible, will help your approach. But if you're in a situation where you've got someone who is going to, you lose potentially loss of output situation or exsanguination, you are forced into exploring that neck urgently and getting some proximal control.
Right. Okay. So that's the next question I'll ask that while you're dealing this one, actually. So this is, we took the patient straight to the theater, actually, because by the time the patient had 5 units of 5 bags of blood, the BP is stable, but again, you can see that from the hole, you can see it's not major injury at all. All you see is a 1.5 centimeter drill hole in the neck. And the patient was unconscious, but blood pressure, everything is stable after things. John, can you just describe what did you do in this case? Actually, maybe it might be useful for others.
Well, the first thing I would do is, apart from wide exposure, is to get control of the common carotid artery. And that's essential. And all steps of vascular surgery is obtaining control. And the first thing you do is get your proximal control. As you can see, I think I need to orientate myself on these pictures.
Yeah, the red one is the proximal carotid artery, and the blue one is the external carotid artery. This is a carotid bulb, what you can see. Yeah.
So you'll have to get control of all 3 vessels. Common, the most important, but you'd get some very profuse back bleeding from the external and the internal, or you'd hope. And you control these vessels, and that gives you a better view of how you might repair this trauma. And I think from the pictures did the guys shunt, did they?
Yep, that's right.
Yeah.
It's shunted, and saphenous vein was taken by a steward, I think, and they did a beautiful job and we ligate to the external carotid. And we also explored IJV. There was a mild trauma. We repaired IJV, and there was no cranial nerve injury. And that's how we sorted. We didn't do CT angio or catheter for this patient because we didn't have a time for this patient. So
in these situations, once you've got control, you can shunt immediately, and that's what I would do. That'll allow you some time to go and find some long saphenous vein to affect your repair. And I see that these are interposition vein graft. They must have excised a section of fairly sick or damaged common to internal carotid, and you can then put the reverse long saphenous vein over a shunt and then do the anastomoses. The external carotid artery can be ligated, as probably in this case.
So what is your advice if you don't have vascular surgeon, if the patient is being managed in small hospital? What's your thought process about damage control measures?
Well, I think if you're in a small hospital, you have to make it your job and purpose to learn some generic skills outside your specialty. Every surgeon with an FRCS should be able to obtain control of a major vessel, I would say in the neck. If you're in a situation where all you have is someone that can press and press only, I think in a fairly desperate situation. It's knowing what's available, knowing what's safe, knowing what vascular clamps you can use, and using them safely should be in the armory of all surgeons. And as ENT surgeons, and you are in the neck, you know the neck better than anybody else, an ability to dissect these structures out and at least put some safe carotid clamps on and wait for help.
Great. So
if no help is available in this situation and you've got someone who's going to bleed out, you can ligate, but ligating the internal carotid artery will have a significant stroke risk and mortality attached to that. But if you've got someone who's going to exsanguinate and die and nobody able to do anything about it, that's all you can do. If a vascular surgeon can come, then you clamp and you wait for them to arrive.
So brilliant. So the take-home message is clamp, pressure, or you can put a Foley's catheters or kind of tampon.
And to familiarize yourself with what vascular clamp you might use. And it's simple. It's called a carotid clamp.
Great, excellent. There is some debate about the investigations. I mean, the CT angiography is kind of readily available and minimally invasive. So what's the catheter angiography? When do you recommend these? Maybe Rajbat or Nash can answer this question.
Look at both. I think if you've got a stable patient and you've got an IR team that can do, and I think one of our cases where it was useful to have both an arteriogram, a catheter angiogram, and a venogram to delineate whether there was going to be any damage to these structures before you went and exposed. And if you can get a wire across, you can fix with a stent. But Raj knows all about this.
Right, he's giving a talk. Raj, comment.
Can you hear me? Can you see me?
Yeah, that's fine. You don't need to see you. It's fine.
Okay. Again, it depends on whether the patient is stable or unstable. Having an unstable patient usually requires a rush to theater to control things, obviously. If the patient is relatively stable, then a CT angiogram is always the first resort, even if there is a knife sticking out of the neck, I think, just to see what the actual lie of the land is. Like a quick CT angiogram and then a catheter angiogram to see what's happening. Especially in a blunt injury where the skin is not exposed and there's a hematoma, angiographic techniques and treatments are an alternative to surgical exploration. Sometimes can be more controlled. And these can be done based on what the anatomical location of the injury is on a CT angiogram. For example, if there's a blunt injury and there's external carotid laceration because of blunt injury and a hematoma, I would think that's better treated with an embolization and more controlled than open surgery, I think. But these are all multidisciplinary discussions. When it comes to bleeding in other parts of the body, mainly the abdomen and chest, where it happens more often, the IR team is always part of the part of the discussion. Less so in ENT because we are not thought of that very quickly, but it's something to keep in mind that there might be options.
Okay.
The second thing is even if you're doing a angiogram and trying to embolize, we would still want the patient anesthetized, because if somebody with a expanding hematoma in the neck or a knife coming out of the neck, only maybe John Rambo won't be distressed. Everybody else will be distressed. So yes, a distressed patient should be anesthetized, but everybody will be distressed by that situation.
Thank you. So the vascular injury, the management always involved a vascular surgeon and interventional radiologist, and signpost what kind of vessels are injured, IJV or common carotid or subclavian vertebral vessels. IJV, either ligate or repair with 6-oprolin is fine, or again common carotid repair or ligate. I mean, ideal is repair. That's what the recommendation. So let's move on to the case 4. So
Jay, can I make a comment here?
Yeah.
So I think one of the factors which is very critical is to the people who are on the site and who are seeing this patient for the first time. And as Raj very correctly mentioned, it really depends upon the site of involvement. So as we know from in the past, we have always sort of divided the neck into the zone 1, 2, and 3. So zone 2, that's fine. I mean, you have the carotid, you have the internal jugular vein. It can either be ligated or it can be sort of grafted, etc., etc. But the moment we are looking at the lower and the upper neck, the situations change, and the people who are actually on site, they should be told and informed that there's no point in pushing this patient to a small hospital. This patient needs to go where specialized care is available, because only those guys are going to ideally treat him, with an endovascular, embolization or coiling or something where, a lot of time is going to be lost. So I think the training of people who are on site to take the right decision and move the patient to the right hospital is very critical.
Brilliant. That's absolutely golden point. This is another case. It's a 46-year-old. The patient had a trauma to the knife and taken to the theater. A wound, hemostasis was done. Wound was closed. 5 days later, a patient developed massive oropharyngeal bleed and collapsed in the ward. The inference here was, it's basically when I took the patient back to the theater again, when I opened the neck, straight away I saw food material in the neck. So further examination of kind of after washout and everything, I saw the huge defect, which around 2 by 3 centimeter from the lateral lamina of the thyroid cartilage going into the piriform fossa. And there was a bleeding from the superior pole of the thyroid, which is where assumed it is a superior thyroid artery pedicle. So the question is, how do you identify esophageal injuries? Professor Mike Vandenbreck, what's your advice to avoid or miss esophageal injuries while dealing neck trauma? This was managed 5 days back. Then 5th day patient developed massive oropharyngeal bleed from the mouth.
Yeah, it's not always easy, of course. But if you see air, of course, deep on the CT scan, that could be a sign. So then during the exploration, you will really have to look for it. And then what we very often do is you can put some methylene blue or another dye during the surgery in the throat, and you can see if it appears in the neck, because that's a certain sign that there is a kind of fistula developing or a perforation. Yeah, in your case, when you've missed it, you find it secondarily, of course, well, you have to look for it. And then I would also use the dye. if I have difficulty finding it, because it's not always easy to find it in this, certainly in this neck with a lot of hematoma and infection. And then, well, the repair, of course, is another issue. Can you still suture it, or is there too much necrosis or infection to primarily close it? You might need a flap to put over it, a muscle flap or something. But that's up to during the surgery, I think. Yeah.
Brilliant. So I think it's as Professor said, it can be missed. So
yeah, it can be missed.
And the symptoms are what you can look out for: hemoptysis or hematemesis, odynophagia, surgical emphysema, prevertebral air leak. The management is just check whether it is a symptomatic or asymptomatic patient. If symptomatic patient, assume it is a perforation, and if there is a large one, you need to repair surgically. If it is a small perforation, you can manage them conservatively by keeping them nil by mouth, nasogastric feeding, parenteral nutrition, IV antibiotics. Contrast swallow is useful, but having said that, the recommendation is direct esophagoscopy and contrast swallow, which gives a sensitivity around 95%. If you do one, the sensitivity is low. So that's why some institutions always assume all neck trauma patients, there is a perforation, and they keep them nil by mouth and start kind of IV feeding, parenteral nutrition for next 5 to 7 days. Then they repeat the contrast swallow, then start oral feeding. So the tip is, if you want to rule out the neck injury, esophageal injuries, do the esophagoscopy before closing the neck, because it's hard to find when you close the neck. When you do the esophagoscopy, everything looks edematous or maybe some blood there. It's easy to miss, and there is esophageal injuries unless it is very big.
Yeah. Can I comment a little bit? Yeah, because yeah, to just observe it. I think it's certainly, if you have a suture line in your vessels, maybe the vascular surgeons can comment. I think you would like to have a clean neck. So I would be reluctant to, if I know there is an opening on the swallow X-ray, or I would tend to try to close it or put a muscle flap over it. Because you can never avoid, patients will always swallow saliva. They will always have pressure buildup in the pharynx. Yeah, I would be reluctant to just wait, but yeah, I have no experience in waiting. Maybe that's my comment. Yeah. So if there is a perforation, I would explore it. Yeah.
Yeah, I totally agree. Esophageal perforation has got a high mortality rate even in this antibiotic era. I totally agree. Particularly for unstable patients with other comorbidities, and the risk is higher because of mediastinitis or systemic inflammation syndromes or all. This is another dagger injury, which is brought by ambulance, and the vitals are stable. As you can see, the patient is intubated in A&E, and and we did a CT and other things. You can see the dagger is going through the thorax and superior mediastinum. So this one had a catheter angiography in theater. Patient was stable, and luckily there was no injury to the mediastinal vessels as far as what we can see. And the question was here, how do we deal? Because the tip goes into the thorax. So the patient had actually lateral thoracotomy. It's not easy to do lateral thoracotomy unless you have a specialist center, which has a specialist anesthetist who can do one lung ventilation and collapsing the lung. And they need to approach the lateral, the superior mediastinum. So the idea is, the tip is, if you remove it from the neck, what happens if there is a bleeding in the thorax? That's why we opened the neck as well as the thorax simultaneously, got the control of the tip. And again, vascular surgeon's role was very helpful, including the maxillofacial Doug was with me as well. So sometimes it's worth having more than one surgeon because end of the day, patient is important. You can have enough surgical experience, but still in emergency situations, it could be rare. So it's always better to get more help. There's no harm in it. this slide, I wanted to put it, yes, you can repair a beautiful jobs and everything. Don't forget the underlying cause. It could be high suicidal risk. So they still have a further risk of committing the same mistakes. So unless you correct it on the underlying problems, for example, involving the psychiatrist, and that's not going to get better. And so even in the weekends, we have to sort this out. Okay. So this is my kind of last case. Move on to there's two more cases, and I just want to briefly mention about don't get fooled by this clothesline injuries. There's no neck trauma apart from there's some bruise around it, but these are the worst injuries. And what we are talking about is a published case report is cricotracheal transection. I think Kishore Sandhu is going to give a talk and later as well. So these cases. Think about the cartilages involved, thyroid, trachea, and cricoid. So if there is a thyroid cartilage, if it is non-displaced fractured, supportive measures, and displaced ones used open reduction, many wires. And for the tracheal ones, it's simple one, end-to-end anastomosis. If it is small tear, it doesn't need much input. The cricoid one is a complex one to manage. Most of them end up with a tracheostomy as well. So this classification is quite useful. Shaffer's classification for laryngotracheal injury, which is like a kind of green, orange, and red. The 5 is laryngotracheal separations. It means airway is imminent danger. You need to open the neck, probably get hold of the distal trachea. Through that, you can intubate, put the endotracheal tube. The 1 and 2 could be managed conservatively because it's all about edema and hematoma, no fractures. So flexible fiber optic endoscopy, steroids and antibiotics and anti-reflex medication, and also make them in the HTU or intensive care unit or serial observations is necessary. 3 and 4, it's a bit of more edema, more mucosal tear, and also cartilage is displaced. This again end up in the tracheostomy, more likely surgical repair. Some of them needing stent, so that's the rough algorithm for laryngotracheal injuries. Cricotracheal separation is a form of blunt neck trauma, and it has to be diagnosed very quickly in few hours surgery. And the case report which I showed is patient presented 48 hours later after a clothesline injury. And that was the CT scan picture. It was almost partial separation. There are full separation, partial separation. Full separation is deadly. They die at the scene. And partial separation is 2/3 is the most common. So it's often present kind of very delayed manner. Even A&E, it's get missed. So the CT, fiber optic intubation, surgical repair, so are all useful. Tracheal repair is not a complex one, to be honest. In most of the cases, you can use a vicryl or monocryl with interrupted sutures, and sometimes you may release the hyoid to get extra length, remove the dirty things. Just use multiple kind of anchoring sutures to bring it together, and so that's more than enough to look after the trachea. The controversies are always there. C-spine we discussed, mandatory surgical exploration or not. I think more and more we are relying on CT angio. And this is, I just wanted to highlight this, sports injuries and the management, for example. What they are doing is just a simple job, lifting a man in a stretcher. It is not a complex job, but you can see things can go wrong very commonly. Even for a simple job, when you do it means basically what you are doing, what job you are doing, and who is doing the job, and where they are doing, that matters. So it needs a kind of coordination and some practice all the time, and able to work under pressure. I think that's my slide. And Jayant, do you want to me to proceed, or do you with advancing the slides, or do you want to share screen?
I would like to share screen, please.
Yeah, you can share it. Okay. It's great. We can see the screen. Yeah.
Coming to the mandible fractures. So classification, there are various classifications in mandible fractures are there, but I like this anatomical classification, which is commonly followed. And the most common fractures are condyle fractures. Next is angle and the body. So these are the common fractures, and mandible fractures can be unilateral or bilateral. So let's come to what will be the goal of a surgeon in the management of facial fractures. Jay?
I think I'll leave the question to Chris. He's the maxillofacial surgeon. Yeah. I don't do this one, unfortunately.
I think my primary outcome measure I'm interested in is the occlusion, and I think everything follows on from that. We want a good occlusion, and if that goes along with a good bony reduction, all the better. But if the bony reduction is not perfect, I'll settle for that if the occlusion is good. And if we get those bits right, then the facial profile should follow and should be nice as well. We want bone stability, and I'm sure we can talk about rigid versus non-rigid later, but we want a fracture that's going to be in a position to heal. And aesthetically, we want to do this and get access to this in a way that doesn't leave the patient with extra scars or extra nerve damage or problems. So they're the main things on my hit list.
Yes. So restoration of facial aesthetic is the first primary goal of any treatment in facial trauma. That is in height, width, and projection. As Christopher rightly said that. So this is the primary aim of any facial trauma surgeon. So coming to the case, this is a young lady presented with facial trauma. On intraoral examination, this is a intraoral picture. This is the finding. Chris, what is your important finding in this?
So from just focusing intraorally, I think as we are, then it looked like that patient had a step in the occlusion. It looked to be in the right parasymphysis and the left body region of the mandibles. I think this patient has a displaced mandibular fracture.
Absolutely. So it's a displaced anterior segment of mandible, that is parasymphysis, and the from para to body of the mandible, the other side. So what will be the, will there be any airway compromise in this patient at all? And
so I'll jump in on that. Yeah, I wouldn't expect there to be any airway compromise. Airway compromise and mandible fracture, I'm sure we're about to talk about in a bit more detail. Certainly can happen, but it is quite rare.
Okay. So if there is an airway compromise, then why does all the mandible fracture cause any airway compromise? Or how do you manage immediately and pre-operatively the airway?
Did you want me to comment on that?
Yes, please.
So I think if that patient had an airway compromise, I would approach them in the same way as any patient, but keep in mind the mandible fracture as well. So the first things I'd be thinking about, do they have a decreased GCS because of a head injury? Are they obtunded with drugs or alcohol? Do they have bloods or foreign bodies in the oral cavity that need suction to clear the oral cavity and pharynx? Do they have swelling? Do they have expanding hematoma on the floor of mouth? Are there other fractures and other problems? And I'd run through all of those things, but keep in mind at the end of that it could be that the mandible fracture is at least contributing or causing an airway compromise because of the lack of support of the muscles that allow tongue protrusion and causing the tongue to fall back. But I think I would approach this the same way as any patient with airway compromise.
Okay. And does all the mandible fracture cause airway compromise? Is it a unilateral or bilateral?
So,
yeah.
I think airway compromise and mandible fractures is fairly unusual. And I think when you do see it, there's often more than one cause rather than just the mandible fracture. But yes, anterior mandibular fractures where the parasymphysis has fallen back can certainly cause it. You lose the suprahyoid and the genioglossus muscles, and the patients can lose that ability to protrude the tongue, and the tongue falls back into the oropharynx. How would we manage that? I think you mentioned there. As I said, I would approach this in my normal airway assessment, looking, suctioning, cleaning, simple airway maneuvers. And if I'd worked through all of that and I still had a problem that I thought was related to the displacement of the mandible fracture, then it would depend how acute that was. If we really needed to do something quickly and get the tongue forward, then you could do that with some local anesthetic and a tongue stitch in the acute situation. If we need to do things that are going to last a little bit longer, we could try and reduce and stabilize the mandible fracture with some wiring.
Absolutely. So not all the mandible fractures cause the airway compromise, just an anterior ones. And it is not just a muscle support, but it also depends upon the edema and other factors, and it's not very common. And the immediate measures, if there is an airway compromise, you can use a interdental wiring at the fracture site for stabilizing the fracture, and the airway. If the airway is compromised, you can think of nasotracheal or orotracheal or tracheostomy in certain cases. So the next question is the role of different imaging, and when and what specification do you request? Mr. Christopher?
So it depends on the clinical situation and the pattern of injury that I think we're looking for here. Most patients that I come across with mandible fractures often have that as an isolated injury. And if they have a mechanism of injury that doesn't worry me overly and they're coming in talking, then simple x-rays, usually an OPG and a PA mandible, are enough to make the diagnosis and to guide the treatment. If we have very comminuted fractures, or if the patient has a fracture of a mandibular condyle that I'm planning to operate on, then I've got a low threshold for some cross-sectional imaging, either a cone beam CT of the mandible or a regular CT of the mandible that can give us some 3D reconstructions and help guide and plan our surgery. But that would be my standard approach to the mandible.
Okay. Do you do X-rays commonly, and you don't go for a CT scan at all?
So with it depends on how the patient presents. With simple trauma, most of the patients we see with mandible fractures are interpersonal violence. They've been in a fight, somebody's punched them in the face, and have very few other injuries. And if I'm not worried about the midface, and this is an isolated mandible fracture, I'm happy with an OPG and a PA mandible. We certainly get patients that come through with worrying mechanism of injury, and they would tend to come through our trauma team here, and they have a very low threshold for doing a trauma CT. And by the time we get there, these patients will tend to have a full body CT already.
Sure. Yes, the CT facial bone with 3D reconstruction is a gold standard, and other, as you said, X-rays, X-ray OBG and Waters view and other mandibular views are quite useful, and MRI for orbital injury is quite useful. When do you do the imaging? It is for this, it's usually after stabilization, that is after primary survey. And what specification is usually 2 to 3 mm slice thickness. For orbital, it is 1 mm. From axial above, from frontal down below to the mandible. It is taken in 3 planes and with the reconstruction, that is it's quite useful. So as you know, YCT, it's very useful for pre-surgical planning for simple and complex fractures. And disadvantage of CT is can miss dentoalveolar fractures. Do you agree with that?
Absolutely.
Yeah. So the radiological finding of this patient is axial, as you rightly said, that it's a right paramedian and left body. Can see that this is an coronal view, and this is a 3D reconstruction, which is basically it's very useful for explaining to the patient rather than this. So what will be the management plan for this patient? Do you do conservative management or go for a surgical management?
I think this patient is going to require surgical management. I think conservative management with 2 displaced fractures is very unlikely to be the best way forward. We have good access to theatres usually, and I would aim to get this patient to theatre for open reduction and internal fixation of these fractures, ideally within 24 hours.
Excellent. So it is surgery, open reduction and internal fixation. Another question, do you do immediately, or if there is an edema, you wait for it?
I would get this patient through theatre as soon as I could. So yeah, I would do it the same day. Often it ends up being the next day. The only facial fractures that I would delay would be zygoma fractures and orbital trauma, and then I would tend to wait the week. And the same is true for panfacial. If we had a patient with a mandible fracture and significant mid-face trauma, then I'm more likely to do the mandible acutely and take the patient back to theatre a week or 10 days later to do the mid-face.
Excellent. So what are the 4 basic things we need to consider while planning for this patient? Already you have mentioned few things. So what are when you plan for this, what are the 4 basic things we need to consider?
There's lots we could talk about this, I suppose. I think in the first instance, heading towards theatre, are you meaning kind of intraoperatively?
Yeah, when you plan for a surgery, what are the things we need to consider things like during the surgery?
So first of all, I'm thinking in surgery, obviously I need to have the right team and the right equipment available. So I'll have a pre-team meeting. I'll look at the equipment that I'm planning to use. I'll have a chat with my anaesthetist about the airway that we're going to use on this. And our standard approach for an isolated mandible fracture would be a nasal intubation. So we can get this patient into occlusion intraoperatively. Beyond that, I'm not sure where we're going.
In case if it is there is a mid-face fracture, as in this case, you prefer nasal, any other airways?
So yeah, so it depends. So this patient had a left-sided zygoma fracture, but the right side looked okay. So I would be happy if we were operating on the zygoma at the same time. I would be happy with a nasal tube down the other side in this case. But if it was a panfacial fracture where we had to operate on the mandible and do significant work on the midface, then a submental intubation would be how I would go forward.
Okay, that's great. So apart from that, which you have mentioned, the 4 things, which is occlusion, that is whether there is a altered occlusion is there or not, and what type of occlusion it is. It is a class 1 or class 2 or class 3 occlusion, so that to give a post surgery good occlusion, patient occlusion. And the second thing during the surgery, which I feel that it is maxillomandibular fixation, and what technique which will be better, that is usually arch bar. Do you use arch bar or any other techniques which you use apart from that, which you prefer?
So I use it not particularly frequently out with the setting of condyle fractures. I think in this case, I would certainly consent my patient that I might use arch bars, and they certainly can be very useful intraoperatively to get the patient into a good occlusion. But if at the end of fixation, plate fixation, I was happy with the occlusion, I wouldn't leave this patient in arch bars. I'd be happy to take them off. But yes, Eric's arch bars would be what I would use if I felt I needed to.
So options are arch bars, eyelets, IV loops, intermaxillary fixations. These are the options which we need to consider. And osteosynthesis.
It's good.
We all know.
Yeah, we have 4 minutes. One more patient to discuss.
Yeah. So this is osteosynthesis. It's an ideal line of osteosynthesis is described by Champy. That is lower arch and the front portion, the lower inferior border, which we should consider. And intraoperative, as already discussed, it's a nasotracheal intubation, submental intubation, and tracheostomy. It's intraoperative, postoperative follow-up. Thank you.
Thank you. Prof, do you want to share your screen for the last case?
Yeah, I will share my screen. 1 second. 1 second.
Yeah.
Desktop. I don't know why.
I can do that.
If you can share, then I would be happy.
I can do that. Yeah, that's fine.
Somehow.
It's all right.
Did you put it in or should I? Yeah.
That's your case?
Okay. Yeah. So a case that is probably, at least, yeah, I work in a cancer clinic, so this is for me more common. So this is a woman who was with a big, you can see here the oropharyngeal tumor with a green line in it. So it's a big one. And so it was staged as a T4 N2C base of tongue cancer. And in these cases, of course, they have quite a poor prognosis. You see quite extensive tumor. They are certainly not amendable for surgery. And she was treated with chemoradiation. And maybe you can give the next slide. And this is after the chemoradiation. She had problems with the chemotherapy. She got renal problems and in need of dialysis, which is in fact quite rare, but it happened to her. And this is the situation after the chemoradiation. So when you look in the throat, you can see on the right side this ulcer, and then you always have this problem in these ulcers. Is it tumor or is it just a radiotherapy ulcer? So maybe I can ask the panelists first a question about how would you go ahead with these kind of things? Would you go in to take a biopsy, or would you just wait or do a PET scan? I don't know who has an opinion.
It's what you describe as a advanced tumor, and I'm not really sure whether it's a HPV positive or negative. It is likely HPV negative. So HPV you generally have a good prognosis. HPV negatives, as there is a high chance for recurrence. And I would try and prove it histologically, because the management is either it could be conservative or maybe some cases immunotherapy. In that case, a PD-L1, sometimes our pathologist will ask for it. So I would consider a biopsy again to prove it. PET scan again is important. It tells me whether there is any recurrence in that area, or at the same time where there is any distal metastasis as well. So I would prefer both.
Yeah, that's what we do at the moment also, more and more, to make PET scans in these cases. And also, indeed, if there is any doubt, take a biopsy. It depends a little bit on how it looks. But I think you're right to have confirmation. Maybe in the HPV positive, we wait a little bit longer, because sometimes you can see later responses. But anyhow, keep them under very strict surveillance. Yeah, can you show the next slide? Then in this case, there was no biopsy taken because it looked apparently just like an ulcer. And a few months later, she started she came into the clinic with a bleeding from the throat. And it was not a very heavy bleeding, but she had a mouthful of blood. And then there is always the issue. This can be prodromal bleeding because it was a deep ulcer still in the throat, also on the MRI. So we admitted her, and she still had a trach after the chemoradiation, because she had problems during the chemoradiation. And she was using anticoagulant therapy because of her previous issue. I think she had a lung pulmonary embolism in the past. And then there is always, I think it's good to do a CT angiography if somebody comes in with this bleeding, because it can be a prodromal bleeding. Is there some other suggestions from the panel, what to do in these cases?
I totally agree. CT angiography, that's what we do regularly. And I don't understand what is this acinocameral stop. Is that?
So she was using anticoagulant therapy for another reason, of course. And we decided to stop that because when she came in with the bleeding. Yeah.
Right.
Yeah.
That's fine. I think that's what we do actually. Yeah.
Okay. Next slide.
I think the only other thing I would add to that is I'd consider giving this patient tranexamic acid in addition to that, and potentially even actively reversing if they were on a Coumarins, thinking about giving them clotting factors to make sure that they weren't anticoagulated at all.
Yeah. Exactly. Yeah. Yeah. And in fact, in this stage, you really need to have a biopsy, because the further management, of course, depends also a lot on if it is tumor or if it's just a radiotherapy ulcer, I think. Although the acute management might be the same, but the discussion with the patient, of course, it's very different. Okay. Next slide.
Can I, Prof, can I come in for a second?
Yeah.
Raj again from radiology. Yeah, CT angiogram is helpful, but if it's done in a major hospital, they will do the right sequences. Sometimes if it's done in a smaller hospital, I think it's important that a triple phase CT is done, which is more sensitive to diagnose subtle bleeds from various areas. So the triple phase CT includes the CT angiogram, but has a pre and a slightly delayed phase, which will diagnose slightly subtle, smaller bleeds.
Okay, and the 3 phases needed to find the venous bleeding, or why?
No, a venous bleed never ever causes a problem. It's just a slow arterial bleed, which is very subtle, from a small branch, or from a tumor, which is small and a very small ooze, which is usually arterial, but slow arterial rather than a spurt. What you find in a CT angiogram is something that what you see in surgery, which is jetting out at your face, but something which is slowly oozing out from an artery on a small branch. You're more likely to find it on a triple phase.
Okay. And what exactly technically do you do in the triple phase? Because
you do pre-contrast scan, then do an arterial phase scan, which is what you call a CT angiogram, and then you do a slightly delayed phase, which is a venous phase. So you do 3 phases of CT.
Okay. Okay. Thank you. So now this patient, there was no bleeding found on the first CT angiography, but it was seen that the vessel, there was an injury to the vessel. So, and in the evening, but no action was taken on the first CT angiography in this patient, which may be doubtful you can discuss that if the radiologist to do embolization or anything. But in the night she had another bleeding, and so the options were to either explore the neck and put in the flap, and maybe ligate the vessels, or do an embolization. So maybe next slide. So this is the angiography, and probably other people know more about looking at this than me. I think this was the face. So you see the internal carotid looks maybe a little bit narrowed, but it was a, I don't really see, I must say, where the bleeding was. At least here you see the coil, of course, after the embolization, but apparently they found probably this is the maxillary, internal maxillary artery that was found to be bleeding. It could also be the ascending pharyngeal artery, but the radiologist was able to coil this vessel. And well, yeah, the question, of course, always is in these patients, do you explore these necks, or do you just coil the vessel? So I would like to have the opinion of the panelists.
I think the first instance I would ask for interventional radiologists to help. We had one similar patient. I think they did a good job. I think ligation of the vessels is going to be the last resort in my book, actually.
Yeah.
If the coiling has been successful, I don't think an exploration after that is necessary. So it needs to be a multidisciplinary discussion before the start of it, whether surgical exploration or embolization first. Surgery is always a sort of a backup option in these kind of cases.
Yeah.
So
if you would have found an injury of the internal carotids, what would be your policy?
Well, we would have seen that on CT, hopefully, unless there's a nice knife sticking out of the neck, which becomes difficult with streak artifact. So we'll have seen that before, and we'll have made the decision whether we're going to sacrifice the internal carotid or not. And then the option is a surgical reconstruction of the internal carotid versus tie off surgically versus embolization versus a stent graft. So these are the four options.
Yeah.
So you decide whether it's in a place where, as a team, you decide whether it's in a place where you can sacrifice it, or it has to be sacrificed because it's in a place where you can't really save it. In which case you can have surgical or endovascular, embolization or surgical tie-off, or you decide whether it can be saved. In which case you have a decision based on anatomy of a surgical repair, which was shown in one of the previous cases, versus endovascular stent graft.
Yeah, yeah.
A surgical option is always better if you can. It's got more long-term durability, but sometimes endovascular is fine.
Yeah, but I must say the surgical options in these cases after chemoradiation with these tumors, they are not very favorable. So yeah, in principle, we try not to enter the neck in these cases surgically because it's very much fibrous, nothing heals anymore.
Yeah.
So in our case, if we see an injury to the internal carotids, we try to stent it. Yeah.
Yeah. That's in a scarred neck. Yeah, the stenting to try and save the internal carotid would be the first option, to be honest. Yeah.
Can I just make a comment? Can I just make a comment?
Yeah.
So I would reserve a surgery in cases where you have an ulcer where the oral cavity is communicating with the neck. So one aspect is the vascular issue, which can be treated endovascularly. And then the other aspect is a direct communication of the oral cavity with the neck. So that I would completely block with avascular flap. Typically, a pectoralis major muscle works fantastically in these cases. And this is the way we are trying to keep the area of infection going into the neck and then creating more and more of problems. So I think the role of surgery is not completely zero. There are cases, especially in cases like these, where this is going to be a kind of a separation between a so-called infective area and the neck, and that will also take care of the vessel.
If I can come in, so we have very little experience, but I think covered stent is the way to go because you're looking at a 6 or 7 hour operation if you're going to try to reconstruct this through a radiotherapy neck. But the removal of an infected source, if you have a covered stent to stop the patient from bleeding, we see this often in aortas and iliacs and whatnot. If you have an enteric source, if the graft is in contact with that enteric source, in our practice, that infection you can never fully suppress that infection. You temporize the problem, you do not have a long-term outcome. If you can separate your stent graft from an infective source, in our cases, most often enteric or bowel, you have a strong chance of a long-term suppression and prognosis for this patient.
Yeah.
And that's pretty critical.
Yeah, I agree, John, completely agree. That's critical. If there is a communication with esophagus or pharynx to these things, they need, once the stent is done, they need to be cleared and washed out and all that. But the second thing, if it's a closed source without any communication with the upper GI tract, I think what the things that need to be remembered are that a straightforward stenting is easy, but what need to be considered is the factors for carotid stenting, which include heparin, enoxaparin, and starting dual antiplatelets very quickly, because the stent grafts in these areas tend to form clots very quickly, and you have a stroke, and you have no bleeding but a patient with a massive stroke. So that needs to be considered, and it's better done when patient in areas where in hospitals where stents of the carotids are done normally.
Yeah. And would it make a difference for you if the patient still had tumor, or would you still have, because that's also an issue. Recently, we had a very similar bleeding after a nasopharyngeal cancer. So there was clearly a connection to the internal carotid artery in this patient in the nasopharynx. So it's not really accessible for surgery because it's very high near the skull base. And you can also not put a flap in there. So
no, it's not. It's what you're trying to do is save the life immediately. You know that the patient's palliative.
Mm-hmm.
So it's the same whether it's trauma or tumor. You can stent across it. You have to remember stroke. You have to remember in tumors, obviously, that the patient understands that this is not going to cure.
Yeah, exactly.
Or her.
I think we are well over into the coffee time.
Okay, next slide. See how it ends with this patient. Well, this was, these are the coils. Maybe you can see them that they use. And this is the stents. We mainly use for the common carotid or the internal carotid. So, and if we block the internal, of course, yeah, you have first these balloon occlusions with EEG monitoring to see if it's possible, if you have time to do all these things at least. And next slide. This patient, she proved to have recurrent tumor, and after this coiling of the external carotid branch, there was no more bleeding, and she unfortunately died of her tumor, of course. Yeah. Okay.
Brilliant. Thank you very much indeed. I think it's thank you very much for all the panelists. I have answered all the questions by live as well as by texting back. I personally thank all the panelists, and we'll have a short 5 minutes break, and during the break I'll play 1 or 2 sponsors video. It's worth watching them, and we after that we have a talk from Professor Kishore Sandhu, particularly laryngotracheal injuries. You can all have a 5 minutes break, please. Thank you.
Thank you, Jay.
Thank you.
Thank you.
Hi there, hope you're having a good meeting. Just to introduce myself, my name's Ben Pattinson from Karl Storz Endoscopy. Today I'd like to show you a new product which we've recently launched called the Telepac Plus. As you would expect, the new model has various improvements and new features. The first of those new improvements, which is a fully HD flexible video nasolaryngoscope. That flexible video scope will connect straight to Telepac Plus and will enable you to perform a routine nase endoscopy, as well as stroboscopy, and as well as enhanced imaging techniques using our S technologies and specifically Spectra modes. The Spectra modes are very similar to what is available from our competitors, namely iScan and narrowband imaging. The system will also connect to a lower cost video flexible nase endoscope, which is cost-wise very similar to a fibre optic scope. However, the features mentioned before are not available on that particular scope. And if needs be, there is a single-use endoscope which also connects to the system. The system will also attach to a standard camera head, which will facilitate connection to your existing flexible fibre optic scopes and rigid endoscopes that you already have in the clinic. The system is now utilising a touchscreen, so all of these icons for recording still images and controlling the light source can be touched from the screen. One of the other main enhancements or new features to the system is around the patient data recording system of the still images and the video files. This can still be stored internally, but in an encrypted format, and can be transferred now to encrypted USB sticks. The new system has been designed with networking in mind to connect to the hospital's electronic patient record or a simple FTP server where the data can be stored. The preference being a connection to the electronic patient record, obviously, and this is very easily achieved via something we call Sonara, and we have dedicated network integration specialists to help you with that, as every hospital, it would appear, is slightly different. I hope you found this video interesting. It's certainly been a new experience for me. If you do have any questions, then there are some QR codes to follow, which you can use to contact me directly via email or phone, or via Zoom and Teams.
That's great. Welcome back. We play Fisher Sanders' recorded talk. He's here to answer the questions. We can answer these questions in a live manner or typing it. Thank you.
Thank you very much to the organizers of this wonderful conference, which is focused on head and neck emergencies. I'm going to talk on laryngotracheal trauma, and the etiologies for this kind of injury are basically of two types. Those which would have an internal trauma related to an intubation or a tracheotomy or post-endoscopies. This kind of an injury I'm not going to cover today. And what I'm going to cover today are the external trauma etiologies, typically related to blunt injury, penetrating injury, inhalational injury, and caustic ingestion. Regarding the external laryngeal trauma, the most important etiology are motor vehicle accidents. And then you have assault or suicide attempts, occupational accidents, as in contact sports, industrial injuries, and in armed combats that we see today. And in these kind of injuries, you, apart from having a blunt or penetrating trauma, you also have a thermal damage to the tissues. That would mean that the management of these patients is extremely, extremely complex and difficult. Here is an example of a penetrating trauma with an anterior cervical wound, CT scan showing cervical emphysema. However, we did not have any cartilage fractures in this patient. This is a patient following a hockey puck impact onto the anterior part of the neck. The CT scan was normal, but whenever you have these suspect air pockets, think that something is happening in the laryngeal cartilages, and he, in fact, did have a cartilage fracture. 40% of blunt injury patients would die. 15 or 20% of penetrating injury would die. But in those patients in whom the thoracic trachea is involved, the percentage of the patients dying is much more elevated. And the reasons for death are basically immediate crush asphyxia, a vascular injury, laryngeal concussion, laryngeal spasm following to a cardiorespiratory arrest. And if we have to talk about prevention, with the modern automobile designs, we are much more protected with airbags and seat belts. The improved body armor in a war-like situation, but in these kind of armor suits, the neck unfortunately still remains open and exposed to a trauma. Normally, these kind of injuries are rare, and the larynx and the trachea are very well protected. So the normal reflex response to an impending anterior trauma is to put the mandible down, and that itself actually protects the airway. It protects the larynx, the trachea, and of course you have the additional muscles which give the same kind of protection are basically on the lateral side, the sternocleidomastoid muscle, the prelaryngeal muscles, and posteriorly, the posterior back neck muscles would protect the larynx and the trachea. However, in certain situations, like in a deceleration kind of effect, you will have the anterior part of the neck exposed, and that causes crushing of the larynx and the trachea onto the driving wheel. And if we have to see the mechanism of action, have a look at this particular diagram. So here we are seeing the anterior force, which in turn can cause crushing of the cartilages, leading to a median or a paramedian cartilage fracture. And because of a recoil of the elastic cartilages, that can cause pharyngeal lacerations. And this springing back effect of the larynx can also lead to a disruption of the anterior commissure, which in turn can lead to a arytenoid dislocation and vocal cord disinsertion at the anterior commissure. Here we see comminuted fracture of the hyoid bone, the thyroid cartilage, and the cricoid cartilage. And here, in fact, it's pretty interesting to see that the thyroid cartilage has a horizontal fracture, which is quite a rare kind of an event on the thyroid cartilages. If we have to now see what is the effect of these injuries on the larynx itself, here, in fact, we see a situation where the hyoid bone, the thyrohyoid membrane, and the petiole of the epiglottis have been traumatized, and the possible sequelae in these patients would be a supraglottic stenosis. Here we see the anterior commissure being disrupted, petiole of the epiglottis being displaced posteriorly, and the anterior commissure uprooted from its insertion. This patient would probably have a supraglottoglottic stenosis. And here, in fact, we see the injury is going through the cricoid cartilage, and this would land up with a sequential subglottic stenosis. Regarding the physical signs, we see patients with cutaneous bruises, lacerations, cervical edema, hematoma, subcutaneous emphysema on palpation. The thyroid notch could be flattened, and there could be false thyroid cartilage mobility. Let's try and see each structure and how trauma can affect it. Talking of the hyoid bone itself, it's a rare injury, often combined with thyroid cartilage fractures. It is very commonly seen in strangulations or a hanging episode. And in these patients, there would be pharyngeal tears. Let's look at the thyroid cartilage trauma, but without a fracture. And when we do a laryngoscopy, we would see hematomas, edema, and there could be an associated pharyngeal tear. When the thyroid cartilage trauma has a cartilage fracture, in these cases, the typical situation that we see is that external perichondrium may or may not be intact, and the internal perichondrium is breached, which in turn leads to mucosal tears. Fracture fragments could be exposed. There is hematoma. And of course, we will see a CT scan showing a cartilage fracture. Here is what we see in an arytenoid luxation. So you have the arytenoid cartilage sitting on the cricoid cartilage being pulled in front, can be seen very nicely here on a CT scan. And this is the endoscopic image of an anteriorly and medially displaced right arytenoid cartilage. This is the extreme form of injury where we have a cricotracheal separation. This separation can happen because of a direct cricoid trauma, or there could be a severe intrathoracic trauma or a external thoracic trauma, compression against a closed glottis, and this in turn leads to disruption of intercartilaginous tracheal membranes, leading to tracheal separation itself. Both these kinds of injury can lead to a uni or a bilateral recurrent laryngeal nerve lesion and an associated pharyngoesophageal injury. And then you have a very, very severe form of pharyngo-laryngo-tracheal injury in a severe cut throat kind of a situation. Here, the young individual had a bilateral recurrent laryngeal transection, laryngotracheal separation, and a severe aerodigestive tissue loss. This is a patient who was actually, the doctors contacted me for this 7-day-old neonate from Belgium. They sent me this video. And in fact, what you can see here is the trachea. You're seeing the flexible endoscopic pictures. Remember, this child had a prolonged, unfortunately, the mother had a prolonged labor and rough manipulation at birth. And again, we go back to the endoscopy, and in fact, we see that this is the normal trachea. Probably this is the pseudo trachea or a pseudo airway. And if we look at the CT scans with reconstructions, we can see that unfortunately, because of the rough manipulation at birth, the child unfortunately had a tracheal separation. Regarding the management, of course, the most important step is to secure the airway. We do an endoscopy for diagnostic reasons. You want to see what the injury is to the larynx, to the trachea, the pharynx, the esophagus. We would do radiological investigations, CT scans, Dopplers, angio-CT, and then, of course, treat these patients accordingly. The first problem or the first question that comes to our mind is, if we have to do a tracheotomy, how should we do it? Should we do it under local anesthesia or general anesthesia? To me, it has to be tailored, and the decision will really depend upon the individual case. One needs to have an expertise and equipment of the endoscopy. And what we want to know is the information above, at, and below the glottis. Because if you already have a cricotracheal or a tracheo-tracheal separation, then one needs to be very, very clear where one wants to put in the tracheostomy, especially in an airway, which could be quite critical in these situations. Regarding the endoscopy, one needs to go ahead with a flexible endoscopy to know the dynamics of the airway, rigid endoscopy to look at the larynx, the trachea. A flexible esophagoscope or a rigid esophagoscope is necessary to look at the pharynx and the esophagus. Remember that missed digestive tears will have dramatic consequences. Flexible endoscope is difficult to pick up pharyngeal tears, and this is where a rigid endoscope is extremely critical. And then you have to secure the airway. If we are not aware of the airway instability, it is much more better to keep the patient spontaneously breathing, as can be seen here. The intubation is carried out with a flexible bronchoscope, and one could think of an awake intubation, but the objective being that we are not having the entire information of the airway. We do not know whether the airway is secure and is stable, and that's the reason why you want to keep the patient breathing spontaneously. As against, if you already know of a compromising pathology in the airway, one needs to go in with a rigid bronchoscope, because a rigid endoscope is going to give you a better control over the security over the airway, and the access and securing the airway is going to be much more important and possible with a rigid endoscope. Schaefer has given us the grading system in the laryngotracheal injury. And in grade 1, you have a minor hematoma. Grade 2 has got mucosal injuries, but the cartilage is not exposed. The grades 3, 4, and 5 are those where you have progressive degradation of the tissues, and grade 5 is where you have the entire airway being separated. The radiological investigations that one does are basically CT scans. Grade 1 and 2 lesions, one can discuss that, but however, it is an absolute indication for grades 3, 4, and 5. Doppler and angiography are required when vascular lesions are suspected. And remember, these lesions are quite common in a penetrating trauma. When we are looking at a clinical presentation, there are two possibilities. Either you are encountering a patient who is conscious, but with an airway which is stable, or a conscious patient, but who's developing an unstable airway. Or you could have an unconscious patient who could either be intubated on site of the injury or on site of the accident, or he could be brought into the hospital dead. Let's look at these three possibilities. When you have a stable airway, you have to go ahead with a flexible fiber optic exam to know the dynamics of the airway. If the dynamics are normal, then one can think in terms of only observing this patient. If you have a grade 1 or 2 injury, then one could think of a CT scan, which again is, we could discuss about that. If CT scan is normal, then we observe him. If the CT scan is abnormal, then the situations are slightly different. In grade 3 and 4, a CT scan is again optional because probably the airway is going to be unstable, and that's where your main concerns are going to be go ahead and get the airway secured. And if the CT scan is abnormal, then one needs to think of a tracheotomy, intubation, endoscopy, and then a surgical treatment adapted to the lesions. If you have a patient with an unstable airway, then there are two possibilities. Either you have a severely acute airway obstruction, or the airway obstruction is getting developed. If you have a severe acute airway obstruction, you have to secure the airway by doing a tracheotomy or a cricothyroidotomy under local anesthesia, followed by an endoscopy, CT scan, and then treatment of the injury. It is much more tricky when you have an unstable airway with developing airway obstruction. And here you have to do a flexible endoscopy to know the airway dynamics. And then you could have, again, two possibilities. Either you have a developing critical airway, in which case you have to secure the airway under a flexible bronchoscopic guidance, or you will have the airway which is visible, which can be intubated. Following intubation, one has to go ahead by doing an endoscopy in the airway, in the esophagus, followed by CT scan, and then the treatment can be directed towards that particular injury. Those patients who have already been intubated, anyway, the airway is secured, so they will require a CT scan, endoscopy, and then grading of the injury. In grade 3 and 4, they will require a tracheostomy and surgical treatment. In grade 5, what would be important is to secure the airway by using a fiber optic exam and then surgically treating him. Remember the slide when we said that if you do not know what is the airway looking like, when there is uncertainty, it is much more better to keep the patient breathing spontaneously and using a flexible fiber optic exam. You would explore the neck in grades 3, 4, 5 injuries, massive subcutaneous emphysema, if there is air bubbling through the wound, profuse active bleeding or rapidly expanding hematoma, neurological deficits. And while you are exploring the neck, if you have to explore the recurrent laryngeal nerve, you would do that in a penetrating trauma where you have a direct transection of the nerve, or if the damage is within the field of the trauma. Blunt trauma, it gets a little tricky because it's generally going to be very, very difficult to find the nerve in swollen tissues, and therefore there is going to be a greater risk of damaging probably an intact nerve. Remember, exploration of a hypothetically injured nerve is not recommended. Regarding late repair, it gets more and more tricky and complicated. There is more edema, there are more hematomas, there is infection, there is cicatricial sequelae, and that's the reason why every hour counts. If immediate action is not taken, dramatic impact on the final outcome can be expected. Let's look at every individual structure now with which is getting traumatized. In case of a hyoid fracture, the treatment is conservative, except in certain cases and for pharyngeal tears. This is a patient who is an 86-year-old man who had a fall and had a fracture of his hyoid bone. When we did the endoscopy, the entire petiole of the epiglottis was displaced posteriorly. So here is a patient who could land up with a supraglottic stenosis, and I went ahead and repaired his hyoid bone. We fixed it with PDS, polydioxanone mini plates. We pulled the petiole of the epiglottis in front and did an epiglottopexy to prevent a possible supraglottic stenosis. Associated pharyngeal tears were repaired by using mitral sutures. Thyroid cartilage fractures could be fixed by using metallic plates, PDS, biodegradable plates, or just by using resorbable or non-resorbable sutures. If we are using metallic plates, then it is important to know what size of drill bit you are going to use to make the holes on a ossified cartilage. So typically I would use the drill bit of size 1 millimeter smaller than the intended screw to fix that particular plate. The plate can also be fixed by using non-resorbable Prolene sutures. How would you fix an anteriorly displaced arytenoid cartilage? So you have the anterior displacement of the right arytenoid cartilage. The vocal ligament is shortened. And in fact, the way we do it is by using a blunt probe and then try to fix it to repose back the displaced arytenoid cartilage. And in fact, this is the patient post-operatively, and he had a very, very optimal improvement from the endoscopy and from the voice point of view. Let's go through certain examples of very severe injuries. This is a patient, a young patient of 25 years who unfortunately had a downhill VTT cycling accident, and he had his thyroid cartilage, cricoid cartilage fractured. He had an avulsion of the epiglottis, rupture of the cricoarytenoid joints, and I thought it's going to be extremely difficult to manage this particular patient. But we took our time. We put the mucosa to mucosa, cartilages were fixed together. We put in a stent to internally support and stabilize the reconstruction. And eventually, the patient had a very, very nice outcome. He had a very good voice and was very happy with the final outcome. What is important in these cases is that one needs to have a three-dimensional meticulous surgical correction to have a very, very good result. And remember that a similar situation, a similar injury, if is presenting late, then the treatment gets a little tricky because this is going to be more cicatricial, the larynx could be non-viable, and then the surgery probably is going to be much more radical. Indications of airway stenting, usually I would do for a disrupted or an unstable airway, laryngotracheal framework, tracheal ring injury, if the cricoid cartilage is structurally fractured, if there is massive endolaryngeal laceration with a high risk of cicatricial stenosis, and if there is mucosal laceration of the anterior commissure. And this is going to be perhaps done for about 2 to 4 weeks, depending on each case. For me, there are 4 varieties of stents. The laryngeal anterior commissure stent is used for the anterior commissure. The Monier's laryngotracheal mold is typically used for the larynx and upper trachea. The Montgomery T-tube is used for tracheal injuries. And we sometimes use the Monier's laryngotracheal mold fixed on the Montgomery T-tube, and this can be used for larynx and tracheal injuries. This is the way we fix the lax. It is fixed by using a Listenberger's needle carrier on a suspension laryngoscope. And here, in fact, we see a laryngotracheal mold, which can also be fixed endoscopically under suspension microlaryngoscopy. A couple of minutes on inhalational injury. So remember, we have a steam injury, which are typically wet heat injuries, and this can cause a laryngeal edema or submucosal petechiae, or it could be related to the flame, and this is basically dry heat that causes severe necrotizing tracheitis bronchitis, intra-alveolar hemorrhagic edema, and soot deposits. Ammonia gas can cause liquefaction necrosis of the supraglottis. And the treatment, again, basically is secure the airway, diagnose the lesion, and then, of course, treat medically and with corticosteroids. There are certain decision-making which are very important in these kind of injuries. Here is a young man who had 80% total burns surface area injury. And one of the decisions was that what should we do for his neck injury? And the important decision making is actually to skin graft them, because if you have to do a tracheostomy, it is going to be extremely difficult in a thermally damaged neck. In these cases, think of doing a percutaneous dilatational tracheostomy, which has got lesser problems of damaging an already traumatized neck. So probably think of a percutaneous dilatational tracheotomy in these cases. However, if there is already a significant tracheal inhalational injury, then of course one has to go by an open approach. Regarding the caustic lesions, in the acute phase, one can see erythema, edema, and basically the first grade of these lesions is restricted to only the mucosa. The second grade is limited to the muscularis mucosa, but there is epithelial exfoliation, erosion. And the third grade is basically when you have a transmural burn, and typically coagulation kind of necrosis in acids and liquefactive necrosis in alkali. And here is a young man again following sulfuric acid ingestion, and a flexible esophagoscopy was done using a pediatric esophagoscope and CO2 insufflation. And in fact, you can see that the esophagus is terrible. I mean, there is fragile hemorrhagic darkened mucosa, really dead tissue. And you can clearly see that the tissue is opened up whilst we are doing our endoscopy. And the management of these acute lesions is medically stabilizing the patient, endoscopy to demarcate the grades of the lesions. Endoscopy could be delayed unless in presence of respiratory symptoms or if one is suspecting an esogastric perforation. And then, of course, management of the tracheostomy, passing of a nasogastric tube, and then directing our treatment to these very difficult injuries. Here is a patient with a partial pharyngolaryngeal obstruction following caustic injuries. And in some cases, one can see a complete obstruction of the pharynx and the larynx. So in such cases, we use the CO2 laser to open up the airway, to delineate the pharynx, and eventually use a colon to line this particular injury so as to create a new pharyngoesophageal conduit. So here is a patient who initially had no voice, had a PEG, had a tracheostomy, and now he has got a normal voice, he eats normally, and he's breathing without a tracheostomy. So the take-home messages in these kind of injuries is basically related to a precise diagnosis of laryngeal and the concomitant injuries is extremely important. And the problem is that early preoccupation of the patient related to injuries to the brain, to the spine, probably might hide these injuries. Systematic airway management is critical. And remember, emergency surgery can prevent disastrous consequences. And here, they are the same as for open limb fractures. Every post-trauma hour counts, because if we delay the treatment, one has to be ready for consequences, and the patient might remain handicapped for the rest of his life. Thank you very much for patient listening, and I'm happy to take any questions.
Brilliant. Thank you very much, Kishore. That's a wonderful talk, to be honest. I learned a lot of things. All the cases are amazing, and you have covered everything in 30 minutes, which is nearly an hour lecture. Thank you very much. The questions are typed in Q&A session, so if you would you mind just type in the answers, that will be great, Kishore. Now, it's great that we are only 5 minutes late. That's because of my panel. My apologies, not yours or anyone's fault. Now we have Cameron Davis is going to lead another panel about soft tissues. So Cameron, you can share your screen and you can invite and introduce your panelist. Thank you, Cameron.
Thank you, Jay. Can you hear me?
Yeah, we can hear you. We can see you. You look very smart.
Thanks very much. It's an absolute pleasure to be involved, Jay. I'd like to congratulate you on your fantastic organizing of such an invaluable educational resource. My name is Cameron Davis-Husband. I'm a consultant head and neck surgeon working out of Brighton and East Grinstead hospitals. I have just in the process of sharing my screen, which I hope you'll be able to see.
Perfect. We can see your screen.
Thank you. So I'm delighted and humbled in equal measure to be chairing this panel of expert speakers, and we have a fantastic national and international cohort of experts from Italy to New Delhi, but of course native to the United Kingdom as well. I'd like to introduce Professor Cesare Piazza from Brescia in Italy, Mr. Kishore Shekhar, who's a consultant oromaxillofacial surgeon at 9 Wells Dundee, Professor Farooq Rafat, consultant ENT and head and neck surgeon in Sydney, Australia, Mr. Mrugranke De, who is a consultant head and neck surgeon in Birmingham, and Professor Alok Thakkar, consultant head and neck surgeon and neurotologist in Delhi, India. So it's my pleasure to bring them in to introduce them to you today in the context of our talk, which is on soft tissue infections of the head and neck. So the aims of this study are not to, this lecture rather, are not to exhaustively focus on deep neck space infections of the entire head and neck. That would encompass too much. So really we're focusing on deep space neck infections within the fascial planes of the neck. I hope to elaborate a little bit on the background and anatomy, but really I hope to divert to my colleagues for case selection, because I think we'll have decades of anecdotal experience and evidence, which I hope you'll all draw from. Neck space infections are particularly important because they affect a broad spectrum of patients, from those in infant years to those in their 7th, 8th, and even 9th decades. Sometimes they can be fairly benign conditions, and sometimes they can be fulminant and life-threatening. It's also important to appreciate that in many situations, it can be the trainee or the registrar who is the penultimate and definitive clinician who is treating these infections. So for training purposes and considering how serious these infections can be, I think formal education is absolutely mandatory. After case selection, the format will be, we will present a little bit of evidence. Some disclosures are that this is non-systematic accrual of evidence. It's literally taken from PubMed, and the purposes of it is not to challenge or refute any of the anecdotal experiences of our expert panel. Rather, it's to provide useful nidus for information and discussion of controversies in the literature. So what are deep neck space infections? Well, simply put, they're defined as an infection in the potential spaces of the fascial planes of the neck. And really, a detailed understanding of the fascial planes will thoroughly guide the surgeon to their location and the most effective way to evacuate and treat them. Accordingly, the surgeon has to decide on a variety of choices during the acute phase of the illness. Or invariably, when you have a deep neck space infection, this may be in close approximation to the upper aerodigestive tract. So securement of the airway, really in accordance with airway breathing and circulatory resuscitation principles, should be the first and foremost priority. This can broadly be divided into three main ways to manage the airway. There is an approach where you can electively observe the airway and escalate where necessary. Of course, you have the opportunity for close liaison with your anaesthetist at an early stage, and elective intubation is always a sensible modality to consider at all parts of the management process. And finally, you have your definitive airway, which would be a tracheostomy. There are advantages and disadvantages of each approach. In the latter case, of course, you have all the complications associated with a tracheostomy, so that may be bleeding, infection, and more serious complications. In the former, where you observe the airway, of course, you negate all those complications, but you have the potential for rapid decompensation. So each case really needs to be assessed on its own basis and merits. How we employ supportive resuscitative care is also extremely important, because many of these patients may present in a moribund situation. If someone has fulminant sepsis or a necrotizing fasciitis, then simple adjuncts such as bolus of fluids and nutrition can be the difference between someone decompensating rapidly or remaining stable until a definitive surgical procedure can be employed. So it's really important to consider such patients really as a global problem rather than a pocket of abscess which needs to be expelled. Antibiotic selection is also extremely important. Over the last 50 years, there's been a paradigm shift in the organisms which are responsible for deep neck space infections, which we'll go on to discuss briefly. In the pre-antibiotic era, it was usually staphylococcal or skin commensals, but now what we're seeing is a mixed flora of aerobes and anaerobes, and in the majority of cases, streptococcal species that originate in the oral cavity or oropharynx that have become made the transition between being a commensal bacteria to becoming pathological. There's always some controversy about when to operate. There are certain research groups who have strongly advocated in certain case series a purely a medical approach, that is to say, antibiotics alone. And there's no doubt that there has been success in such an approach. But it's also very important to understand when you don't have that option and when you should simply operate. So I hope that that will be covered in and reflected in the cases that we discussed today. When we do come to operate, it's also equally important to consider what procedures we perform. Clinicians may describe anything from needle aspiration to simple incision and drainage, and this can be performed intraorally or transcervically, depending on the extent of the abscess. And again, I hope that the cases will be useful in helping to discern what the best approach may be in certain situations. So to make all these decisions, the surgeon must have an appreciation of the anatomy of the region. So a detailed understanding of the cervical fascia and the spaces is key really to helping to determine the approach. The etiology of the infection, according to how it originated, may not always be immediately discernible, but it's very useful to help understand and guide your antimicrobial therapy. And empirical antimicrobial therapy until cultural insensitivities have been elucidated as key to the resuscitative process. And finally, There are a variety of diagnostic tests which are available for the clinician, some of them potentially with therapeutic purposes in the context of a guided needle aspiration or drainage, and the clinician should be intimately familiar with these. So just talking a little bit about the cervical fascia, we have broadly two main types. The superficial cervical fascia originates from the cranium and extends all the way down to the axilla. It lies just below the dermis and encompasses the platysma muscle, extending to involve the muscles of facial expression. And the confusing part of the nomenclature of cervical fascia, and certainly something I encountered during my training, is understanding that there is a superficial, deep cervical fascia. So I think that's where trainees can find a little bit of difficulty in appreciating. So the superficial or deep cervical fascia has a broad attachment from the nuchal ridge posteriorly down to the clavicle. Acknowledgement to Professor Fagan for his fantastic works in the Open Atlas, and for which these subsequent diagrams are derived. As we can see here, the cervical fascia, the deep cervical fascia, originates from the nuchal ridge, extending laterally to involve the mastoid process, the inferior border of the zygomatic arch, also from the inferior border of the mandible. It also encompasses the parotid glands or the submandibular glands, which are not demonstrated in this diagram, but for those purposes detailed. It attaches to the hyoid bone anteriorly, down to the manubrium in the sternum anteriorly, inferiorly, laterally along the clavicle to the acromion, and also encompasses the sternocleidomastoid muscle and the trapezius. Secondly, we have the second layer of a deep cervical fascia, which is pretracheal. And the pretracheal fascia has two separate components. The first is the muscular component, and this extends from the hyoid bone to the sternum, encasing the infrahyoid strap muscles. The visceral component, contrariwise, actually houses the organs in the pretracheal fascia, so that is to say the pharynx, the esophagus. It forms the pharyngobasilar fascia, and also encloses the trachea. As we can see, there are variances in the termination of these fascia inferiorly, and this has clinical consequences in sequelae. Finally, we have the deep cervical fascia, and this originates from the atlas and the skull base superiorly and fuses with the muscular division of the pretracheal fascia inferiorly. So when we observe a topographic diagram in a sagittal and an axial setting, we can readily appreciate that the different fascias separate the neck into key spaces. So looking at the axial view, we can see the turquoise outline of the sternocleidomastoid muscle and the trapezius muscle. Moving deeper, we can see the purple outline of the strap muscles anteriorly. Here we can see the trachea and the visceral layer of the pretracheal fascia encompassing the esophagus and trachea. And posteriorly, we can see the prevertebral muscles, the scalene muscles, encircled with fusion of the atlas superiorly. So when we look at the sagittal views, we can now start to appreciate the ramifications of different terminations of fusion with the cervical fascia. So if we look at the red outline here, we can see that the visceral layer of cervical fascia fuses with the alar fascia in the retropharyngeal space at approximately vertebrae T2. So an abscess in this area would terminate at this level and be self-limiting according to these principles. But if we get herniation through and perforation through the alar fascia, then this reaches the so-called danger space. And the danger space, as we can see moving inferiorly, is completely contiguous with the mediastinum and actually all the way down to the diaphragm. So being able to appreciate this anatomically and physiologically will help the surgeon to risk assess and plan the treatment modalities accordingly based on how they predict ways of spread of infection. As we mentioned previously, there has been a paradigm shift in the etiology of deep neck space infections, and up to 85% of them are now derived from oral cavity sources. So submandibular space and masticator space abscesses account for up to 85% of deep neck space infections. And as we can see, any variety of oral trauma or infections can induce these. We can also see that tonsillitis is the predominant etiological factor for development of peritonsillar space abscesses, and the same can be said for parotiditis and parotid space abscesses, respectively. When we get to parapharyngeal space abscesses, we almost sort of open up a highway to more serious complications. The parapharyngeal space will almost inexorably be put to trainees during their exams, and typically it's described as an inverted pyramid originating from the skull base and extending down to the hyoid bone, with the pharyngobasilar fascia medially and the mandible of the right ramus of the mandible laterally. It's also divided into pre and post styloid spaces, determined by the styloid process, with the post styloid space housing the carotid fascia and the carotid artery with its internal jugular vein and nerve. And so from extension of infection from the parapharyngeal space, we can see that we can actually breach the carotid space, the retropharyngeal space, and then the danger space, as previously mentioned. So going from a very benign condition such as tonsillitis, we can see how the flow of infection can result in some very serious potential sequelae, such as mediastinitis, vertebral osteomyelitis, and empyema. We also know that if the parapharyngeal space infection extends laterally, then the carotid space similarly is contiguous with the mediastinum. The final point to mention on this slide is that these arrows are unidirectional, but in fact, it's not reflective of how infection can flow. We know that it can actually go in between any of these spaces, but it helps the clinician understand what the worst case scenarios are with seemingly indolent infections at the outset. Like any complex medical condition, the diagnosis should be through thorough history and examination, and this includes nasoendoscopy, where safe to do so, for an airway assessment. An appreciation of common and uncommon symptoms, in addition to early and late signs, is extremely important. Not all patients with deep neck space infections will present with unilateral odynophagia, trismus, and a fluctuating fever. Sometimes the symptoms, particularly the early symptoms, and for example, those in children, may be reasonably subtle. It may be something as seemingly innocent as the child not quite feeling right, or having restricted turning of their head movement, which could actually be a sequelae of a retropharyngeal abscess causing torticollis. So the surgeon should always employ very high degrees of suspicion when the mounting evidence starts to accrue that this could be something more sinister. Finally, of course, we do have imaging, and CT, ultrasound, and MRI have all been described in the literature with their various advantages and sensitivities and specificity results. We can discuss that ad nauseum, but the most important principle here is that it secures the diagnosis, and it should only be arranged in the context of a secured airway. So this conveniently brings me on to my cases. So I'd like to first of all introduce Professor Alok Thakkar, who is a professor of head and neck oncology at the Institute of Medical Sciences in New Delhi, and has a specialist interest in head and neck oncology and neuro-otology. Good morning, Professor.
Good morning. Thank you.
So Alok, would you be so kind to comment on the clinical photograph? We have an 18-year-old female who presented with a 7-day history of worsening odynophagia, dysphagia, a fluctuating pyrexia with a recent alteration in their voice. This may have been some time since you've managed such a case, but if there is such a time where you have managed one, how would you approach this?
So what we see here is what is almost certainly a peritonsillar abscess, because you have a young girl who's had gynophagia, difficulty in pain in swallowing with tonsillitis, pyrexia, and of course an alteration in voice, which tells you that there's significant bulge out there, what one tends to call a hot potato voice in this situation. When you look inside, you can see that there's a bulge on the right side, and the tonsils push down, and of course medially, and you see the bulge above it, which is reaching up to the uvula. So in this setting, given the pain and the pyrexia and the setting, this is almost certainly a peritonsillar abscess. Of course, if you also found some evidence of tonsillitis and lymph nodes, that would further confirm your impression there. And well, you asked me as to how we would manage this. So yes, antibiotics, as one tends to do for tonsillitis, which generally includes either a second-generation cephalosporin or a penicillin. And in this particular instance, with the peritonsillar abscess setting in, I would look at an aspiration to confirm the diagnosis, and of course, general treatment to look at hydration and to look at pain relief and control of pyrexia.
Thank you very much, Alok. That's been very useful. I'd also like to defer to Professor Cesare, who is a professor of head and neck surgery at the Institute of Head and Neck Oncology in Brescia, Italy. Morning, Cesare.
Hi.
How would you manage this? Would this be a similar sort of management algorithm that Alok has described?
Yes, I would start either by an aspiration through a needle. This is frequently accurate. I mean, if directed lateral to the tonsil in an existent space, I mean with abscess, you will feel the typical sign of a cavity. In that position, you will take some cc of pus, and you will have a confirmation of your diagnosis. In the same situation under local anesthesia, I mean in the office, I usually complete this kind of aspiration and diagnosis with a formal small 1 centimeter maximum cut again after local anesthesia, and to drain the lesion, to drain the abscess. Again, this is usually a very immediate maneuver that give relief to the patient and must, at least in my opinion, always repeated 12 or 24 hours later. And frequently, even though you don't find any more abscess in at the first maneuver, you will have some more drainage in the subsequent 12 years. Obviously, it must be accompanied to, as already mentioned, by antibiotic therapy, corticosteroids, and painkiller.
Thank you very much indeed, Cesare. That's taken me conveniently on to our next points, which are some focuses of discussion in the literature. So, Alok, may I go back to you for this question? So, a study by Kawabata and colleagues actually triaged patients into situations where they felt a tonsillectomy was indicated when CT scan demonstrated extension of peritonsillar abscesses into the parapharyngeal space. Generally speaking, in my practice, I have to say only a small proportion of patients undergo imaging, and an even smaller proportion go on to have tonsillectomy. But Cesare has already mentioned that he would incise and drain in some cases. Do you have a comment on imaging quincies, or do you routinely image them, or maybe not? Maybe more so in a minority of cases.
Well, it's more the exception than the rule, at least in my experience. But it may happen that, for example, when there are not convincing evidence of discordance between, for example, trismus bad general condition, and you don't find the abscess by either a puncture or an incision. So there is a discordance between what you see and what the patient feel, and you may suspect something different from what you are looking at, perhaps just a tonsillitis, and you are doubtful for a deeper abscess. Then I do obviously a CT scan, it was just something that happened last week. You find, for example, a posterior abscess in the retropharyngeal space or in the parapharyngeal space, and then you have to you can drainage with a more targeted maneuver the abscess, or again putting the patient under general anesthesia and doing it in the OR. I usually do not like a lot Quincy tonsillectomy, but obviously if you need it, sometimes you should do that. It's not my rule, however.
Thank you very much, Cesare. That's extremely insightful. Alok, the next question for you is that the mode of intervention has already been touched upon. In situations where you get a dry tap, we sometimes see recovery in patients, and the anecdote is that we sort of punctured the area and allowed the theoretical abscess to drain, even though we never quite reached it, perhaps. And we do see improvements in these patients. Do you believe in peritonsillar cellulitis and that the abscess hasn't formed, or do you focus down on trying to identify an abscess if the signs remain present?
Well, it happens indeed. The peritonsillar cellulitis, if you're lucky enough to take in time your patient, again, you find a negative aspiration and sometimes a negative even incision. But in the following 12, 14, 24 hours, you should have a brilliant rapid improvement of the pain, trismus, and general condition of your patient just under antibiotics and corticosteroids. If this is the case, sometimes you don't see any abscess at all, and you take revert the situation to the pre-inflammatory condition. But this remains in my book an indication to schedule the patient for tonsillectomy anyway in the following 1 month or so, when the situation will be cold enough to do it in a normal way.
Thank you. Professor Thakkar, what are your thoughts on the elective use of corticosteroids in peritonsillar abscesses?
No, we haven't done that, and I don't quite see the need for doing that, because I would say that the conventional way of treating it with antibiotics and drainage works well and works very well. And yes, on the theoretical ground, you're a little bit worried that steroids may quite work on the disease process in the wrong way. So no, haven't done it. I'm sure that if you use steroids, you'd get faster relief. But it doesn't seem necessary and perhaps unwise. So not in my opinion.
And what proportion of patients whom you get a good yield of an aspiration from a peritonsillar abscess do you send home on the same day? Do you admit all these patients and treat them with intravenous antibiotics, or if you get a very good symptomatic improvement and a good yield of pus, do you believe that, and they remain systemically well, do you believe that's an indication to send them home?
No, we tend to admit them, especially after an aspiration. Certainly when we started out in the specialty and the standard was incision and drainage, there was more confidence that once the abscess is drained and drained completely, you could send the patient home because you expected a quicker resolution of symptoms. But nowadays you tend to aspirate because that is the way that everybody does, and that's how it's expected and anticipated. And with aspiration, there is going to be the odd time where you might need to aspirate again in a day or so, or convert to a drainage. The basic advantage of aspiration is that it confirms your diagnosis. You get the pus out, you get the microbiology, you can give the right antibiotics, and oftentimes that's good enough. But yes, now and then following an aspiration, you would need to go back and aspirate again or do a complete quinsy drainage as has been described, yes.
Thank you very much. That's excellent. I'm mindful that we could probably continue talking about peritonsillar abscesses for the rest of the session, so we should probably move on to the next case, but thank you to the panelists. The next case we have is a 45-year-old male who describes a recent sore throat with progressive adenophagia, dysphagia, neck swelling, and significant trismus. And I'd like to introduce Professor Farouk Rafat, who is a consultant ENT and head and neck surgeon working out of Sydney, Australia. Good morning, Farouk, or it might be good evening over there.
Hey, Cameron, good evening. Yeah. Nice to see you virtually. It's been exactly 10 years since we were fellows.
Yeah. Since you were teaching me about parapharyngeal abscesses, and you're still teaching me.
Correct. So look, this is an axial contrast enhanced CT scan. So what you see is radiolucency in the pre-styloid parapharyngeal space, extending. It's multiloculated and pretty much extends right down to the level of the hyoid, displaces the pharynx and the laryngotracheal complex medially. In fact, it actually has locules extending out to the pre-tracheal space into the strap muscles. It's very extensive. So it pretty much highlights what you showed earlier with that flow chart. This is something that started in the parapharyngeal space. It's extended out to the masticator space and to the pretracheal space. You can see there around the masseter temporalis, there are locules of radiolucency. So this is quite a nasty infection. Requires, do you want me to keep talking? Or?
Oh no, thank you. No, I was writing down your notes and for my revision purposes. But in this situation, Farouk, as you've already described, quite a severe and extensive abscess that you very kindly described in perfect detail the extent of the abscess. When you see a condition like this, and there's a predominant intraoral component, that is to say, the swelling is in the mucosal space of the upper digestive tract. Would you consider primarily addressing this through the transoral route?
No, I wouldn't, certainly not for this. Look, in any deep neck space abscess, specifically for parapharyngeal, you've got to have good source control, microbiology, and manage the systemic infection and manage the airway. So the problem with this, number one, is that it's multiloculated. It extends across multiple fascial planes. The vertical extent is very significant. With a transoral approach, your airway, number one, is not secure. This pharynx is quite significantly medially displaced. Secondly, you're very likely just to probably get one locule of pus, which might give you a false sense of confidence or maybe at best a temporary relief. And this is at risk of spreading further down into the mediastinum, down into the carotid sheath, down into the prevertebral space, exactly all the things you said earlier. And it's airway threatening. I mean, at least radiologically, look, ultimately airway is a clinical assessment. So you can never really use a CT scan to assess the airway. But this airway is certainly displaced and potentially, even if it's not threatened now, is impendingly threatened. If this was in A&E at 6 p.m., you certainly would not leave this patient overnight to do the next morning. So no, I mean, I would secure the airway, awake fiber optic intubation, and take an external approach, classical approach. We won't necessarily describe that, but I think most of us know how to do that. Get into the parapharyngeal space, blunt dissect the entire area out to break down the locules. Look, often it's quite disappointing. I mean, I've done a fair few of these, and it's surprising that the amount of pus doesn't always correlate to what you're expecting. You're going in and you're thinking you're going to get this. I used to do general surgery before ENT, and it's like a perianal abscess. You get this huge amount of pus, and indeed you surprisingly get very, very little. So I think there is a concept of toxic vapors, which you talked about earlier with quinsy, where I think if you break down the locules, wash it out, put a Yates drain in or a Penrose drain in, it seems to get the patients better.
Thank you, Farouk. That's extremely helpful. Can I introduce now Mr. Kishore Shekhar, who's a consultant maxillofacial surgeon working out of Nine Wells Hospital in Dundee. He's got a specialist interest in oral cavity and skin cancer. Good morning, Shekhar.
Hi, good morning.
Good morning. So sometimes we find ourselves cross-covering each other habitually in the UK, and an advanced infection like this may reach the echelon of a maxillofacial surgeon when there is no ENT surgeon on call, and vice versa. Would you agree with the comments made by Farouk concerning the extent of the infection in the approach?
I actually fully agree with what Farouk has said. I think the philosophy of most maxillofacial surgeons would be not to let the sun set on pus, and especially not in the neck. I know that there are papers talking about long-term antibiotic therapy, but I think that is only going to delay the inevitable. So I fully agree. We would approach it via the neck and drain all of that, including we would go on to explore some of the masticatory compartments too, because invariably you want to look at not just the parapharyngeal, you want to also look at the lateral pterygoid space. And if you've got such a big abscess, your extension into the temporal space is also quite high. So we would explore all spaces. We would not delay by giving antibiotics. We'd just go for surgery first.
In the context you mentioned the temporal space, would you go transurally via the coronoid for that abscess extension?
No, we would approach all of it straight through the neck axis, because at the end of the day, as you and I both know, these are all artificial spaces and they are all interconnected. So I would not get at it transorally, because what we should not forget is that if they truly have a parapharyngeal space and a masticatory compartment, they are going to have absolute trismus. So trying to get via the coronoid would be a futile attempt. All we're going to do is cause more damage than good. So your best attempt is to go extraorally and go into the temporal space via the pterygomandibular space and then come down into the lateral pharyngeal space.
Thank you very much. So some discussion points, and our final panelist whom I've yet to introduce is Mr. Mriganke De, who is a consultant ENT surgeon and head of robotics at Queen Elizabeth Hospital, Birmingham. Good morning.
Good morning. Can you hear me, Cameron?
I can hear you perfectly. Thank you.
Thank you. Thank you for the invitation.
Oh, you're most welcome. Yeah. So we've covered the management quite comprehensively in this case, Mriganke, but a paper coming out of Korea has tried to algorithmize as best as possible parapharyngeal abscesses, and as we can see, they seem to have used the size of an abscess being justification for more simple approaches. And indeed, it's not beyond the realms of imagination, particularly if we don't scan quinces, that we may be aspirating a small proportion of parapharyngeal abscesses, and these could be resolving with such. Do you have a sort of hard and fast rule when it comes to parapharyngeal abscesses? Do you always treat them? Do you always incide? Do you always drain them externally? Do you always aim to aspirate them? Or have you seen situations which resolve?
I think if you look at it from perspective, I think both Farouk and Kishore has alluded to what I believe is the case. The case you presented, you will not be doing a localized approach to drain with an aspiration, because that needs an open approach. However, if you see a localized abscess with a scan, you can deal with an ultrasound guided drainage, and we tend to do that. If we look at a paper in the ENT masterclass by Annie Offo, he has looked into that, and I think there are publications on it based on the fact that, especially on the pediatric side of things, I think 2.5 centimeter is a benchmark. If it's less than that, one can manage those patients conservatively with a long-term antibiotic or a localized, intervention. Whereas if it's a larger abscess like the one you showed, I think the option of local topical approach, such as ultrasound guided aspiration, probably not a good start. So it depends on the case which you are facing, and obviously CT scan, especially for parapharyngeal abscesses, is a very important part of the investigation. and it is very sensitive. MRI is better, but CT is, because of the ease of access to CT scanner and time it takes, etc. It's probably the best investigation. And I think the paper you showed us, it shows that smaller abscesses, you can sit and do either a needle aspiration or give antibiotics and wait for it to settle down. But you have to be carefully observing this group of individuals.
Thank you very much. And I think you've made a really good point concerning the CT scan, which I think all of us would agree should be sort of up there at the first line investigations wherever possible in helping plan the next appropriate steps. So thank you to the panel. We'll just move on to the next case now. I have mentioned corticosteroids with regards to this, but I think we've probably covered that in the context of Quincy. So the next case we have is a 59-year-old male who presents with recent toothache. He now has developed progressive neck pain with swelling and a fluctuating pyrexia and dysphagia and a past medical history of diabetes. The clinical photographs can be shown. So Kishore, could I defer to you in this instance? It seems to be something that I would be calling you about.
Yes, absolutely. This is something that we get regularly, what people would call as a Ludwig's angina, which I think anatomically we would describe it as a bilateral involvement of the submandibular space and the submental space and the floor of mouth or the sublingual space. In maxillofacial surgery, I would consider this one of the true emergencies that we act upon because of the risk of airway compromise in these patients. So my own approach and the approach of most maxillofacial surgeons would be to admit straight away. If the patient is diabetic, I would consider getting his blood glucose level in line and starting a sliding scale, putting him on some IV fluids, because we should never forget that these patients would have had this toothache and this brawny swelling for probably close to 48 hours before they actually present to us. So they invariably are dehydrated. So fluid resuscitation is quite urgent. In terms of management, I think nobody will deny that surgical management is the first line. One can argue whether you need a scan or not. I would argue that you do not need a scan. There is enough clinical justification in a true Ludwig's angina to go to theater ASAP. So we wouldn't delay trying to get a scan. Surgical access would be transcutaneous to approach all spaces. And for the young trainees, you do not expect to find too much pus in a true Ludwig's angina. It is often described as a brawny, hard swelling. So it may not truly be an abscess. It would more be in the line of cellulitis and inflammation. So do not expect to find too much pus, or do not be disappointed if you do not find too much pus as expected from a swelling. So I would just go ahead, drain it. Invariably, patients do come with trismus, and with muscle relaxants, you should be able to open the jaw wide enough to get that tooth out. I agree that the commonest cause for a Ludwig's angina is a tooth abscess, but you can get it with tonsillar infection as well. In our own practice, we do not do a tracheostomy on these patients. We do an awake fiber optic intubation in our unit and most of the other units that I worked in. If there's a risk of post-operative airway, then I think we would put them in the ITU, intubated and ventilated for 48 hours. What is, of course, interesting is there is a paper from 1970s and early 80s, which has suggested continuous infusion of steroids in these patients at 1 milligram per kg body weight over 24 hours. It is something that I don't do regularly, but I have seen other units in London do it. And that is something that you can definitely consider, that in big dose of steroids for 24 hours at 1 milligram per kg body weight for the first 24 hours as a continuous infusion. That is something that can be considered. Broad spectrum IV antibiotics and managing their medical status, especially the diabetes. That's the way we would approach it, but I'm happy to be challenged and questioned.
Thank you very much. I'll try not to create too much conflict between you all. So here we have an axial CT image, and if I could now defer to Cesare. Cesare, the cross-sectional images on the CT are shown, and as we can see, there is widespread gas-filled abscess formation in the bilateral masticator space and the floor of mouth, but also with extension into the left submandibular space. Would you elect in this situation to proceed straight to theatre based on clinical grounds, as per Kishore has suggested, can sometimes be the most judicious approach?
Well, the CT scan shows, in my opinion, probable anaerobes deep neck spaces infection bilateral. If this is the CT scan of one of the patient that you previously showed clinically, it's in line with what I was looking at in the submental and submandibular area of that patient, which is also diabetic. So I would have no doubt in this case. I would proceed with nasotracheal intubation and bilateral drainage of the abscess. I would have been surprised not to find an anaerobes in this case, where I see a lot of air inside the and together with the pus, and also I would do in the same OR, in the same procedure, a close evaluation of the teeth by a maxillofacial colleague, and if in case of abscess or evident origin of the problem from the inferior teeth, I would recommend treating them simultaneously to the surgical procedure. Then the problem of extubation of the patient can be postponed up to 48 to 72 hours, leaving the patient in the ICU, as mentioned by Kishore. But in a case like this, I would be more inclined to make a tracheostomy and leave the patient under general sedation the shorter time possible, just because he's old, diabetic, and I think that sooner or later the problem of the extubation will arise even in ICU 2 or 3 days later, and usually it ends up with again a tracheostomy. So well, it's a case by case choice, but I would be more inclined to make a tracheostomy straight away at the end of the surgery.
Thank you, Cesare. And that's brought us almost through fate onto our discussion points, which are airway management. Alok, if I could please defer to you for the next question. This study quoted that all patients with Ludwig's angina should have tracheostomy cited because of the compromise. We've now just heard from a couple of experts that is not required. We're always taught in medicine to try and avoid always and never in clinical situations. Alok, what are your thoughts regarding tracheostomy in Ludwig's angina? Have we lost Alok, perhaps? I think we've lost Alok briefly. Farouk, perhaps you'd like to step in and make a comment?
Look, I think a lot of this, Cameron, is resource dependent. If a patient, I mean, I think most of our teaching hospitals have no problem, as Kishore said, and most of our anesthetists are able to do an awake fiber optic intubation. Certainly with ENT registrars, fellows, and consultants in theatre, the awake fiber optic intubation, in order to secure the airway, is not going to be an issue. I think, as Cesare highlighted, the problem is an unpredictable duration of how long this patient will need to be intubated. So the issues with tracheostomy are twofold. Number one is whether you need a tracheostomy to safely secure the airway pre-procedure. And the second is whether you need the tracheostomy to accelerate their progress through the hospital. Because if a patient is intubated, then they're occupying a very valuable ICU bed. If they're tracheostomized in our teaching hospitals, they're not in ICU, they're in a normal ward, an ENT or maxillofacial ward who are able to manage tracheostomized patients. So I think the unpredictable nature of the resolution of this infection, particularly in a diabetic, would mean that I would do what Cesare says, which is secure the airway with an awake fiber optic intubation, perform the procedure, and then perform a tracheostomy through an entirely separate incision. So you must make sure that your two incisions don't communicate. And then the tracheostomy allows them to go straight to a normal ward and an accelerated pathway. And then if they get better and you can deflate their cuff and their airway swelling settles down, well, you can get the tracheostomy out and get them home. But sometimes these patients take an awfully long time, especially when they're diabetic and their sugars are unstable and made more unstable by the infection. It can actually save them a second trip to the theater and then going through this spurious process of awaiting a cuff leak on the ventilator. And then if they don't have a cuff leak, then you might take them for a trial extubation. You're just adding unnecessary steps to the process. That's my opinion.
Thank you, Farouk. That's invaluable insight. And I think everyone's in agreement that there is a spectrum of indications for forming airway adjuncts. And I don't think anyone is in disagreement here. Rather, it is tailored on a case-by-case and resource allocation basis, as you've astutely described. We'll move on because it's the cases get more interesting as we go, and I'm cautious of not restricting the learning opportunity. So the next case is a 4-year-old boy who presents with progressive neck stiffness and reduced neck movement. He also describes feeling not quite right, and his parents are concerned. He has a fluctuating pyrexia and has had a recent upper air digestive tract infection. I'm just going to see if Alok has managed to find his way back online, and he hasn't quite yet. So in this case, Kishori, what are your initial thoughts when you see a presentation like this? Is it something you would defer to one of your registrars, or are your ears sort of pricked up at this?
We would never defer a pediatric patient to a trainee is the first starting point to say, because I think that with the pediatric patients and with the elderly patients, their physiological reserve is limited. So what you do not want to do is to lose time over this. So progressive neck stiffness and reduced neck movements with dysphagia, probably my own differential diagnosis in a pediatric patient would be a peritonsillar abscess or a quinsy or something along those lines. Because it's a 4-year-old child, I'm not sure how easily we could get an awake CT scan. So my thoughts would be to get an anesthetist involved earlier than later. Think of getting the child intubated in some form of format and getting CT asleep. That would be my first line, aside from medical management of this patient.
Thank you, Kishori. So fortunately, the child is extremely cooperative and goes to the CT scanner. And as we can see when we scroll more caudally, this particular patient has evidence of a retropharyngeal space infection with stranding of the parapharyngeal fat in the right supraclavicular fossa and some reactive lymph nodes. As you can see here, also the airway looks reasonably patent without imminent compromise. We can see the outline of the low signal density in the retropharyngeal space here. I'm just going to try Prof. Alok again to make sure that everyone is. Oh, hi, Prof. I was wondering if you had some comments on this case. How would you approach this child who's clinically sitting upright, drooling a little bit, but not in an imminent airway compromise, but after the CT scan, it might allude to potentially some deterioration?
Right. So you'll excuse me, but I didn't quite sort of get this from the beginning, but I get the clinical picture of someone who may be on impending airway compromise, and should you actually go in for a CT scan?
So this is a 4-year-old boy who has evidence of what seems to be a retropharyngeal abscess.
Yes. So I must say that for some reason we have very little experience with pediatric retropharyngeal abscess, because we don't see this quite. We never quite see this with tonsillitis. I'm not so sure why. But yes, I mean, I would certainly make the point that a CT is not essential, and the airway takes precedence over CT, and it's always airway and general resuscitation of patient, and then radiology, and then of course antibiotics and surgery. So if the airway is a concern, then I would be worried. I'm just saying that, is this a retropharyngeal abscess? If the patient just came in with fever and drooling and a child, then in today's day, of course, epiglottitis is very unusual. But nevertheless, I mean, the DD would be between retropharyngeal abscess and epiglottitis, and you would try and get a better view of that, maybe get a lateral X-ray rather than a CT. And that should generally give you the diagnosis as to what you're dealing with and move forward.
Thank you. That's very, very useful to obviously consider alternative diagnoses in the presence of somewhat atypical presentation of symptoms. I think that's an invaluable learning point. Raganke, if we move on to the case discussion, we've got a systematic review of the literature, which is compared in a non-randomized fashion antibiotics versus surgical management for pediatric deep neck space abscesses. And as we can see, the overall risk benefit seems to be firmly in the middle, with abscesses being drained and managed conservatively, straddling the confidence line. What are your thoughts regarding when is a safe time to treat with medical management, or is it simply dictated by who happens to be on call that evening?
I think, first of all, sorry for a bit of noise. I'm sitting in a clinic and there was somebody screaming the place out next door to me. My sincere apologies. So it's a retropharyngeal abscess. The case in context which you are describing, it will need draining, because that's a sizable abscess. And I agree with Olok and Kishore's point, is we need to secure the airway or get some kind of airway assessment before we do a CT scan. Question with regards to antibiotic and whether surgical intervention, as I commented in the previous comment, is that there are discussions among the pediatricians and those who do pediatric ENT. They talk about the size, which is important. If it's a small size abscess, they still believe, and as you can see from your paper, the paper you're quoting, is that I think the outcomes are similar. So if it's a small abscess, there is a point of continuing on a broad spectrum antibiotic such as clindamycin with tazocine or something on the lines, depending on what the microbiologists say, and see how the patient goes. But it is very important that the patient needs to be clinically assessed on a regular basis rather than, not reviewing the patient again. If it's obviously it's a massive abscess, then there is definite point of doing something. The reason for that is for those of the guys on the line who are very junior, if it's a retropharyngeal abscess, and if you're putting this 4-year-old child to theater, there is a fair chance the child will go to a high dependency status. So it's something you have to bear in mind, because you can't do it from outside. You obviously can do it from outside, there's drainage, but more than likely you're going to do it from inside. So that is why the discussion about how do we manage this group of individuals, and obviously 4-year-old or 3-year-old or 2-year-old, putting them to sleep, anesthetic part of it also is quite a challenging issue. Obviously, if you work in a massive hospital like the way I work, it's fine, but if you're in a smaller hospital, that is another thing you need to take into consideration.
Thank you. That's very comprehensive management algorithm that you've highlighted there. I think we'll move on to the next case for the purposes of getting a broad spectrum of conditions. We've got 2 more cases. We may only have time for 1 more. So case 5 is a 42-year-old lady who presented with severe adynophagia and dysphagia for 1 week. This has been associated with left-sided neck pain and torticollis, And on examination, she seems to have a discrete area of cellulitis involving the left anterior neck. And this was all following an episode of quite severe pharyngitis, which she's not experienced before. And if I could please call on you, Cesare, for your thoughts when we look down at the axial images of this CT scan, which when we scroll caudally, we can see a filling defect in the left internal jugular vein with some lymph nodes and some in level 5 of the neck with some fat stranding, and posteriorly there's a very small retropharyngeal fluid collection which your radiologist has assured you is reactive and not an abscess. What are your thoughts when you receive this report and take into account the patient's symptoms?
Well, this is a so-called Lemierre syndrome, usually following sometimes a trivial upper airway digestive tract infection like tonsillitis or something like that. It develops in the following days a thrombophlebitis of the internal jugular vein, sometimes associated with the reactive inflammation of adjacent muscle, usually sternocleidomastoid muscle, but it can happen also for prevertebral muscles, so causing pain usually in rotating the neck on the contralateral side, with stiffness at palpation of the and pain at the level of the, in this case, left sternoclavicular muscles. It usually is not associated with a so evident clinical signs. Sometimes you have some redness in the neck. Sometimes the original infection in the tonsil or others has already solved, has already vanished, and so you don't see no more the source of the problem. The patient refers a sore throat and nothing else. But like in this case, you have no abscess and nothing else to drain or to address surgically. So this is the point I would like to stress in this case, looking at the CT scan, is just to have a look from the surgical point of view to the cranial and caudal extent of the phlebitis, since it can well extend intracranially in the sigmoid sinus and distally into the junctioning between the jugular and the subclavian vein. That those are 2 points of attention that you have to check with your radiologist, since they can change a lot of the management of the overall management of this patient.
Thank you, Cesare. That's a very useful point to consider. And in terms of the management, Lemierre syndrome actually has been reported with increasing frequency over the last 40 years, and it's difficult to ascertain whether or not this represents a genuine increase in cases or an improvement in radiological detection of a flow void within the internal jugular vein. Farouk, what are your strategies with regards to anticoagulation of a completely thrombosed jugular vein? Do you think it's something that's mandatory?
Look, I mean, I don't think there's any harm in doing it. I think I do it, but we wrote a paper on this a few years ago, but I think this needs quite aggressive systemic treatment. Cesare said, you want to find the source. Look, it's the same principles for all of them. Find the source, get source control of the infection, secure the airway, systemic antibiotics, and for this one, anticoagulation. I think, you know, a jugular vein is one of the major veins. It's not a minor vein, so it's not a superficial thrombophlebitis. This is a deep vein thrombophlebitis. There is a risk of septic emboli, which can be consequential to a lot of these patients. A lot of them are immunosuppressed. We have also seen these with intravenous drug users in less desirable parts of Sydney, where they run out of peripheral veins and they use their external and internal jugular veins as routes for access. So you do have to check that in the history. But yes, look, I think you do need anticoagulation for these.
And finally, Farouk, just Cesare mentioned that surgical management is not indicated. There have been reports of resection of a thrombosed internal jugular vein. Is that something you've ever done in your experience?
No. Look, the vascular surgeons can do endovascular thrombectomies, but it's very uncommon. These things actually, I've only ever seen 3, and all 3 recanalized very quickly. And 3 over 10 years, they're not that common. This is in the largest teaching hospital. So yeah, but they recanalized quite quickly.
I think that's exactly what's reflected in the world literature. So thanks for confirming to our audience. I'm just going to defer to Jay. Jay, do we have time for another case, or I'm mindful we may be running over a little?
I think, can I give you 2 minutes? Is that possible?
Yeah, sure. So the last case we have is a 34-year-old woman with recent pharyngitis and presents acutely unwell. She looks gravely ill with septic shock and a CRP of over 400. The only sign is some mild redness in the oropharynx and diffuse cellulitis in the anterior neck, which from the time taken for the trainee to clerk them to the time when resuscitative measures are put in place seems to be visibly spreading. Alok, you're nodding almost knowingly, and I'm sure it is. Do you have any thoughts regarding this? I think you're muted, sorry. I think you're muted, Alok. Can you hear us?
He's muted.
Who knows the sign language for muted?
So I'm sorry, I'm not nodding knowingly. I'm a little bit confused as to what's happening, and we are short of time. Please go ahead. And there's no point.
So I'll open this up to the whole panel. So we have a CT scan, which going from craniocaudally demonstrates extensive gas-filled abscess in the left parapharyngeal space, the left posterior neck, into the mediastinum and into the retropharyngeal space, danger space, and to the level of the pericardium.
So I think the clinical sign here would have been that when you would have seen the patient, you would have got some subacute crepitus, and that would have taken us to the diagnosis. But just looking at it, I can't make it. Yes.
So opening up to the entire floor, and if we bring the diagnosis to you as descending necrotizing mediastinitis, does anyone from the panel who'd like to volunteer their experience with this, if they've had such? It's extremely rare.
Yes, I can if you want to. Because of my current working relationship with the thoracic surgeons, we tend to get quite a lot of the referrals across from on around West Midlands to us. This is, as you put it down in the slide, it's a mediastinitis. This patient needs an urgent attention with the ENT head neck or a head neck surgeon with a thoracic surgeon. I know that they try with VATS drainage and things like that, but I think this patient will need an open, sort of exploration of the neck and, open exploration of the chest even, because it's going all the way down to the pericardium. We're not going to get with the VATS all the way down to the pericardium. So it's quite a dire situation. The chance of mortality is very high with this patient, and the patient, will need airway securing, going to intensive care for quite a length of time. The swallowing will be affected. So it's quite a, sort of distressing time for the family, and, things are not going to be great either. How the outcome is going to be difficult to predict in this constant.
If I can comment briefly on that case, honestly, I would not do it through sternotomy, or I would not suggest to my thoracic surgeon to open the sternum of this lady. I would do for sure a neck incision, and my thoracic surgeon at least should do left thoracostomy due to the fact that if you open the sternum in a case like this, you will have an osteomyelitis of the sternum, and you will have also problem with the tracheostomy itself. So in this case, the pericardium should be addressed by left thoracotomy. If needed, and this is obviously the case in which you need that.
Thank you very much, Cesare, and thank you to the whole panel. I think if there are no other comments, we probably don't have time for our last case, but I think we have unreservedly covered a full breadth of conditions of deep neck space infections. And I'd like to thank the panel for their time and expertise. And thank you, Jay, for giving me the opportunity to chair this panel. Are there any questions?
That's really, thank you very much, Cameron. You did a wonderful job, all the panelists. It's amazing cases. I think I could have given more time. Great, and we will move on to Matthew Ellie's talk. And Cameron and the panelists, I would kindly request to type the answers from Q&A and some of the questions directed to some of the panelists as well. So either while typing the questions, please answer to all of them because it goes to all. Thank you.
Thank you, Jay.
Hello, my name is Matthew Ellis. I'm a consultant paediatric ENT surgeon at the Royal Hospital for Children in Glasgow. I'm very grateful for the opportunity and really pleased to be here to present this talk on paediatric head and neck emergencies. I've structured this talk to try and represent the sort of common calls that you might receive whilst on call, covering children. So stridor, swelling, bleeding and tracheostomy problems. Here's a child with stridor. You can hear a harsh respiratory noise which is due to airway narrowing, causing turbulent airflow. Stridor is a sign, not a diagnosis, and it's associated with problems that can be mild all the way through to life-threatening. The diagnostic clues that you can pick up are related to the pitch, the phase in the respiratory cycle, respiratory rate, work of breathing, importantly effectiveness of breathing, and other diagnostic clues such as the presence of fever, which might give a clue as to the etiology. SATS monitoring is important, but primarily it's a clinical diagnosis and a clinical assessment. Localizing the source of the narrowing can be done using the respiratory cycle. So an inspiratory stridor is more likely to be in the region of the supraglottic larynx. A biphasic stridor is likely to be arising from the glottic or the subglottic region, and an expiratory stridor more likely to be arising in the intrathoracic region. Also, it's possible to have multiple synchronous airway lesions and other lesions such as nasal stenosis, which in itself doesn't cause stridor but can exacerbate stridor. Relating to the work of breathing, the clues that you can pick up about a child or especially a baby: nasal flaring, grunting, head bobbing, tracheal tug, recession and accessory muscle use are all worrying signs. Red flag signs for a child that's really struggling: silent chest, cyanosis, desaturation, or a slow respiratory rate should all be considered peri-arrest signs. So to talk then about laryngotracheobronchomalacia, a group of conditions associated with narrowness and collapse of the airway. Laryngomalacia is not necessarily an acute condition, but it can present acutely, either because of progression of the disease, progression of the condition, or because of an intercurrent condition causing the child to decompensate. 90% of kids get away with conservative management only, perhaps with feeding, support and anti-reflux treatment. But the 10% who need surgery sometimes presents as an emergency. The emergency management of a child for whom you suspect laryngomalacia are all about patient positioning, for example, a head-up position or sit the patient up, supplemental oxygen, non-invasive ventilation if possible. Nasal suctioning is helpful because it confirms the patency of the nasal airway and also will help to clear secretions, so reduce any additional airway compromise. Oximetry and or capnography is important if available. The mainstay of diagnosis for laryngomalacia is flexible nose endoscopy. This can be done at the bedside. Here's a video of laryngomalacia. You can see the classic features. So a curved epiglottis, short aeroglottic fold and redundant arytenoid mucosa. In this video, this one is from microlaryngoscopy, and here it's predominantly the arytenoids that are causing obstruction. The point of this is to demonstrate that laryngomalacia is not a single, it doesn't present in a single way, but treating it is all about identifying where the source of the obstruction is and tailoring the surgery that you're going to do to the source of the obstruction. There are several classification systems, at least 7 that have been published, and most of them help to try and locate where within the larynx the obstruction is. Here's a video of tracheomalacia. Surgery for laryngomalacia involves supraglottoplasty. The 2 main complications are aspiration and supraglottic stenosis, also potentially recurrence and the need for further surgery. A meta-analysis of over 1,000 patients a few years ago showed that a unilateral approach can reduce the risk of stenosis down to 0. However, the authors of this paper favoured a bilateral approach on the basis that there was a 4 times higher risk of needing completion surgery or further surgery for patients who underwent unilateral supraglottoplasty. My approach is to favour operating on just one arytenoid, but approaching both aeroglottic folds if necessary. Let's move on. Considering a call where you've been asked to help because a patient can't be intubated, here's a video of a laryngeal web. This video shows grade 3 subglottic stenosis. This is a static image of a subglottic hemangioma. These lesions, it's fairly obvious why it might be difficult to intubate. Here's a picture of a laryngeal cleft. It might not be so obvious why this could cause difficulty. There is a case I was involved with, not this particular picture, but a patient with a neonate with grade 4 laryngeal cleft for whom the anaesthetic team were having difficulty intubating. And what was happening is they were able to get a reasonable view and get an ET tube in, but what happened was the tube fell from the trachea down into the esophagus and they were unable to effectively ventilate them. That patient had an emergency tracheostomy. Here's an image of a patient who you can expect would be difficult to intubate. There's a small jaw and a large lesion within the tongue. You can imagine trying to get a laryngoscopy view around the corner. The important thing when trying to secure the airway is all about communication. There are multiple techniques and strategies available, such as anaesthetic type equipment, laryngeal mask airway, supraglottic airway, video laryngoscopy, and jet ventilation. My go-to get out of jail free technique is to railroad an endotracheal tube over an endoscope, either a flexible endoscope or even a Hopkins rod. Ventilating bronchoscopy is the standard way of securing the airway, and if all else fails, emergency tracheostomy. The Difficult Airway Society is a UK-based organisation that provides guidance on training and the approach for emergency front of neck access surgery, and they recommend a scalpel bougie tube approach, but also the guidelines say that if a particular operator has particular skills or experience in a particular technique, that clinician should use the technique which they're most familiar with. For me, emergency front of neck access in a child involves stabilising the larynx with a non-dominant hand and making a vertical incision, aiming for the 2nd to the 4th tracheal ring. Let's talk about infection. Croup is probably the most common infective cause of stridor and accounts for 80% of cases of acute stridor. Almost always mild. There was a recent review that demonstrated less than 1% of patients had severe presentation, and intubation was required somewhere between 0.4 and 1.4% of cases. It typically presents with stridor, barking cough, and the main decision to make in severe cases is whether or not to intubate. Of course, securing the airway, intubating is always the default position, but it's not always necessary. And if you do intubate a patient with croup, then you're then committed to probably 3 or 4 days on the intensive care unit, waiting for the swelling to go down, waiting for a leak to appear. So making that judgment call as to when a patient is safe enough to observe and when you need to intervene can be difficult. The mainstay of treatment is nebulized adrenaline and systemic corticosteroid, and there's been a Cochrane review which clearly demonstrated benefit to both of these two. Steroids improve symptoms quickly, benefit lasts a fairly long time, and there's a 50% reduction in readmission following croup. Supplemental O2, supplemental oxygen is always worthwhile, and if a child's really struggling, then Heliox can be beneficial. Some authors have published advice about Heliox that in a patient who is having ineffective breathing, Heliox may be disadvantageous because the maximum fraction inspired oxygen for Heliox is 30%. It's formed of 30% oxygen and 70% helium, and the advantage is that it has lower viscosity, so it's easier to shift air, it's easier to breathe in and out. However, if a patient's ineffectively shifting air, that patient might do better with going for 100% oxygen instead of trying Heliox, which can only achieve a maximum of 30% FiO2. Here's one of a few different staging systems to help assess the severity. A high oxygen requirement, biphasic stridor, and multiple signs of struggling represents a patient who's likely to need at least consideration of intubation, and if not that, then close observation, which basically means level 3 observation on PICU. While croup is a viral infection, bacterial tracheitis, as the name suggests, is bacterial and presents with these suppurative exudates, and the patient would present with a stridor, barking cough, and a high fever. Pseudomembranes deposited within the tracheal lumen can cause airway obstruction, and here's a video of an optical grasping forceps being used to remove the pseudomembrane in a case of bacterial tracheitis. Epiglottitis is another airway bacterial infection which presents with a sore throat, drooling and high fever, characteristically very rapid onset, usually within 24 hours, and occasionally associated with stridor. It's caused by, most commonly, Haemophilus influenza B, and although vaccination has reduced the incidence, it's not completely excluded it from clinical practice. This is a situation where, to assess the patient, the safest way to do it is to move to a position of safety first, and that means either resus in the accident and emergency department or theatre or intensive care. Another not uncommon infection is retropharyngeal abscess. It's rare in adults but more common in children because of the presence of some retropharyngeal lymph nodes which tend to regress by adolescence. Children tend to present with stiff neck, sore throat, and it's always important to consider this diagnosis in a non-verbal child who presents with drooling. The complications can be airway obstruction, mediastinitis, vascular compromise, and intuitively it would seem that an aggressive surgical approach is necessary. However, the evidence doesn't necessarily bear that out. A retrospective study of 93 children carried out in Liverpool showed that abscesses less than 2.5 centimetres can be safely managed conservatively. Also, a different observational study of patients who did go to theatre found that the false positive rate on CT was 25%. So even a CT demonstrating a possible collection, if it's early, it may not yet have suppurated. One way to establish that is to look at the thickness of the prevertebral tissues. The way to do that is to look at the level of C2, and if the prevertebral soft tissue is more than 7 millimeters, or a rule of thumb, more than 1 vertebral body width, that's abnormal. At the level of C6, if the width is if the width is greater than 14 millimeters, that's abnormal. And either of those things should prompt you to consider a contrast-enhanced CT scan. Other deep neck space infections, less common in children, but do occasionally occur. When parapharyngeal abscess occurs, it's usually in the post-styloid space, unlike adults, which is typically pre-styloid from direct spread. In children, post-styloid again because of the location of some lymph nodes there. A study of 178 children had a similar finding. The authors identified 2.2 centimeters in this region as the threshold for needing surgical drainage. Less than that, conservative management may be appropriate as long as the child is not failing to progress after 48 hours and not showing any signs of airway compromise. In this region, clearly a very vascular area, and there's a risk of Lemierre syndrome, which is infective thrombosis of the internal jugular vein. In the submandibular and sublingual space, those abscesses are very rare in childhood, typically because they are odontogenic in origin. Quincy's happen in adolescents, but are very rare in younger children. Any child presenting with a deep neck space infection, remember not just the surgical approach, but the physiology of the child. The Sepsis 6 campaign provides guidance for both adults and children, and any of these warning signs, I won't read them out, but there they are, should prompt these 6 interventions: on oxygen, vascular access, broad spectrum antibiotic, IV fluids, a senior review, and consideration of whether inotropes are required. Let's talk about hemorrhage. Unfortunately for children, post-tonsillectomy hemorrhage is a reasonably common presentation. Trauma also a source of hemorrhage. Bleeding is usually evident, but not always, especially post-tonsillectomy. Always be aware of a quiet child who's sitting up and apparently swallowing, because this can be a sign of ongoing bleeding that's going down into the stomach and may not be immediately obvious, especially if the child presents with abdominal discomfort or nausea. It's worth knowing some of these numbers. The emergency fluid resuscitation bolus recommended by the Resus Council is 10 milligrams per kilogram, and this can be repeated if necessary. This represents the protocol for maintenance fluid. Possibly a simpler way of remembering it is that for a 20 kilogram child, 60 mils per hour, and then plus 1 additional milliliter per kilogram. The circulating volume of an infant is 80 mils per kilogram. It can be difficult to identify a child that's going into hypovolemic shock, particularly because the objective signs, high tachycardia and hypertension, are late signs. The things to watch out for are a child who's irritable, cool peripheries, agitated, or pallor, as these can all be signs of fairly advanced stage of shock. Deciding whether or not to transfuse. Remember that hemoglobin concentration is a poor indicator of resuscitation status, partly because of physiological hemodilution. Also, the child may have had IV fluids. A better indicator of end-organ hypoperfusion is elevated lactate level. The probably most widely accepted transfusion target in modern practice is 70 grams per litre, and this is mostly based on, or a significant contributor to the evidence base of this is a study that was performed in over 600 PICU patients, where they were randomised to groups of either having a target of 70 or 95 grams per litre in their transfusion protocols. Those who had the lower target didn't suffer any additional organ failure, and there was no additional mortality, aiming for 70 grams per litre. Also, the patients with the lower target had half as many pulmonary complications as for those where the target was 95 grams per litre. Remember transfusion-associated coagulopathy. Any of these things can can affect coagulation, and make sure to be aware of your trust's massive transfusion protocol, which the most common type is 1:1:1 with packed cells, platelets and cryoprecipitate, but there are some local variations, so make sure to know your local protocol. Other interventions that can be used for post-tonsillectomy hemorrhage: tranexamic acid is growing in its body of evidence in favour. This study was just published this year, and patients who were given nebulized tranexamic acid had a significantly lower rate of needing to go to theatre following a post-tonsillectomy bleed. A couple of other studies have had similar findings, and the disadvantage to systemic tranexamic acid is mostly with prothrombotic conditions, ischemic heart disease, things that tend to affect adults more. The main contraindication in children is hypersensitivity. Antibiotics aren't indicated to try and prevent bleeding. This is a large meta-analysis which showed no benefit with prophylactic antibiotics in terms of bleeding, or post-op fever, or resumption of normal diet, or resumption of normal activity. Hydrogen peroxide is something which has been commonly used but is contraindicated. An observational study of 10 years of cases published in 2005 showed that gargles of hydrogen peroxide had no effect on the duration of admission following a bleed, or the rebleed rate, or the readmission rate, or the requirement for theatre. Children may not be of an age where they can even tolerate hydrogen peroxide gargles, but if you have an adolescent with a post-tonsillectomy bleed, it's not really indicated. Additionally, there was an MHRA alert released in 2014 advising against the use of hydrogen peroxide in body cavities or deep or large wounds due to the risk of air embolus following 5 cases of deaths in the UK and some others around the world. Arguably, an exposed tonsil fossa in a small child could be considered a large wound. Let's talk about potential tracheostomy problems. The sorts of problems that children get are similar to the sorts of problems that adults with tracheostomies get. But the old adage that a child is not just a small version of an adult is true. Kids have short, fat neck, a narrow, pliable trachea. The pleura extends superiorly up into the neck, and they have a low physiological reserve. Also, they're less likely to be cooperative when there's a problem, and may have multi-system comorbidity. Relating to the tracheostomy itself, most paediatric tracheostomies are single lumen, and a child is much more likely to be ventilator dependent than an adult with a tracheostomy. Here's an image of a case of a child who had a relatively short period of inadequate humidification, and there was very significant crusting within the tracheostomy lumen, and an emergency tube change was performed. However, there was also significant crusting within the trachea lumen, and the child had to go to theatre for removal of those dried secretions. Tracheostomy displacement is definitely a risk. One way that this can be mitigated is with the use of stay sutures, and my routine practice is to insert these and remove them at the first tracheostomy tube change. When using stay sutures, it's important to remember to label them left and right, so that if in an emergency they can be used to open the airway, because if they're held the wrong way around, they actually can do the opposite and close the stoma, which doesn't help. False passage is a risk particularly following an emergency tube change, but also can happen after an elective tube change. It means the tip of the tracheostomy tube ending up in the pretracheal space, which clearly is ineffective for ventilation. Worse still, if someone recognises that the child's not ventilating properly and tries positive pressure ventilation, this can cause surgical emphysema, which can cause swelling of the neck, which can just make the whole situation worse. So therefore, for any elective or emergency tracheostomy tube change or tube insertion, there's a set of checks that I go through, and I keep on going down this list until I'm 100% certain that the tube is in the right place. Does it look right? Does it sound right? Can you palpate airflow with the dorsum of the wrist? That particular one's difficult while wearing full PPE. If unsure at that stage, you can pass a suction catheter or flex blendoscope to make sure it passes smoothly into the lumen. Look for symmetrical chest wall excursion, chest auscultation, and if available then tidal PCO2. And don't stop going down that list until you know that the tracheostomy is in the right place, and if it's in the wrong place, take it out and start again. Some red flags relating to tracheostomies: a new air leak or new vocalization, difficulty passing a suction catheter, grunting, stertor or snoring, or any kind of increased ventilator requirement should all prompt an urgent review. There have been some recent guidelines published about tracheostomy care, and these guidelines are really all about standardization. So standardization of training, protocols, standardization of bedside information cards, and standardization of the bedside tracheostomy box to make sure that the emergency equipment is always available and always the same, so you know what you're going to get in an emergency. Here's an example of a safety info card, and the idea of this is that it's laid out in a standard manner to quickly give all the relevant information required for someone who may not be familiar with the patient about the details of the patient's airway and their tracheostomy, and therefore what can be done and what needs to be done in case of emergency. Also on the back of that form is a helpful flowchart for dealing with emergencies. Clearly this is not an exhaustive list of paediatric ENT emergencies, but hopefully a helpful overview of the sorts of presentations that you may encounter while on call. I'm grateful to my colleagues Kerry McAllister and Haytham Cubber for letting me use some of their clinical photos. Thank you very much for your attention.
Thank you very much, Matthew. Any questions to Matthew, please write it in Q&A so he will be able to type. And now I'll invite Omar Hilmi to introduce Simon Crawley.
Could I just make sure there was one question? I was typing answers to questions as we went along, and one of them I made a typo and I deleted my response and typed it again. So I just want to make sure everyone saw that the second one was the one I meant. Someone asked how I address supraretinoid collapse, and I initially said if the patient is one of the 90% who can be treated surgically, and I meant treated conservatively. 90% of kids are treated conservatively. Just want to make sure that the second answer is the one that was correct, or more correct.
Thank you very much, Matthew. Wonderful talk.
Thanks for inviting me. That's a question.
Much go. And moving on. Well, I must admit, I'm looking forward to this lecture by Dr. Stephen Crawley, who's going to talk to us about emergency airway management in anaesthesia and head and neck surgery. Stephen Crawley is a consultant anaesthetist based in Ninewells Hospital, and he's got a special interest in tubeless field anaesthesia. And to that end, he's chairman of the Scottish Airway Society. So without further ado, Simon, over to you.
Hello, my name is Simon Crawley. I'm a consultant anaesthetist and airway lead at NHS Tayside. Thank you for inviting me to speak again at the Scottish Head and Neck Conference. I'm going to talk today about the emergency airway management and head and neck surgery, and that'll be from an anaesthetic perspective because I'm an anaesthetist. I'm going to start with my slide 2. I've worked with several trade partners in evaluating equipment for research. I've also performed some consultancy work. I will talk about high flow nasal oxygen today, but it's important to say I've got no affiliation with Fisher Paykel or Armstrong Medical, 2 of the main suppliers of these devices in the UK. Head and neck surgery, there are lots of urgent cases, but thankfully very few true emergencies that are an imminent risk to life. It's a pretty high risk field. I spoke here last year and commented on complications of airway management, and those who attended may recall NAT4, which examined airway complications after surgery, and it's finding that head and neck represented over half the reported cases and about 1/3 of all the deaths. So it's high-end stuff. When emergencies happen, timing is of the essence, and I think non-technical skills are as important as technical ones. And our immediate aim is to secure safe and effective airway, namely to get that cuffed endotracheal tube into the trachea as safely as possible. So it's a pretty different situation to the elective stuff and even the urgent stuff. Emergencies will happen at any time. It's going to be 4 a.m. with the junior team. Patients can be extremely compromised. Time for or the ability to lie down flat for CTs or other investigations just means they may not happen. And much of the well-considered preparation discussion that we undertake, even in urgent cases, these decisions must be made quickly and promptly. So these sort of situations need calm and experienced heads. DAS do a lot of guidelines. They do guidelines for obstetrics, critical care, unanticipated difficulty, soon to be pediatrics. There is no guideline for the emergency error management. I think there's just too many variables with pathology, patient compliance, clinical state, the location where these things happen. But we can apply some simple core principles to pretty much any situation, which is having the right ethos. So getting the right person to do it with the right equipment that they're familiar with, the right time and in the right place. Oxygenation is very much a priority. And if you take the principle of the safest airways are the ones where the patients are awake and or the patients are sleep intubated and paralyzed, then our job is to get from one to the other with the least amount of fuss, the shortest amount of time, and to do it safely. So we need some plans. That plan should not be like the chap in the purple top hat to run out the door. We need to work out some stuff quite quickly, so rapid information retrieval to look at, to get thoughts on pathology, the condition of the airway, predict a clinical course, assessment, work of breathing, hypoxia, rate of onset, potential efficacies of any holding measures are at our disposal, and thinking about where we can best manage that. The mantra of must go to theatre should be challenged. This should be an active decision rather than a default move. It was always the exam answer in the FRCA that you must move to theatre. That could be true in some circumstances, but it may be safer for the patient to bring the equipment to you if you're in the emergency department. But if you are going to go, then you need to let the team know that you are coming and what you need when you get there, so everything's in place when you arrive. There are certain measures that can be put in place immediately, such as scoop for anterior neck hematoma, and of course call for help. This is a team sport, and applying those basic principles of right time, right place, right person. So your strategy in terms of what we're actually going to do, we should consider the pathology, the technique that best addresses it, who's there and what you're good at doing. Plan A and head and neck anesthesia may well be bespoke to the situation or the patient's airway, what their airway was like previously. But rescue must be simple and effective. And the evolution of the airway rescue trolley, which many of you will have in your hospital, has really helped that sort of simplify that with standardized airway equipment that is familiar and used routinely by everybody, making airway rescue swift and effective. And I think given the extreme situation the patient is before you start, realistic options of waking the patient up if failure occurs isn't there. So that conversation about further access and having absolute clarity on what that entails is really important. It was interesting to see the acknowledgement and recommendation that scalpel bougie tube is the most efficient and reliable emergency front of neck rescue technique when the airway is obstructed and other methods have failed. So ENT UK have this on their website, and I presume you're all aware of it. It should be noted that this is rescue. I think if plan A it involves our wake tracheostomy, then the airway is clearly not blocked, and therefore that plan can proceed. You can obviously deviate from that plan in light of deterioration or patient compliance, and a switch can be made if the situation requires it. So can you buy yourself time in these emergency situations? Yes. Various holding measures can be employed. Some may not be appropriate depending on the situation. Heliox, adrenaline nebs, steroid CPAP are quite often used. These might be less suitable for the traumatic airway or if the airway is bleeding. Heliox is kind of sort of going out of fashion a little bit in this, but what is definitely not going out of fashion is high flow nasal oxygen, which is kind of just finding more areas to move into. And in anesthesia, it's kind of been a game changer. It's preoperative use for pre-oxygenation, intraoperative use, tubeless field anesthesia, supporting extubation. It just grows and grows in its evidence base. Its utilization in even the most stenosed airways, and its ability to exceed patients' peak inspiratory flow rates means it can deliver oxygen at high percentages, reduce work of breathing, and that really helps the hypoxic, distressed patient who's working hard, and it can make an uncompliant patient just that little bit more compliant, which opens up various techniques to your strategy. In the emergent situation, it's a real game changer because it provides seamless transition from pre-oxygenation device into ongoing oxygenation efforts during intubation, or even through rescue apneic oxygenation in the event of deterioration, provided there's a degree of patency. That's very important. Flow is the key. Obviously, humidity makes the patients tolerate the really high flow levels. The benefits are impressive. The respiratory benefits of the reduction of work and breathing by providing that flow assist, improves secretion clearance, decrease atelectasis, well oxygenated functional residual capacity, increase in expiratory lung volumes, enhanced recruitment, just the list goes on and on and on. And the ability to sort of have that flow and that flow dependent level of PEEP, about 1 centimeter of water for every 10 liters of flow, really helps open the airway, so you can have a bit more room for the patient to breathe through, a bit more room to access with your endoscope. Pre-oxygenation, it's kind of all about apnea time, the time before the tone of the pulse ox starts to fall. It'll just increase your apneic window, and that's particularly important in patients with reduced FRC, such as the obese and the pregnant, or those with increased rates of oxygen consumption, like the people who are working hard to breathe. Once apnea is induced, provided the air remains patent, again, you can prolong the desaturation time. That time is variable. It generally shortens as BMI increases or as mass increases, but any increase in time is useful. And in extremis, it does more than just provide the oxygenation. As I said before, it reduces that work of breathing, so that hard work the patient is generating, that feeling that they can't get their breath, is helped if the flow exceeds their peak inspiratory flow rate. And taking away that oxygen hunger can improve patient compliance, and as I said before, it can open up certain techniques into your strategy that may not have been possible with the uncompliant, distressed patient. Transitions, airways change. If you have this in place, or if the intubation fails, high flow will continue to provide oxygenation, PEEP, enhanced CO2 clearance, whether spontaneous ventilation preserved. If you're having to sedate that patient to try and get a bit more compliance, or if they're apneic because you've had to anesthetize them and it buys you a little bit more time, and it's already been there and set up and on the patient because you've used it for pre-oxygenation. So different strategies are situation dependent. A lot of strategy comes with the state the patient is in, and one must recognize that airway can be lost at any time. Exam answers always say, do these patients awake? But anyone who's ever been in this situation will recognize that was not always possible. Patients just won't comply. And this is important for us to know that sort of local anesthetic drugs and sedative drugs can make a partial obstruction into complete obstruction. And then any lack of compliance and need to improve the definitive airway often means sort of taking on risk and sedating the patient. But if they are compliant, I would still put on some high flow nasal oxygen because it buys me a bit of time. It's there in case the clinical state of the patient changes, and it makes nasendoscopy a little bit easier because it splits the area and gives you more room, and also because it's prongs, you can easily access the area either through the nose or through the mouth. Nasendoscopy is my favorite investigation. I'm just going to show you a video here. Nasendoscopy is readily available. It's mobile, it doesn't require transfer, and patient can be intubated as part of the procedure. And I think in these extreme circumstances, you load the nasendoscope with your best guess tube size, because you don't want to have to do this twice. This patient presented with pretty much near complete airway obstruction. He's pretty obese, and he's only breathing through slow maximal effort inspiration. He's sort of gasping breaths. We're using high flow, so he looks pretty pink and well oxygenated, but he's got pretty minimal lubin. And you know, this is a tricky nasendoscopy. There's not a lot of room. Going slow, trying to time advanced movements with his breaths, and you know, load your tube, because you know you don't want to do this twice. Really challenging. So having a high flow, therefore, for these techniques, it gives you a bit more room, patient compliance, oxygen saturations. I wouldn't say it means you can take your time, but it makes a technique that might not have been possible. We ended up getting the tube down this person awake, so avoided tracheostomy, which was quite good. So if they're uncompliant, different story, because you just have to get control, and that kind of means that you might have to undertake something you don't want, which is to sedate the partially obstructed patient, or just give a high-risk GA with your best efforts of getting the tube down, and having everyone standing by to rescue if and when you fail. And that means that you as the surgeons are ready to go. Bleeding, this is just a nightmare. There's an excellent review written by Mike Christensen and Barry Maguire, and bleeding is a big issue. Like 60% of people will have a nosebleed at some point in their life, and we have post-tonsillectomy bleed rates that are anywhere between 2 and 10%, depending on what you read. And bleeding following surgery for head and neck cancer is a leading cause for an emergency airway requirement. Challenging because conventional approaches such as VAL, that's video laryngoscopy, and endoscopic techniques may be ineffective. Blood soily mix visualization just really hard. So these toys that we sort of produce and use in extreme circumstances, they are less useful. Oxygenation is difficult because of tolerance, and there's two problems. So you need to try and control the bleeding. So there's an airway problem and a bleeding problem, and they're kind of mixed. So it's good to have a person who can control on hemodynamic optimization while you're focusing on securing the airway. If you've got active oral bleeding, trying to oxygenate through a tight-fitting mask is really hard. Patients don't like it. They can't get the blood out. They choke. High flow nasal oxygen can help this, but relatively contraindicated. It may force blood distally into the lungs, so maybe not at the high flows of 50, 60 litres a minute that we would often use in extreme areas, but maybe you can still give 20 to 30 litres. It may help, and it allows you to suction the airway at the same time. If the airway looks relatively simple, a GA RSI will allow best control. GA with a Macintosh type VL may be advantageous, as it can perform both direct and indirect laryngoscopy. So if the camera gets soiled with blood, then you can still use it as a direct laryngoscope. Having two suctions is really important in case one blocks, and you can park one over to the left of your laryngoscope blade. You can park it in the esophagus, hypopharynx, so as blood comes to meet you, you can suction it up directly and be focusing on the tube passing into the trachea. Airway techniques are pretty challenging. You can do, although not as a definitive airway, you can put in a supraglottic airway, like LMA or an iGel, and that can be done awake. And what that does is, if the bleeding's above the glottis, it kind of creates almost an umbrella over the airway, which means you can then have a clear run at the glottis when you intubate it using the LMA as a conduit, which is a technique I've done only once and hopefully never again. Trauma, brilliant review by Simon Mercer and Pete Groom in Entry. And trauma is really challenging. Head and neck injuries, burns, max fax injuries, laryngotracheal injuries, tracheal injuries, they can be really challenging to manage. Facial and airway burns have a time critical nature, so general anesthetic, RSI, uncut ET tube is with rescue scalpel tube can be the fastest way to secure an airway. An awake trachea is possible if your patient's compliant, but it might just take too long. This review is well worth a look. It breaks down a variety of pathologies into management streams, which is kind of what I've been talking about. It will base it on patient compliance and the time critical nature of the intervention required. And here's an example with laryngotracheal trauma, employing the principles of avoiding positive pressure ventilation, so maintaining sponge venting, awake techniques to make sure you place your tube distally to the lesion, avoiding ventilation or pressure on mucosal lacerations that might allow entrainment of air into cause mediastinal surgical emphysema. So accessing the airway under direct vision to avoid entering a false passage or causing disruption. And any need for general anesthetic, you should really have a post-intubation endoscopic exam to make sure that the tube is placed appropriately. Extubation is pretty high risk, so when we put these tubes down, at some point they're going to have to be removed. So we see more adverse events at extubation than we do at intubation, and a misjudged extubation, a cough or partial obstruction with anesthetic drugs still hanging around can result in pretty rapid decline. I show this video. So this is us placing an airway exchange catheter, so that when we extubate, we still have a route into the airway if this young chap does deteriorate. And it's good to have reintubation plans that are based on previous successful techniques, previous unsuccessful techniques, and appreciation of how the airway has changed. So leaving these in until the patient's airway is deemed to be safe can be quite useful. They're pretty well tolerated if you topicalize the airway well. But the patient needs to be observed for a pretty decent amount of time, a few hours at least. So extubation straight onto high flow or CPAP can splint the airway, ease work of breathing. Has been shown to reduce intubation rates in ICU for all patients. We don't routinely use this in our unit as we work pretty hard on getting extubation right, and have a pretty negligible reintubation rate in our head and neck population. But I know some centres do, and have found it quite a useful thing in their armory. So that's a quick blast through. Head and neck anesthesia is a pretty high risk game at times. Defining urgency is the key. Patient cooperation dictates strategy. You sometimes just have to put them to sleep. Awake techniques will invariably usually be deemed to be safer, but if the patient is uncompliant, then the patient needs to go to sleep, and everyone needs to do their best. At some point you must wake them up, and it's important to pay attention and focus on making that extubation as good as it can be. Thank you very much.
Thank you very much, Simon. That was a very interesting talk. A couple of questions generated. I mean, clearly there are certain fashions in anesthesia as there are in surgery. A few years ago, everyone had to get an awake fiber optic intubation. We've now moved on to high flow nasal oxygen. What clinical situations do you think high flow nasal oxygen isn't suitable for?
Yeah, there's a few
sort of relative contraindications. The ones off the top of my head, I kind of mentioned in my talk. Sometimes the heavily bleeding airway, it's kind of a relative contraindication because it might blow blood further down the tree of the airway. Some people think it's contraindicated in head injury in case there's a base of skull fracture and you drive high flow rates of gas up the nose, causing problems. Those are kind of two things off the top of my head. There are some smaller print stuff, but it's kind of although the flow rates can be high, the pressures within the airway are actually reasonably low. It's 1 centimeter water for every 10 liters of flow. So there's not too many things that you absolutely cannot use it in, but the two that I mentioned already are the ones that are probably most commonly discussed.
Mm-hmm. Okay, thank you very much. Not much from the participants on this one, and time is moving on, so I think we're going to hand on to Liam for our piping.
Sure.
Thank you very much. That was absolutely wonderful. Liam, you're waiting there.
That's right.
How was it? Go ahead.
Yeah, great. Thank you. Before Liam, I just want to play two more sponsors video. Then Liam is going to entertain with the Scottish pipe. He's a music teacher and for more than 15 years of experience, because I love music more than the education, to be honest, and dance. So I just play two reps videos.
Of course.
Hello, my name's Lorna from Medtronic. I hope this finds you all well and enjoying the meeting so far. I'd like to take this opportunity to thank ENT Scotland for inviting me along to this online event. And here's hoping we'll be able to see each other all in person back at the winter meeting in November. Shortly, there'll be a presentation of our new exciting products from Medtronic ENT. If you'd like some more information on these products, my contact details will follow shortly afterwards. Thanks for watching, thanks for your time, and enjoy the rest of the meeting.
What if you could do even more to bring relief to your chronic rhinosinusitis patients? With technology customized to your unique clinical and facility needs. Introducing Stealth Station Flex ENT Navigation System. A customizable system from Medtronic ENT, a market leader in image-guided surgery technology. Featuring 6 hardware configurations, an optional portable card, 2 different electromagnetic emitter options. With flexibility in hardware design and optional software functionality, get everything you need and nothing you don't. With Stealth Station Flex ENT. Let's flex forward. Contact your Medtronic representative to customize a navigation solution that's right for you.
Hi, my name is Matt Livingston and I work for Reckitt Benckiser in Scotland. We make Gaviscon Advance, which is licensed and specifically indicated for the treatment of LPR, which is a common cause of cough and throat symptoms. Currently, there are no standardised guidelines for the management of LPR. Alginate-based reflux suppressants are used. Vocal hygiene and lifestyle advice is also very effective. Importantly, Gaviscon Advance is licensed and specifically indicated for LPR. It has been shown to entrap bile and pepsin and rapidly form a barrier to the damaging elements of gastric reflux. At present, PPIs are still the mainstay of treatment for LPR. However, there is yet to be an approved license for their use in this treatment area. And some studies have shown that there is no benefit to the use of PPIs alongside Gaviscon Advance for LPR. The use of PPIs in this treatment area is not evidence-based. This is being investigated through the TOPITS trial of proton pump inhibitors in throat symptoms, which we believe is likely to be published later this year. This is a UK multi-centre randomised controlled trial for adults with persistent throat symptoms to compare the effectiveness of treatment with PPIs versus placebo. I now want to highlight previous work which helped develop this treatment pathway. A review by Janet Wilson, Jason Pibble and James O'Hara in advance of TOPITS looked at the evidence base for the use of proton pump inhibitors in the treatment of LPR and identified the key features of LPR. The recommendations from the review were that there is almost certainly a subgroup of patients with reflux as a defined factor in their symptoms. A trial of an alginate seems very beneficial and low risk. However, a PPI should only be used if the patient has coexistent GORD symptoms such as heartburn. Lifestyle advice is also beneficial. Failing this, referral to secondary care would be recommended for further investigation and management. Alongside that, there has been an independent study in 2018 by Mark Wilkie, Helen Fraser and Himal Raja. This looked at Gaviscon Advance versus Gaviscon Advance plus PPIs in the treatment of LPR. From the study, their recommendations were that Gaviscon Advance alone is effective in treating symptoms of LPR, and adding a high dose of PPI appears to confer no additional benefit. In addition, with the concerns around the potential side effects of PPIs and the potential cost of leaving a patient in a PPI, it would be sensible to pursue with a solo treatment of Gaviscon Advance. Data supporting the use of Gaviscon Advance in the treatment of LPR. We need to highlight the individual study by Julian McGlashan conducted at Queen's Medical Centre in Nottingham. This study looked at patients with LPR diagnosed with reference to the reflux symptom index and the reflux finding score. Both groups received vocal hygiene advice and one group received Gaviscon Advance 4 times a day. These patients were then assessed at 2, 4 and 6 months after treatment. So this involved 25 patients in one group and 24 patients in the other. The findings were significant. This has given Gaviscon Advance the license in the treatment of LPR. What we see in this first graph is the reflux symptom index being significantly reduced more effectively than just having the vocal hygiene advice, and Gaviscon Advance sustained that benefit over the 6 months. In the laryngeal findings, improvement was seen in the reflux finding score when patients underwent fibre optic examination. Another study we are looking at today is a retrospective study conducted at Bridgewater Joint Voice Clinic in Warrington, involving 100 consecutive patients attending the Joint Voice Clinic. There were 2 groups, half received Gaviscon Advance plus a PPI, and the other half received Gaviscon Advance by itself. The study showed that there was no significant difference between the groups. The reflux symptom index reduction was equally achieved by both groups. It showed no significant additional benefit in adding a PPI to treatment. In conclusion, I hope I have given you some food for thought today. The recent clinical updates I highlighted today show the benefits of reviewing the use and prescribing of PPIs in LPR based on the evidence supporting it. Therefore, would you now prescribe Gaviscon Advance for LPR as first line or as an adjunct therapy with acid suppression therapy? And how will you ensure your patients now only receive Gaviscon Advance? Would that involve a patient information letter or a treatment protocol? If there is any feedback or if you have any questions, please feel free to contact me at matt.livingston@rb.com. Thanks for your time today.
Liam, it's over to you for next 15 minutes. Thank you very much. You may have to unmute your mic, Liam.
Perfect. Thank you.
Liam, you may have to come a little bit far away. Liam? Liam, you need to go back a little bit.
No worries.
You need to go back a little bit. You're very faint.
that better?
No, it's still you need to back because it's blowing away. Yep.
Okay.
A bit more further is better, I think. Yep. Liam, do you want to come forward and just stand there and play that? Yeah. Liam, it was initially okay, but after sometimes become faded.
No worries.
But it was really nice. Sorry,
Thank
we
you.
got
That's good. Thank you.
yeah. Thank you very much. Do you want to play for a few minutes?
Play a couple more sets.
Yeah. Okay. You can do that from where you are standing exactly. Yeah.
Perfect. Thank you.
Trial and error. Thank you for your effort.
Thank you very much for listening, everyone. I hope you enjoy the rest of your conference.
Thank you very much.
A pleasure to speak for you. I've got one more set for you, and then I'll leave. Thank you.
Yeah.
Thank you very much for having me.
Thank you very much, Leah. My apologies. I think Kirsten, my registrar, sent a nice text message saying that Zoom actually blocks a non-voice type of thing, and she has sent me a link how to play music through Zoom. Certainly, I will go through that. I will feed back to you, Liam. But it's wonderful. Thank you very much, Liam, for your.
Thank you very much.
Pipe.
For the rest of the
Brilliant. Thank you. So I'm going to play one more sponsors video. Then we'll hand over to the next panel. That is.
Hello and welcome to Inamed Neurocare Limited. Today I want to talk to you about our complete ENT monitoring package. This consists of two devices. First and foremost is our C2 Explore nerve monitor, which enables the recurrent laryngeal nerve to be monitored throughout thyroid or parathyroid surgery. We additionally have an option for continuous nerve monitoring using our Delta electrode, and bipolar and monopolar stimulation options. The device itself is very intuitive and easy to use for the OR staff, and provides a large touchscreen to be able to see and audible recognition of when a nerve is stimulated. We have a range of consumables to accompany this. Predominantly our 360-degree wrap electrode enables the connection to be placed on any intubation tube, a big plus for our pediatrics and also for the anaesthetists. There are 8 contact points, and this provides 4 active channels at any one time, meaning we will never lose signal from the vocal cords during thyroid or parathyroid surgery. Additionally, the C2 Explore nerve monitor can be used for facial nerve monitoring, providing both 2 and 4 channel options. There is a head box that connects to the table, operating table, which makes it very simple and easy to use. The hardware device itself has inbuilt QR and barcode scanners. It can be integrated into the theatres via Wi-Fi. There is an easy report generation, of which during the operation pre-programmed annotations can be applied. Our second device is the Fluoptics Fluorbeam LX. The Fluoptics machine is designed to identify the parathyroid glands using autofluorescence. Here you can see some images from the OR recently, where there is excellent recognition of the parathyroid glands glowing, and in conjunction with our nerve monitor alongside provide our total ENT package. The principle of how this works is through our handheld camera, using a light source and an excitation filter. These near-infrared wavelengths pass onto the active tissues and bounce back via the emissions filter to the camera, which is filtered and then passed directly in real time onto the screen. Here we can see further images of the parathyroid glands during dissection, and the parathyroid glands can be detected in up to a depth of 5 millimeters of tissue, which would be something that the naked eye may be struggling with. Additionally, to the autofluorescence mode of the Fluoptics machine, we have our ICG fluorescence angiography, which enables us to evaluate tissue perfusion both in thyroid and parathyroids, but also in other surgical fields such as plastics and free flap reconstruction. Combined, both machines are available on a stack system within the OR, and combined they enable us to provide a total ENT package for our monitoring services. My name is Fabrizio. I look after the north of the UK. You can find my contact details here. Please drop me an email or a phone call, and I would be happy to arrange a visit and to set up a trial. Thank you.
That's great. Now I invite Stu Professor Stuart Winter for moderating the airway panel. It's over to you. Thank you.
Thank you, Jay, for inviting me to chair this panel. And it's been a fantastic meeting so far. So greetings from a sunny Oxford and welcome to all the delegates. Firstly, it's my pleasure to introduce the panel today. Ian Nixon is a clinical and academic ENT surgeon at the University Department in Edinburgh. He's an honorary clinical senior lecturer and he did his training in London and Memorial Sloan Kettering. He has a PhD in thyroid surgery and is an expert ENT head and neck surgeon. Ms. Ekpemi Aruni is a consultant laryngologist and head and neck thyroid surgeon in Addenbrooke's, Cambridge. Her practice includes benign and malignant head and neck pathology. She's a further interest in transoral laser and robotic surgery. She runs a sleep nasendoscopy service, a specialist voice and swallowing clinic, and she has been doing a lot of work on post-COVID effects. She's also currently the president of the Women in ENT Surgery. Professor Vin Polari is a surgeon at the Royal Marsden Hospital. He did his ENT training in India and the UK before completing his fellowship in Adelaide, Australia. He was initially a consultant in Newcastle upon Tyne, but is now Professor of Surgery at the Royal Marsden. He's an extensive robotic practice and has widely published. Simon Crawley, who we heard from earlier today, is a consultant anaesthetist in Dundee. He is secretary of the Scottish Airway Group, and he has a specialist interest in difficult airways and tubeless anaesthesia. And Professor Kim Assay is an ENT head and neck surgeon in Aberdeen Royal Infirmary. He completed his training in Glasgow, Edinburgh, and a fellowship in Rotterdam. He has a special interest in head and neck cancer and difficult airway management. So it's a pleasure to welcome that panel. And before we delay any time, we're going to move on to the first case. So I'm going to present a case. This is a 75-year-old lady who was discharged one day following a thyroidectomy for a large retrosternal goiter. She was discharged with normal breathing, no particular voice problems. She was eating and drinking, but she presents on day 7 with quiet stridor. She does have a background history of psychiatric problems, and clinically she had bilateral vocal cord palsy with a 2 or 3 millimeter vocal cord gap. She's not very mobile because of her age and the fact she's had surgery, but she certainly has stridor at rest. And her psychiatric problems have not got better. If anything, they've worsened. Biochemically, she's all her numbers are normal. So firstly, perhaps come to you, Ian. Ian, any thoughts on delayed bilateral vocal cord palsies?
Hi, thanks. Well, this is a rare situation to find oneself in, to have a delayed cord palsy. Of course, we can't be certain that it is, because presumably she didn't have an examination prior to discharge. I did that briefly in my early career and then found the worrying rates of temporary palsy put me off that concept. But I guess I might think, for example, does she have a hematoma? Is something causing some compression that wasn't present in the immediate post-operative period? And would probably try to support this patient on some kind of non-invasive ventilation if there's a problem with her ventilation. But it looks like she's managing reasonably well at rest. So yeah, I'd probably image her to see if there's some collection that could be addressed.
Thanks. So we actually did image her, and there was no collection. So, Kim, perhaps coming to you, I guess the question is, how do you decide if intervention is needed?
You ask the patient, how is she getting on? Is she coping with the, albeit limited, day-to-day activities that she's participating in, or is she really struggling? And on top of that, of course, there will be your own clinical assessment of the patient's ability to maintain her airway. She's got a pretty small gap there, and it's difficult to know whether this is going to recover because it's too early to say. Whether this is temporary, one might want to peruse the operation note or speak to the surgeon involved to see how comfortable they are or were with the integrity of the nerves. But even if they're happy with the integrity, then a neuropraxia can take really quite some time to recover.
And if you, so, I mean, the surgeon was confident the nerves were intact. We don't know if this occurred immediately afterwards or it is delayed. What are your options if you do want to intervene?
Well, what I have done for these cases is a cordotomy. And see if that will improve their airway sufficiently and won't cause too much long-term change to the structure of the glottis. I wouldn't be advocating any tracheostomy type thing at this particular stage. So I think I would try and do a minimally invasive procedure, which in my hands would be a cordotomy.
And just talk me through how do you do your cordotomies?
Well, I've done them in various ways, and I think probably one of the commonest is to use the laser to divide the attachment of the vocal cord just anterior to the vocal process of the arytenoid. The question is whether you should do one side or should you do both sides. And again, I think that would depend on your assessment of her airway problems and challenges and how much of an improvement you would hope to get with just doing perhaps one side. But accepting that if she is, I maybe missed if she's overweight, I can't remember if you said that, Stuart. That might move me more towards bilateral cordotomies using the laser. Having said that, recently our own laser wasn't working very well, so I had no option but to do a cold steel bilateral cordotomy. And I have to say the patient did, in my mind, almost better after that than I had previously anticipated if we'd been using the laser, probably because of less heat artifact and less post-operative swelling. So that would probably be my next step if the airway needed intervention.
Pemi, can we come to you? I mean, what are your thoughts on, assuming we do need to do something for her airway, what would be your approach?
Yes, hello, thank you. Apologies for being late. I'm just going to summarize what I understand, that this is an overweight patient who had a total thyroidectomy, and that's the massive thyroid there in the scan. And on the scan, you can see how obese she is. And she's now developed bilateral vocal cord palsy post-op. Is that correct?
Yes, there's a slightly funny story, and she developed possibly a delayed palsy.
Right.
Okay. She's now got a bilateral vocal cord palsy, and I'm just interested in
what you do next.
Assuming you do think she needs some intervention, given that this is 2 weeks after the surgery, what would be your approach?
I think just like my colleague just said, I would probably, first of all, get an idea of how much her current situation is impacting on her quality of life, because with 2 weeks post-op, there's a possibility that this could be a neuropraxia and it could get better. And with the increasing psychiatric concerns and sectioning, then you may have a problem even trying to gain consent to take this patient to theatre. So that's something that we need to be aware of. And then how do you manage them post-operatively as well? But like my colleague, I have done Kashima cordotomies on patients like this in the past. I like them very much, but I would only do a unilateral. And the reason why is because the trade-off when you do a Kashima cordotomy can sometimes be voice. And so if things were to recover, then I would have only done one side, and I could always augment a little bit of the cord in order to make up for that later on. So I'll probably offer the same thing. I might not go straight ahead. I'll want to first of all assess how much of an impact this is on her. If she's got limited exercise tolerance, she's not moving around anyway. So there's certainly an option for conservative management and just keeping an eye on her, depending on how she does. I don't like this 2 to 3 millimeter vocal cord gap. That can be very scary when you see the patient in clinic. But again, these are the options to present to the patient. Wait until you crash or go ahead and do something small like a Kashima cordotomy.
Thank you. Vin, can we come to you and get your opinions on this?
Did I hear you right when you said she went home on day 1 post-op? That is impressive.
Well, yeah, the day after surgery, yeah.
That's impressive. So you know, I think it's too early. I'm inclined to agree with Mimi that I'd be reluctant to jump into surgery at this stage. I think for bilateral vocal cord palsy in this setting, especially with previous history of mental health issues and so on, there might be other factors at work. We do not use CPAP often enough for bilateral vocal cord palsy. Remember, this is only an obstruction that is functional. So if we can provide a positive airway pressure, some patients do tolerate it. So this could be a stopgap measure for her. So I think observation, admission, combination of CPAP, Heliox, whatnot, to see how she pans out over the next few days. Immediate post-op, a shot of steroids or at least for a few days won't go amiss, but given her mental health issues, that may potentially worse than that. So consult with your mental health colleagues. And she just had big trauma to her neck, surgically, that is. Can inducible laryngeal obstruction be a factor here? Could she just have abnormal vocal fold motion causing stridor on inspiration? So these are things to be considered, especially when you say she went home with normal swallowing and normal voice, because when you see patients post-op with bilateral abductor palsy, usually the voice is impaired, the swallow is impaired to an extent as well. So I'd be really conservative here, admit her, figure out what's going on, might take a few days or so, and then consider intervention. That would be my approach here.
Ian, you've got your hand up.
Yeah, sure. I thought I would just agree there with Vin that I think the psychiatric thing makes you think the less you do here, the better. You don't want a complication that leads this lady to be in not just because she's sectioned, but also because you've given her iatrogenic complications. So the less you do, the better. But what I was going to say is that I think in the situation where you've done the thyroidectomy yourself, particularly if you have pinged the vagus nerve on both sides and you feel they're definitely okay, then I would really be trying to do as little as possible here, because I want to sit it out and hope that there's improvement and only intervene if there's deterioration and she's unstable. But I know that there are some groups that if, for example, this was done in a community hospital that you weren't part of, and this was transferred overnight to a tertiary centre, and you don't know what the state of the nerves, some groups would explore a neck like this in Europe and go and try and look for the nerves, confirm whether they're intact or not, and then re-anastomose if they're not. I've never done it, but I know that there are some European groups who do support that approach if you don't know what the state of the nerves are like. Although it's rare that they went home day 1 fine in the with the severed nerves. But I've never done it myself, but I know there are some groups that do.
Yeah, that's a good point. Really good point that Ian makes. If if you're not certain about the status of the nerve, you are duty bound to explore it, figure out what's going on, find the severe dents, join them up. And if you can't find the proximal end, then find the answer and jump the answer into the nerve. You must do that because that gives future long-term tone to the cord, at least on one side.
So well, this is a case I was involved with. So we did treat her conservatively. Simon, just coming to you to start with. So she was admitted and her mental health deteriorated quite a lot. I know it's slightly outside your area, but one of the questions was, is chronic hypoxia contributing to her mental health deterioration? And also one of the concerns was that she had saturation monitors on her, and unsurprisingly, particularly in the night, they would drop down to low 80s and then come up when she was awake during the day. Simon, any thought, and it's slightly outside your area, any thoughts on how you would assess whether hypoxia was contributing to this and anything you could do to help that?
Yeah, I think the thing, I think I would take it in the context of what you're saying, where she dips during the night and then she improves during the day, and that's a fluctuant level of hypoxia. And if with hypoxia, you can become confused, but if she's got fluctuating saturations, you would expect that confusion.
Simon, I think you've frozen, Simon. Can anyone else hear Simon?
No, I can't. Stuart, just to point out, there are some questions on the chat function.
Okay,
I might wish to address
at the moment, so I'll have to. I'll come back. Sorry, Simon, you froze there. Actually, we missed almost everything you said.
Am I still frozen, or can you hear me?
No, we can hear you now. Thanks. That's all good.
Cool. I think the fluctuating level of her saturations that you described would suggest this is perhaps not a hypoxia-induced issue, because although you certainly can get confused.
I think we've lost Simon again.
We have.
It was a very difficult question. No wonder he's feigning to freeze.
I think we'll give him a second just to see if he reappears. Simon.
Yes, I'm just going to move somewhere else in my house.
Simon, I'll come back to you in 2 seconds just to give you a chance to find yourself. Just coming back to Kim, do you have any concerns with a cordotomy if this recovers?
I think, yes, of course, you may well have compromised the person's voice because of the scarring that would occur after your cordotomy. But I think, you're going to have to weigh up the immediate airway issues versus the long-term possible issues to do with voice. And that's a very individual assessment for each patient. I have to say, one of my concerns would be sectioning a lady like this and her ending up in a psychiatric ward where assessment of an airway would not be their forte. So I would have concerns about conservative management if this lady ended up in a psychiatric ward. And in some places, that's a different hospital on a different site, miles away from anybody who's capable of assessing their airway. And that's why I would have a low threshold for intervening and accept that there may well be some long-term consequences related to her voice, but we're talking about her airway at this juncture.
Ekpemi, I think are you in agreement with that?
Yes, I do. I do want to note the fact that there are challenges with managing this patient. in a center that is outside of a major unit. And unfortunately, that's part of the problems we have to tackle here in this case. I think there you could potentially make an exception in this case and have her nursed in your acute center, you know, under the medics. But I do take full. I do completely agree with my colleague there and his sentiments. For any further investigations, it will be difficult because you need cooperation in this patient with the mental health issues. I think here we're just going to have to be a little bit reactionary if we cannot be definitive in our initial management. With regards to her staying overnight, then just as Vince said, non-invasive ventilation is something that can help. But again, that requires cooperation, and it's unlikely she'll be cooperative with having a mask strapped on her face for non-invasive ventilation at night. So that's a challenge. Heliox might be an easier way to go with this patient. But yes, I think here it will be watch and wait and see what happens. I am not keen on giving this patient a tracheostomy because of all of the care issues that go with that. She'll be in hospital for a long time. She's unlikely to be able to be discharged to the community with a tracheostomy. But if your hands are tied and it's a crash situation, and I expect that she probably will decompensate at some point, then you will have to do a tracheostomy and hope for the best.
Simon, I think you look like you're in a better room.
Stuart, if I may come back on the issue of cordotomy again. I don't know what your experience is, Kim. Sometimes I do a cordotomy and it isn't enough, and you got to go back in a few weeks later. So this patient, it's not like we can do a cordotomy and send her away home the next day. She may need monitoring for a while to ensure that she settles down from a cordotomy perspective. So I think we've got to bring the mental health team on board, and she has to be nursed and observed and monitored post-op in the acute airway ward before we turf her to the mental health setting, I think. Because certainly in my hands, I'm usually cautious. My cordotomy, I take it all the way till I see the paraglottic fat, make sure there's a nice hemi-diamond in there. Even then, some people scar up and then the airway goes off in a week or two. You see them back, they have the same procedure, they have the same stenosis. And usually a second cordotomy is 95, 99% effective because it takes the scar away and it stays open.
Simon, I'm going to come to you just for the question we asked before. If that's okay.
Sure. I've moved to a different room, so hopefully it's slightly improved. I think hypoxia certainly can increase agitation and confusion, and certainly individuals who already have psychiatric issues may become more easily confused and disoriented in their surroundings. As to whether this the case is here, the fact that you described that her saturations are worse at night and improve when she's more awake during the day would suggest that that perhaps isn't the case. I think some people talked about CPAP, which is quite useful in these instances. And then one of the other panelists said that she might not cope with a mask on her face, and as useful as Heliox can be, the patient compliance with some nasal prongs with some high flow will produce both the PEEP that Vim was suggesting would be advantageous, and it might not be as unsettling as a tight-fitting face mask over this patient's face. So that would be one way to go.
Well, in the interest of moving on, this lady, I think you've all hit on the problem. So she actually became, her psychiatric problems meant that she really should be on a psychiatric ward, but her airway problems meant that she really needed to be on an airway ward. She did end up having a tracheostomy, and after 3 months, one of her vocal cords started working, and by 4 months, both had. Interestingly, the tracheostomy had no effect on her immediate mental health. So I think Simon's right, it probably wasn't contributory, but that did improve with psychiatric medication and heavy input on an ENT ward with somebody with psychiatric problems. So I'm going to just move to the next case. So this is a 35-year-old lady who is well known to the rheumatology team. She has a positive P anchor. She's been on various medications, methotrexate, azathioprine, and had developed progressive breathing problems over about 6 months. There's a history of intubation about a year before. And the picture on the right at the top is the picture of her supraglottic airway. And in fact, there's just a small hole that you can see just there. And that's the view through it of normal looking vocal cords. So she has a tracheostomy. It's been in there for 6 months, but she's a young lady with a young family, and essentially she's increasingly frustrated. It's a CT scan showing relatively defined stenosis at the level of the supraglottis. So, Ekpemi, this lady would like something to be done. If she came to see you, what would be your thoughts and suggestions?
So with positive anchor and staphylococcus stenosis, you're looking at vasculitis, granulomatosis with polyangiitis until proven otherwise. In our center, we are lucky to have a fantastic vasculitis team who work very closely with our ENT colleagues, ENT, in order to assess these patients. I want to know what her previous history is, whether or not she's had a previous established diagnosis of this. Has she or not? Or this is the first time she's come into hospital?
She's been under the rheumatologist for quite a while. They haven't labeled it with a final diagnosis, but she's certainly known to them.
We've seen the scans, and I think what's left really, and when you look at this sagittal view, it looks like there is a potential airway there below that, and you can see that most of the problem is at the level of the glottis. So it's not unreasonable to offer exploration to see what exactly is going on there. Is it full of scar tissue? Is it soft mucosal work? Are her vocal cords still intact? All of those things. And that's not unreasonable to have a look.
Yes, I'll show you that those are her vocal cords.
All right.
That you can see just through this supraglottic scarring, for want of a better word.
Sorry. I'm just trying to look at your top picture there.
There's just
that one. And so these are arytenoids. This is that you're seeing left and right arytenoids in the picture at 11 and 4 o'clock, isn't it?
That's correct. Those are her arytenoids.
And all of this is scar tissue. Right. So, I mean, this is a very difficult case. You could, the option of whether or not you can actually open up this airway is what the problem is, and whether or not you'll be able to save this airway. My suspicion is that she'll just scar up again. But is it worth having a go? Well, I'll have to. I don't know about wanting to actually offer surgery in this situation, just because it's likely to scar up again. Now, the picture you're showing me, you're showing me this area here in the first picture with some scar tissue over the arytenoid. Where then, is the second picture below the scar tissue when you go below that?
Yes, in that picture, just between the arytenoids, there's a very small little hole. It's hard to see on that picture, but you can just about get an endoscope through there, and then you can see what appear to be normal vocal cords below it.
I mean, it's not unreasonable to offer surgery in this situation. Warn the patient that she could scar up again. And if you are going to do that, you would want to use a laser. You want to think about steroids. You might need serial procedures to have this done. And then you might start thinking of how you can keep this open. And just managing expectations is the most important thing. You might cause more scarring by doing this, but it's a short segment. It looks like it's less than 1 centimeter, and it might be worth going for it, especially because it looks like she's got normal vocal cords beneath that. It will also be important to see whether or not even opening that gap means that she's left with functioning vocal cords. I want to know if she's got a voice as well.
perhaps come to you, Vin. What are your thoughts on offering, and if you did offer something, what would you offer? How would you do it?
Stuart, I don't have a benign laryngology practice at all, so I'm going by what I would have done potentially 5-6 years ago. I liaise with my rheumatology, clever immunology colleagues and take the advice on this. That looks really awkward to manage. It's as difficult a laryngology problem as one may get. I've had similar stenosis occur in the neoplastic post-treatment setting, but this is not comparable. I think these patients, whatever you do, the underlying disease process persists, and it's going to go on for a while. I was looking at the chat, and Prasad Kothari, who is a consultant surgeon in Luton now, sunning himself at St. Elsewhere, has just said he has patients with a tubeless tracheostomy in this instance. I don't know much about this, maybe something has to consider, but I don't have a good answer for you, Stuart, in this instance, apart from liaising with immunology colleagues.
Well, we maybe pick up the phone and ask Kim. Kim, what are you going to do?
I think you've given us a real challenge here, Stuart, and I think if most of us are honest, we've never seen this before. And the scan suggests that this is it's not a long segment of scarring or stenosis, which is good. It would be nice to think that we could somehow excise this and get the laser in and try and chop our way through some of this scar tissue. That any surgical intervention, of course, carries the caveat that you don't want to do anything until the rheumatologists tell you it's safe to do so, i.e. they're happy that the patient is as stable as they can get her. Using the tools that I have in my own experience, I probably would try first putting a balloon through the little hole and giving it a shot and see what happens if I stretch some of that scar tissue. It may look a mess afterwards, but I would probably give it a shot and see A, how easy it was to dilate with an airway balloon, and B, how the tissues looked once they had been opened up. Is there any role for excising some redundant tissue? Is there any place for just applying topically some mitomycin if you still believe that helps? So I think in the absence of any experience, I would probably resort to first principles and give it a go with a balloon first.
Can I just add, Stuart, also that, I mean, one of the benefits of, being in theater is that you can also take some tissue and send it off to the lab to see whether or not you get anything exceptional, and especially if you want to rule out anything infective as well. But just thought I should mention that we want to have some pathology on this.
Yeah, thank you. Ian, any comments beyond?
Not much other, as you say, you've got to get them optimized, got to understand the prognosis of the case from the vasculitis point of view. You might also think with the respiratory guys, is there obstruction elsewhere? Because if this is multi-level in the bronchi or anything like that, then it's going to make it even more difficult. But you got a nice safe situation, I would have a go. I don't think you lose very much by ballooning that. The worst that can happen is she's still got a trachea at the end of it. Well, she'd have that anyway. So yeah, I would have a go with balloon dilatation in the first instance and see how I get on.
Simon, is there anything you'd add from a sort of an anaesthetic perspective in somebody with a underlying vasculitis? Does that sort of give you any concerns?
Yes, I mean, we are a service specialty, so we will do what you want us to do. Yes, if someone has a vasculitis, then it's a multi-system disease, so they can have lung involvement, they can have poor renal function. So it would just be a case of having those organ systems as optimal as possible, avoiding anaesthetic techniques and drugs that would add further insult to those organ systems. But we are guided by what you want to do to this patient. And if there was a balloon then or an attempt at laser, I would change what looks like an uncuffed tracheostomy to either a cuffed trachea. You can get a cuffed metal tracheostomy tube from that's laser safe from Capatex, I believe. We don't have one, and I would let whoever was involved do what they needed to do from the top end, knowing that she has a tracheostomy already in place and has a safe airway through the front of her neck.
Thank you all. Well, again, out of interest, we did decide to do something. She was felt to be as stable as possible, and in fact, she had we did use a laser and tried to suture some silastic into there because she had a tracheostomy, and at 6 weeks after surgery, she has an impeccable looking airway. The challenge is knowing whether that will stay like that and if and when to remove her tracheostomy. But at the moment, she's doing quite well. I'm just going to move on. So this is a 75-year-old gentleman who in early 2020, so a couple of years ago or 18 months ago, had an early laryngeal cancer treated with radiotherapy. As part of his sort of routine follow-up, he presents with new onset hoarseness and is found to have a left vocal cord palsy. His imaging shows a malignant mass arising probably from within the thyroid, no obvious mucosal abnormality, but wrapping around his esophagus and causing compression of his trachea lower down, such that he presents with noisy breathing. And he's had an FNA of this, which is SCC. So 75-year-old gentleman with some degree of compressive changes from an SCC and involving predominantly the thyroid. Simon, just start with you. I know you've given your airway talk, but when you've got these difficult cases, how do you like the surgeons to approach you? I know you said you're a service in, but having worked with lots of anaesthetists, I also know being surprised on the day isn't always the best plan.
I've had all sorts of approaches. Some have been a text message the evening before saying I have this patient I'd like to add on to tomorrow's list, or we do it in a semi-planned approach where our ENT surgeons might look to see when there's a airway savvy anaesthetist who's able to staff the emergency list if they're adding it on as an urgent case through CPOD. I've had email communications, phone calls, people coming to the department just to ask. Having, just sort of finding these challenges on a list. It's not ideal, but this is a head and neck list. We have these all the time. It's so it's not an inconvenience. It's nice to get a heads up, but this is a head and neck list. This is what we do. So surgeons will often approach us about the more extreme end of things when patients are very compromised, but this seems pretty routine.
You sound like the perfect anaesthetist. Vin, maybe just start with you. What are your thoughts on this in terms of treatment options and, both cure and palliative?
I bet this is squame arising from the larynx and driven out by the previous treatment. It's not a new primary, it's an infield recurrence that's behaving atypically because of treatment in there. I would, in the first instance, because of the way the scan looks like, scan on first instance looks like a thyroid malignancy heading further back, I'd certainly do a core on that mass lesion, run some immuno and molecular tests and ensure it is an SCC and not an anaplastic cancer, because that will change things substantially. Because if it's anaplastic with BRAF mutation, then we're in a different territory completely. But if we can confirm this is the case, it's SCC, I'd certainly get a PET scan done to ensure we haven't got anything low in distally
Kim, any comments from you?
I agree that this is local recurrent disease. And the question is, how are we going to treat him? Are we going to treat him surgically? Can we treat him surgically? Is this surgically resectable disease? And as Vin has highlighted, we'll need to do further assessments, both imaging and EOA assessments to check the extent of involvement, not just in the esophagus, but also the trachea. I think you mentioned the trachea might be involved as well. And that would add another dimension to the surgery. The alternative is to speak to your oncologist and say, look, I know this patient had radiotherapy 18 months ago. Do you think there is anything you could conceivably offer, possibly in a trial setting that might be likely to be palliative, but nonetheless might help with symptomatic control? He's 75. Even if he's a good 75, my oncologist won't give patients standard chemotherapy over the age of 70 because the morbidity outweighs the benefit. So there may be a role for immunotherapy in the context of a trial setting. But the surgery, if that's what is available, is going to be radical, and we'd have to have serious conversations with this chap at his age and his ability to tolerate that extent of surgery.
So I'm just going to move it on a little bit. So he for comorbidity reasons and other reasons was deemed irresectable, and actually was proposed or is proposed for a immunotherapy trial. Coming to you, Ian, do you have any concerns about his airway and managing that while he's on immunotherapy? I'm just thinking rebound, swelling, covering. Obviously, there's a small chance that he gets a meaningful response, but a lesser chance that he might not.
Yeah, more likely he doesn't, and he gets a remarkable response, isn't it, in this setting? And I think the answer in Edinburgh is we don't know. We haven't had very many of them. We have occasionally had, we tell patients that roughly, if there's 6 of them, all at the same stage, 1 of them will get a good response, 2 of them will get a reasonable response, and 3 will get no response from immuno. But you don't get the response immediately. It takes months to develop. And we have had this problem where this patient signs up, they're physiologically fit enough, and you're going here for a local response, but you need to give it a while to achieve it. And what are you going to do? You need to have a plan about what you're going to do if there's rebound and if things deteriorate. And perhaps the right thing to do is nothing, or anticipatory medications. But if he's fit and well, I mean, you mentioned comorbidities, but if we just say he's fit and well and he's fit for immuno, but it's not resectable, and I would agree, without radiation backup, you can't get a margin there. I'd be very reluctant to operate on this guy. Then you might find yourself in a situation where you're treating him palliatively, but you still accept that you do a tracheostomy to control the airway in the hope that he falls into the half who gets some form of benefit. But it's a very difficult decision to make. I think it in part depends on whether you think if he managed his if he got a trachea, would he be able to be independent? Because if the assessment is for example, if he's has bad rheumatoid arthritis or bad eyesight or something that was going to prevent him from being able to manage a tracheostomy, then I think you go into it and you say if things deteriorate irrespective of the cause, we're not going to do anything, because I don't think debulking is realistic in an extrinsic compressive situation like this. And I think thinking about that up front is a good idea.
Ekpemi, what are your experiences of immunotherapy and the speed of onset, and what do you do in the meantime? It's an expensive drug to give.
Yeah, and especially in a patient as old as this 75-year-old patient. I mean, the time to recurrence is not that bad, and it could be much worse. But he has significant disease, and the disease is quite low down in the neck as well. I don't know if you have any other images, but when I look at your images, it looks quite low down and already compressing the esophagus. It would be good to know what the OGD showed and whether or not he has disease in the mucosa, invading the mucosa of the esophagus.
Interestingly, there's no mucosal abnormalities within his esophagus, which is one of the challenges. So it's very hard to know where it stops apart from radiologically.
Yeah, I think, primary thyroid cancer SCCs are rare, and I don't think they do well anyway, no matter what you do for them, unfortunately. So I think that the very real option for this patient is best supportive care. A 75-year-old, he can still eat and drink, I suspect, at the moment, warn him that he will soon stop being able to eat and drink. I don't know whether or not, I don't really like offering tracheostomies to patients like this, because I think it prolongs the inevitable. But I mean, offering him surgery is something that you can do, and I would offer him if I think I could get margins. But the problem is that I can't follow this up with radiotherapy. Certainly, I can't follow him up with chemoradiotherapy, not in a 75-year-old man in my center, and he wouldn't be considered for immunotherapy in this situation in our center. So for him, a real option will be best supportive care and manage him and palliate him.
Thanks. So he has gone down the palliative care route.
One thing to consider, Stuart, might be his previous radiation fields. This looks fairly low, as you rightly said. And if his previous field for T1 glottis was a 5x5, 15, 20, then this could well be outside the fields. And it might be worthwhile considering a short, sharp course of palliative radiation as well in that setting to halt disease progression.
And that's exactly what we're sort of, he's had discussed with him. Right. Slightly different case. This is a 35-year-old lady who has moved to the area. She's got a history of recurrent chest infections that have largely been managed in the community. Multiple admissions to hospital, but mostly seen in A&E, treated with antibiotics. And eventually she has a CT scan of her chest, which is shown in the bottom right-hand corner. And there's a 3D reconstruction there showing a small tracheoesophageal fistula. Kim, I don't know whether you've any experience of these, but if you were presented with this, what would be your approach to treating this?
Phone my cardiothoracic colleague. I'm afraid I have no, I'm sorry, Stu, I have no experience of dealing with these things. I think my cardiothoracic colleagues do, and I would be asking their advice as well, trying to work out, I guess, initially what the cause of this fistula is. So she'll need some endoscopy and plus or minus biopsies. I don't know if we've got any clues in the history of this in this young woman, why she's developed this, or if we think this is congenital and has just been missed for 35 years. But I would imagine, let me guess that my cardiothoracic guys are going to want to go in and try and obviously close it and put something between the trachea and the esophagus. And I think that's about as detailed as I can be, I'm afraid.
So it is thought to be congenital. You know, when you talk to her, she's been coughing and spluttering for a long period of time, and never quite sort of got to the bottom of it. I think she was labelled with asthma at one point. Ekpemi, any thoughts?
Yeah, I love cases like this because it means you're going to collaborate with someone else. So this, I actually think you can manage endoscopically. My upper GI, and I have a couple of upper GI colleagues who are just whizzes with their endoscopes. And in this situation in Adam Brooks, we'll take this patient to theater and we'll use an OGD and use an over the endoscope clip to clip this in the esophagus. We've used it to do a few cases with our patients who have stubborn tracheoesophageal fistulas that are not healing. And actually those are much more difficult because here, you know, there's no post-radiotherapy changes. The mucosa ought to be hopefully pliable. And it's something that you can manage quite well. And hopefully if it goes well, you feed the patient the next day and the patient's home the next day, all being well.
Ian, any comments?
Referral to Cambridge by the sounds of things.
Sounds good. Simon, when you're presenting with someone who's had lots of chest infections, do you like any particular investigations before embarking on any form of treatment, just to know what effect their lungs may have?
Yeah, I guess, you know, every time you have a chest infection, your chest just gets a little bit worse because of any scarring or fibrosis or so having sometimes pulmonary function tests are quite useful, an arterial blood gas, so you know their baseline levels of oxygenation, making sure any time you choose to do an intervention is when they're in a good phase of their diseases. Trying not to do it when they have an active infection unless you actually have to. So we've certainly had some patients who get recurrent infections, and when we find out what their date of surgery is, we sometimes give them prophylactic antibiotics for a week before they come in, optimize their inhalers, their asthma medications, so that when they arrive in hospital, they're as good as they can be. But basically just trying to avoid operations when they're not good, and sometimes that's hard to find a good time, but yeah, that's the crux of it. Choose your moment.
Vin, I'll just come to you. Any comments on that?
Gosh, that's a tough one, Stuart. I was going to ask Mimi what exactly the clip was she was going to use, but I have no experience in this, and I would just send it on to my thoracic and upper GI colleagues after diagnosis. But that's a good call, the diagnosis mind. No, I'm sorry, I have no experience, so I have nothing useful to add.
Epemi, can you just, because I've not come across this over the clip, over the OGD scope, just explain what you're muted.
These are clips that are made from titanium, and actually they've been used for a very long time by the general surgical and gastroenterology teams to manage fistulas in the bowel. I could share a screen, but you know, I don't know if we have time to do that. But essentially, these clips are placed on the end of the endoscope, and the endoscope, as you know, for an OGD has a suction port, and so all you need to do is get that bit of the end of the endoscope onto the esophageal aspect of the fistula, suction the mucosa in, and you deploy the clip. The nice thing about this is that it's obviously lined somewhere adjacent to trachealis. So all of that would just get suctioned, and then you deploy a clip. At the end, the clip actually, you know, people worry about the profile of the clip being hard, being broad, but it isn't. And the patients are usually able to eat and drink quite well after that. It works very well. We'll see how the program goes, and I'll look for some pictures maybe I can show you before we move on.
Sounds like you might be getting a few referrals.
Great.
Okay, I'm just going to move on. 73-year-old male who, coming up to his 5 years of discharge, had chemoradiotherapy actually given for a T3 larynx. And then he's noted to have abnormality running alongside his right vocal cord. A biopsy of this confirms squamous cell carcinoma. He has a background history of osteoarthritis. He's had both knee replacements. He can walk about half a mile, although that's obviously slightly impacted by his arthritis. He stopped smoking 15 years ago. His imaging doesn't show any significant volume of disease, and this is staged as a recurrent or new primary T1 right vocal cord lesion. He does have an anesthetic assessment, which puts him at high risk. And I think my first question, Simon, is we often get these anesthetic assessments, and they're often brief. Any thoughts on how we should interpret and how high risk is generated? I know this wasn't your case, but it's something that comes to us all quite regularly.
Yeah, it's based on the information that you provided. He's he's not in his 80s, he's in his 70s. He's got two knee replacements. He has two knee replacements. In Scotland, if you can walk a quarter of a mile, I would say that's pretty good. So it would be interesting to know where the high risk came from, whether he's got other comorbidities that you haven't told me about. Biggest complications in anesthesia come from heart disease, lung disease. We have risk scoring systems that can utilize these, and they'll include things like whether people are on AF or sinus rhythm, exercise tolerance, degrees of heart failure, but are really, the end of the bed sort of question that is not sort of necessarily what's the echo or what's the ECG is, what is the functional statuses of this patient. And if you can walk a quarter of a mile on the flat without stopping, or get up 2 flights of stairs without stopping, I think that's not too bad. So high risk, obviously different anesthetists have different levels of where they place risk. Some are very conservative, some are very gung-ho, but I can't see where a high risk comes from. And I'm probably sort of sit in the more sensible end of anesthetics where, yes, there's high risk, but if this guy needs something done and understands the risks, and the risk of doing nothing is in itself a risk, then sometimes you have to take on a bit of risk and control that risk as best you can as an anaesthetist in order to progress the patient's journey forward. But I don't think this guy's high risk.
He's obviously from the soft southern part of the country. Vin, what are you going to offer him?
So I'm going to offer him a comprehensive assessment starting from scratch. This is 4.5 years down the line. I know you've given me some issues with hip and knee replacement and so on. I'd want to assess his lung function comprehensively. I'd want to assess his swallowing comprehensively. And once I do all that, I'll take him to theatre. I want to do an endoscopic assessment with narrowband imaging under GA, after the scan has been done, to precisely assess the extent of this lesion, maybe even take some mapping biopsies if appropriate. I would then get him back, have a discussion with him, and after speaking to MDT and anaesthetists, this is clearly not for further radiation therapy, it's for salvage surgery, and just eyeballing that lesion and the scan, I think less than total laryngectomy is very much feasible. If after assessment, the lesion is limited to the mid-cord, then a transoral laser microsurgical resection is entirely appropriate. However, looking at that bottom image, the NBI image, I think there's too much red to the anterior commissure for me. So that worries me slightly. All things being equal, if he's fit and well and his lungs aren't too bad, I know he's had CRT in the past, I'd offer him a supracoracoid laryngectomy, which has predictable, repeatable rehab trajectories and a high chance of obtaining local control and cure, dare I say. If that isn't feasible, then we have to think of other options. But total laryngectomy would be a last resort option in my hands for this man.
I hoped you'd say that. What is it that's going to, in all your investigations, tip you into he could cope with a partial laryngectomy or not?
Is that open partial or transoral?
Well, you're supracricoid, so you've because I agree, it's the MBI. It's actually quite diffuse along that cord. It's certainly up to the anterior commissure. So I guess just in terms of when you see a patient, what is it that tips you to think they can cope and can't cope?
So it's two things mainly. One is, what's his pulmonary function? I go by the 2 flights of stairs as a rule of thumb. And if that is feasible, then I would certainly consider the lung function to be appropriate. We don't go for anything fancier than that. Secondly, swallow. He's had previous CRT. I don't know what a swallow is like. Things could be quite stiff. Did he have IMRT with a constrictor sparing regime or fields, or did he have something else? So these are considerations. If a swallow is quite poor, and after discussion with my speech and language colleagues, if his digest score is bad, PSS is bad, then we would be getting worried in that instance. But if swallowing is decent, 2 flights of stairs, I'd say CRT or not, big guy or not. Some people turn people away from open conservation surgery because they're obese and big. My last open conservation surgery was BMI 46. So let's not discount that for these reasons. Not function.
Kim, what are your thoughts on treatment options?
Yeah, I think in the past, in my junior consultant days, he would have had a salvage total laryngectomy. And I think that remains an option. And I'm very conscious that we're speaking to an international audience who may have varying degrees of access to partial, subtotal, whatever types of non-total laryngectomies. And we have to be aware that these patients may well breathe and swallow afterwards, but they take an awful lot of rehabilitation. So you need a massive multidisciplinary team involved in their care post-operatively. And sometimes you just think, well, they probably would have been better off with a total laryngectomy, get a valve in, get some swallowing and get some valve speech. Bob's your uncle and no more faff. But we are more inclined now to try and be conservative, and some form of partial laryngectomy is an option. I initially wondered about lasering, but if it's as extensive as you're describing, then that would be quite an extensive core out transorally. But again, that is an option for the chap. And I agree with Vin, you have to look at their comorbidities, especially their pulmonary reserve, because that's what's going to get hit hard when they're struggling with their aspiration after your non-total laryngectomy. So yeah, similar thought processes, I think, really, but I don't think there's anything wrong at all with a salvage total laryngectomy.
Stuart, sorry to interrupt. Maybe it's kind of time to wind up.
Yeah.
Thank
you. Just very quickly, Ian, any comments on that?
No, I don't. I think it's been well covered. I don't think I have anything different to add.
And Pemi, I'm just going to give you the final say for this panel discussion.
Nothing more to add. I think it's important.
One of those clicks on the glottis here.
Maybe.
Can I say great cases to it?
Absolutely, great cases. Stuart, I sent you the over the telescope, or I could share my screen, but I wanted to show people just the end of the clip so they can see what it looks like.
Okay. Well, I'm going to stop sharing my screen, and that just brings me time to thank the panel for their fantastic contribution. A big thank you to Jay for organising this amazing conference, and a big thank you to the audience for listening.
Okay, thank you. Stuart and the panelists, I request you to go to the Q&A and you can type the questions, answers for the questions, please. That'll be great. Thank you.
Yeah, so I can't do two things at once, so I haven't answered those during the talk.
Yeah, absolutely. You can do it on your own time now. Thank you, along with the panelists. Thank you.
That's the clip in the endoscope at the end of the endoscope there. And that actually, I don't know if you can see my screen.
Yep, we can.
That metal thing, that's the clip. And that just gets deployed. So it's, but there we go.
Thank you very much, Mimi. Now I request Professor Kimasi to introduce Professor John Fagan and for his talk. Thank you.
Thank you, Jai. Yes, thanks very much, Stuart, for some really difficult cases, but very interesting cases. So thanks for organising all of that, Stuart. That was really good fun. But it's a great pleasure that I have now to welcome to our audience Johan Fagan to deliver an invited lecture entitled Laryngeal Cancer, Airway Emergencies. Johan is currently the chair of otolaryngology at the University of Cape Town in South Africa, and I think it's fair to say he spent most of his career over the last 20 plus years developing education and training for ENT surgeons in Africa and other developing countries. He founded the African Head and Neck Society and has established fellowships for training in the University of Cape Town, specifically for African surgeons. He is very widely published, and I would be surprised if any of us have not come across his open access resources, which are valued and used globally, I think it's fair to say, and for which quite rightly he has received recognition and international awards from IFOS and the American Academy. So without further ado, it gives me great pleasure to introduce Johan to us this afternoon, and I very much look forward to hearing what he has to say. Thank you, Johan.
In this presentation, I will be discussing managing the airway in laryngeal cancer. My name is Johan Fagan, and I'm the head of otolaryngology at the University of Cape Town, and Ross Hofmeyer is an associate professor of anesthesia with a special interest in airway management. At the University of Cape Town, we perform about 40 primary laryngectomies per year for advanced laryngeal and hypopharyngeal cancers, and about 60% of our laryngeal cancers require emergency tracheostomy for stridor. That is, we are performing it every 2 weeks. So we have quite a large experience of such cases. This algorithm outlines our approach to the compromised airway in laryngeal cancer. We start with airway topicalization with nebulized or atomized local anesthetic. We then proceed to endoscopic airway assessment by the surgeon and the anesthetist, so one can chart a roadmap for the intubation. We then have to make a fundamental decision: are we going to proceed straight to an awake surgical airway, or are we going to attempt an awake endoscopy, or are we going to anesthetize the patient and intubate the patient? Should we decide to do an awake endoscopy, then we use a flexible endoscope or the video laryngoscope for an awake tracheal intubation. Should that fail, one then has to convert to an awake surgical airway. Should we decide to anesthetize the patient, then we would breathe the patient down and then proceed to tracheal intubation with direct or video laryngoscopy with or without the use of rigid or flexible endoscopy. Should that fail, then once again you would proceed to do an awake surgical airway. And then one would proceed with the surgery. using balanced anesthesia and an analgesia strategy. And then very importantly, one needs to start planning for a smooth emergence from the anesthetic, anticipating possible airway obstruction, and admit the patient to a post-anesthesia high care unit. Critical question therefore you have to ask right up front is a surgical airway required, or can you try and intubate the patient? And the question to ask is, are you likely to lose the airway on induction of anesthesia? Are you able to intubate the patient should you lose the airway? Are you likely to lose the airway on reversal of anesthesia? And finally, will debulking the tumor protect the compromised airway on reversal of anesthesia? A critical factor to consider when deciding whether to use a surgical airway or intubate is the normal difficult intubation pointers, such as the Lemon score, and very importantly that one should have a preoperative endoscopic airway assessment, so one can describe the tumor, one can determine whether the tumor is involving the base of the tongue, as this can complicate the access to the larynx. You need to be able to describe the laryngeal anatomy to the anaesthetist and also determine whether there's any airway distortion. And the anaesthetist and the surgeon should jointly discuss and agree a best strategy. The surgeon should be present at the operating room table throughout the intubation and extubation, so that he or she can step in to assist with the surgical airway or help with the intubation. And the anaesthetist and surgeon should know each other's abilities, but also their limitations and the potential contributions each can make in terms of intubation and achieving a surgical airway. There are certain red flags which you should highlight. The first is the fibrotic neck. We've all seen patients who've had previous chemoradiation or previous neck dissection where the neck is absolutely rigid and woody hard, and those are really high-risk patients in terms of intubation. Then tumors involving the base of tongue, such as this case here, or the vallecula, that can preclude rotating the epiglottis anteriorly to gain a view of the larynx. Patients where tumors involve the epiglottis or pre-epiglottic space, such as this, can also be difficult because one cannot adequately rotate the epiglottis anteriorly with a blade placed in the vallecula. And then there are patients with so-called dynamic obstruction. This is typically patients such as this with a supraglottic tumor or base of tongue cancer, where when they are anesthetized or when you extubate them, that their tissues collapse inwards and they obstruct their airway. And with patients with cancers of the piriform fossa, one also has to be concerned about the tumor pushing the larynx across to one side, making intubation challenging. And then one has to be concerned about positional airway obstruction. Some patients will obstruct when they lie flat as opposed to sitting up. And then one has to elicit a history of difficult intubation, of trismus, and snoring and obstructive sleep apnea and obesity can point to the possibility of airway obstruction during induction or during reversal of anesthesia. And of course, poor cardiopulmonary reserve, especially ischemic heart disease, can be problematic with a difficult intubation. So securing a difficult airway, there are 3 points I'm going to raise. The one is emergency surgical airway. Second is anesthetizing the non-stridulous patient. And thirdly, a few tips on intubation techniques. So let's look then at the emergency surgical airway. Indications for an emergency surgical airway include significant stridor, hypoxia, hypercapnia, and fatigue, cardiorespiratory comorbidities, inadequate airway monitoring in the ward, when one cannot access the operating room urgently should the patient deteriorate in the ward, and having an inexperienced anesthetist or surgeon that precludes a trial of intubation and extubation. How then do you assess a patient when you're going to do emergency surgical airway? Firstly, you want to, in general, you want to look at the airway, how obstructed they are, do they have stridor, do they have pulsus paradoxus. You want to determine whether they're hypoxic. This might manifest as cyanosis, confusion, or restlessness. You want to check for comorbidities, pulmonary and cardiac we mentioned, and you want to also check their medications. Are they on anticoagulants and are they on sedatives? You want to determine from an anatomical perspective whether the landmarks are palpable in the midline of the neck, the position of the cricoid relative to the sternal notch, because if it's very close to the sternal notch, doing an emergency airway can be very difficult. Airway displacement to the left or the right. A large thyroid can make it very difficult to do the tracheostomy, and prior surgery in the midline of the neck. And once again, you want to check whether there's any positional airway obstruction, which might determine the position you have to do the airway in. The options really to achieve an emergency surgical airway is to intubate the patient, proceed to general anesthesia, and then do a tracheostomy. Or you might need to do an awake tracheostomy under local anesthesia, or in real emergency, a surgical cricothyroidotomy or a needle cricothyrotomy. And all this depends also on the expertise of the anesthetic team and the surgical team. I'm not going to say much about tracheostomy technique. You can read about this in the Open Access Atlas. Suffice it to say that when you're doing an emergency awake tracheostomy under local anesthesia, a chest X-ray is useful, especially in our setting in South Africa where we have a lot of tuberculosis, which can pull the trachea across to one side from scarring. You want to ideally do it in an operating room. The anaesthetist should avoid respiratory depressant sedatives and adapt the anesthetic accordingly. You want to monitor breathing, blood pressure, and pulse oximetry. Positioning, you ideally want to do it supine with the neck extended, but you might have to do it seated. It is more comfortable. You want to identify the cricoid to place the incision. You want to infiltrate with local anesthesia and vasoconstrictor into the skin and surrounding tissues, into the deeper tissues in the midline, and into the tracheal lumen, drawing back to confirm you in the right position. Proceed to the tracheostomy, and then importantly too, once you've done the tracheostomy, observe the patient as correction of hypercapnia and hypoxia may cause loss of the respiratory drive and apnea. Next, needle cricothyrotomy. This is well described in the Open Access Atlas. Needle cricothyrotomy is an emergency temporizing procedure when you cannot intubate the patient, or tracheostomy is too time consuming, or there's no surgeon in the room. One must be aware that the needle lumen diameter does not permit adequate ventilation. Using jet ventilation, one can oxygenate the patient for about 45 minutes. However, when one uses a low pressure self-inflating resuscitation bag, oxygenation becomes ineffective within a minute or so. So one really needs to intubate the patient rapidly thereafter, or perform a formal tracheostomy as soon as possible. And one also needs to know how to connect the needle to the connection piece of an endotracheal tube so one can ventilate the patient, and the techniques on the right are all summarized in the Open Access Atlas. Cricothyroidotomy. This is also an emergency temporizing procedure when you can't intubate, or tracheostomy is too time consuming, or it's a difficult tracheostomy, or there's no surgeon in the room. But there are caveats. You may violate the glottic or subglottic cancer by cutting through it, and you must convert to a formal tracheostomy once the patient has been stabilized. The second issue I want to cover is anesthetizing the non-stridulous patient with cancer of the larynx. Now, indications might include obtaining a biopsy, staging the tumor or mapping the tumor for treatment planning, or to debulk a tumor so that you can safely extubate the patient. But it requires very close teamwork between the otolaryngologist and the anesthetist to jointly predict difficult intubation, predict difficult extubation, and one has to be able to describe a roadmap for the anesthetist in terms of tumor size and site whether the base of tongue is involved, as we mentioned before, whether there's airway distortion, and also whether there's an adequate nasal airway for nasal intubation. The anaesthetist and the otolaryngologist need to jointly discuss and agree on a best airway plan, and they should know each other's abilities, their limitations, and the potential contributions each can make in terms of intubation and creating a surgical airway. There are certain predictors of difficult intubation. We mentioned the Lemon criteria, which is listed on the right side. A history of difficult intubation, very important. We mentioned the fibrotic neck, obstructive sleep apnea, which can become a problem also during extubation, and of course the tumor site and size, which we mentioned previously. Finally, I want to touch on intubation techniques. If one predicts a difficult intubation or an extubation, then one would proceed to an awake tracheal intubation using a flexible endoscope or a video laryngoscope. One should have a range of laryngoscope blades available, and one also has to have the operating laryngoscope, the bronchoscope, and the light source and suction at the ready. And one should prepare for a tracheostomy under local anesthesia should intubation fail. That means one should have tracheostomy instruments, tubes, and the scrub nurse in the room and ready to proceed. And one should prepare the neck by injecting local anesthesia into the skin and the tracheostomy tract as well as the trachea. And the surgeon should be at the operating table throughout the intubation and the extubation to help assess the patient and to intervene and to assist the anaesthetist. The intubation options are: you can use conventional intubation, you can use a video laryngoscopic intubation, which has become almost a standard of care. You can use a flexible or rigid fiber optic or video intubation. And of course, you can use an ENT intubation where you use an operating laryngoscope or a bronchoscope. As far as direct laryngoscopy intubation is concerned, this is of course the standard which is familiar to all anesthetists. The hollow core bougie shown on the right, this is useful because it increases the intubation success rate, and you can oxygenate the patient through the small apertures in the hollow core bougie. And then, of course, there's a trick of the paraglossal approach with the Miller or the straight blade for basal tongue tumors. Video laryngoscopic intubation, the traditional MAC blades are good for most situations. Remember, you need to have an introducer and a suction available. The hyperangulated so-called D blade is excellent for basal tongue or epiglottic tumors. And the reason is that you can place the blade behind the epiglottis right into laryngeal inlet, and you also have an angled view of the vocal cords. And then there's also channel blades shown on the right there, which you can use for fixed neck flexion or soft tissue swelling. When performing awake tracheal intubation, the gold standard is the flexible endoscopic ATI with the video laryngoscope. But in challenging cases, one can use a rigid intubating endoscope shown on the right side, or you might use a dual endoscopy where you use more than one technique simultaneously to gain a view of the larynx and intubate the patient. A few words about ENT intubation with the operating laryngoscope. Most certainly I've salvaged a situation with a number of patients during my career where the airway is lost due to bleeding or to a poor view. The advantage is you get a panoramic view, especially with a larger scope. You can do really good suctioning if there's active bleeding from traumatized tumor. You can pass the scope behind the epiglottis directly into the laryngeal inlet. You can even force the tip of the scope through tumor into the larynx and into the airway. And you can pass an introducer or an endotracheal tube through the laryngoscope directly into the larynx. And the indications are really when the anaesthetist cannot intubate the patient, when there's active hemorrhage and they lose sight of the airway. It's useful for supraglottic tumors or base of tongue tumors to bypass them, and you can, as I said, force the scope right through tumor into the airway. The intubation technique using the operating laryngoscope is that you advance the tip of the scope into the laryngeal inlet as you would with a microlaryngoscopy. You then pass the introducer or the bougie or the endotracheal tube through the scope into the trachea. You then establish ventilation and anesthesia with the scope still in place. Then you remove the connector from the endotracheal tube shown on the right side. And so it's important that you select an endotracheal tube with a removable connector so that the laryngoscope can be removed without removing the endotracheal tube. And note that many armored tubes have fixed connectors, so you must just check on that. And then you retract the laryngoscope, leaving the endotracheal tube in place, replace the connector, and you resume ventilation. And then there are also predictors of a difficult extubation in laryngeal cancer patients. There are the general guidelines in the Difficult Airway Society extubation algorithm on the right side. In head and neck patients, the fibrotic neck from previous chemoradiation or prior neck dissection is a high risk. Patients who are obese or have obstructive sleep apnea should be considered high risk for difficult extubation. And then there are patients with so-called dynamic obstruction. This is typically patients such as this with a supraglottic tumor or base of tongue cancer, where when they are anesthetized or when you extubate them, that their tissues collapse inwards and they obstruct their airway. And then also that group of patients with a fixed obstruction at the level of the glottis or the subglottis, and these are the patients where you need to aggressively debulk the patient tumor so that one can hopefully extubate the patient without any obstruction. To conclude, the management of the compromised airway in laryngeal cancer calls for close teamwork between ENT and anesthesia. It is most certainly not for the inexperienced trainees. One should always undertake a preoperative endoscopic airway assessment, and there should be agreement between ENT and anesthesia about an intubation strategy, about emergency surgical airway strategy, and also an extubation strategy. And the team needs to be prepared for any eventuality and a change in airway strategy, which can happen very quickly and requires prompt action.
Thank you very much for that presentation, Johan. Are you available for any questions, Johan? I haven't seen any on the chat or the Q&A.
I'm right here. I'm right here, yes.
Thank you. Hello, welcome. Hello. And thank you again for that wonderfully pragmatic overview of managing the airway in these difficult cases. You mentioned in your last slide, of course, that it's not for the faint-hearted or the inexperienced trainee managing these difficult cases. And there will be hopefully few, but they still happen situations where the emergency tracheostomy needs to be done. And in fact, it is only an inexperienced trainee who's available. Have you got any top tips that you might want to give the more junior members of our audience that might help them cope with that sort of difficult situation?
I think the important thing is you must be prepared for it, because there's nothing worse than the anesthetist not being able to intubate, and then you start calling for the nurse and the instruments, etc. So that's why I emphasize that in any case where you might lose the airway, you should infiltrate the skin, infiltrate the trachea, have the scrub nurse standing ready, and be all set for it. So I think preparation is absolutely essential. And then the other very important thing is to have a good discussion and a joint strategy with your anesthetist. But I think that's the bottom line. You have to be prepared, and of course you can do a cricothyrotomy, and you can then you can then convert that to a tracheostomy. So so certainly I think that's a good option to consider when you're in a real emergency situation.
Sure. And you're talking about buying some time there by doing the cricothyroidotomy. We had a talk earlier from Simon, one of our anaesthetist colleagues, about using transnasal high flow oxygen. What's your experience with that in your institution?
We haven't been using the high flow in our situation, but certainly we would make certain that the patient is well pre-oxygenated before we start anything. But now in the COVID pandemic, we've all become so aware of the high flow oxygen as a tool, and it's used in our pediatric hospital so routinely. So certainly, I mean, that's a very good tool to use.
I was interested that you advocated the use of a rigid bronchoscope. I have to say I'm a fan personally myself of having the rigid bronchoscope at hand, and that's probably the only time I ever do use it, is to have it available in case the anaesthetist can't intubate and we might be asked to step in and be a little bit more aggressive, perhaps one might say, with the handling of the tissues. Can you tell us a little bit about how you use your bronchoscope in that situation?
I tend to use the rigid ringer-scope. I find with the bronchoscope you sometimes just lose sight of your overall anatomy, and you find yourself going down the esophagus, or and not in that emergency situation. But the advantage of a bronchoscope is you can ventilate through it once you're in the airway, of course. So I favor using a ringer-scope, and use it as you would do for a diagnostic laryngoscopy. But as I pointed out, the advantage is you can forcefully push it into the larynx, which you can't with the anesthetic tools, and then you can intubate right through that. So most certainly, it's got me out of trouble a number of times, and I've got a number of very pleased anaesthetists around me in the hospital, who have bailed out over the years.
Yeah, sure. Thank you for that, Johan. Does anybody from the panel or anybody else have any immediate questions? If not, I don't see any hands jumping up at the moment. Johan, thank you very much for your recording of your presentation and for taking the time to answer our questions and to participate today. And it's very nice to see you.
Well, thank you very much for having me.
Thank you very much. And I would request now Dr. Sudarshan to take over as a radiologist. He's going to give a brief introduction of panel and Dr. Raj Bhatt, and they have their presentations. Thank you.
Thank you, Jay. Yeah, we have next we move on to radiology of head and neck emergency. So we have with us this afternoon two great speakers. Dr. Anu Kamalasanan, who works in Glasgow, and she's a head and neck radiologist. So she's going to concentrate on radiological assessment and diagnosis of head and neck emergency. So she's going to cover the diagnostic bit. And then we have Dr. Raj Bhatt, who's one of my colleagues at 9 Wells Dundee, and who was also on the panel this morning. So he's going to cover the intervention aspect of it.
Jay, are you showing the recording, or do you want me to speak?
No, it will be played.
Okay. And diagnosis of Welcome to Radiological Assessment and Diagnosis of Head and Neck Emergencies. My name is Dr. Anu Kamalasanan. I'm a radiologist in Scotland. I have no conflicts of interest. ENT emergencies are a lot to go through in a matter of 10 minutes. So we will pick a few teaching points that will help you in your day-to-day practice. These are head and neck infections can spread intracranially. They can spread into the mediastinum. So anyone presenting atypically, presenting with abnormal neurology, extremely unwell, or those presenting but not responding to conservative management, they should undergo imaging. Imaging should be to diagnose the primary pathology and also its complications. CT with contrast is ideal. MRI can be kept for imaging complications or problem solving. We have to remember that trauma can obliterate in cross-tissue plane. Infraplatysmal injury is better assessed by imaging if deemed clinically appropriate. Sometimes patients present with airway instability, and once the airway is stabilized, we have to look for the culprit. With that in mind, we'll have a look at few cases that will explain this in detail. Case number 1 is a 20-year-old who presents with left-sided orbital swelling, fever, and a history of rhinorrhea. On examination, they've got a swollen red eye, painful eye movements, diplopia. These are classical presentations for orbital cellulitis. Do they need imaging? Yes, they do need imaging, and with contrast. The reason for needing of imaging is to differentiate between preorbital cellulitis from orbital cellulitis. Now, preorbital cellulitis is inflammation of the soft tissues anterior to the orbital septum. The orbital septum is a thin sheet of fibrous tissue that originates from the orbital rim periosteum, and it blends with the tarsal plates. They're difficult to see on CT, but if you look at the arrow that I've shown here, it is the kind of region of the orbital septum which separates the fat from the orbit, from the fat of eyelids and the orbicularis oculi muscle. In this case, there is a subperiosteal abscess on the left side. There is opacification of the ethmoid sinuses on the left side as well. The subperiosteal abscess is rim enhancing. It causes displacement of the left globe and the left medial recti with no involvement or of the optic nerve. Now, this is somebody who would need drainage of the subperiosteal abscess for treatment, and this can be done in conjunction with the ophthalmologist. Now, sinusitis and orbital cellulitis, they can come with multiple complications as well. One of the complications of sinusitis is intracranial, and you can see in this case there is a extra-axial collection with peripheral rim enhancement. Then they also have a right frontal parenchymal collection or an abscess with peripheral rim enhancement. So intracranial pathology or intracranial complications are also seen in other head and neck infections. For example, of these cases, there is a 34-year-old male presenting with pyrexia, sudden onset confusion, and headache to A&E. On first view, it may feel like this is a neurological or a neurosurgical problem, but on probing, we get a history of otorrhea and otalgia. Now, we also have a younger patient, a 3-year-old one, who presents with pyrexia for a week, 7-day history of oral antibiotics for a ear infection. They've had febrile seizures, but they're still spiking temperatures, confused, and have right-sided torticollis. Now, both of these cases have got otorrhea, but they present and on their with different set of symptoms, and on imaging they have different findings. Now, looking at the first case, this is a sagittal sequence, and in the sagittal sequence you can see there is pneumocephalus, that is air inside the skull, and that is not normal. It can either come from outside where there is trauma, or it can come from the air-containing structures within the skull. So that is the paranasal sinuses or the mastoids. Now, we know in this case, this patient had otorrhea. So when you look at that, you can see that the left side, the mastoids are nice and clean and clear, but on the right side, they've got opacified mastoids. When you look at it in the soft tissue or brain windows, you can see there is asymmetry between the right and the left side. If you look superiorly, the CSF in the extraaxial space are similar on both sides, but when you follow it around, you can see these are all CSF, lower attenuation, and come here and there is something there in the extraaxial space. So you think there is an extraaxial collection. And if you look at the gyri, nice and clean here, and you can see the extraaxial space here, which is not so clearly seen, and which makes you think, is there something going on in the brain itself? Is there some edema of the brain? Do we need to confirm this? Do we need to do any further imaging? It depends on the patient. If the patient is unwell, then yes, we do. And in this case, we went ahead and did an MR, and the MR proved that the patient has a right-sided extraaxial collection, and on post-contrast sequences, you can see there is peripheral limb enhancement. Thankfully, for this patient, they had no cerebritis or evidence of intraparenchymal pathology. Now, as far as the young child goes, they have got a different way or different imaging presentation. What we can see they have is a pre- and retroclival collection. You can see that also in the axial sequences, there's a peripherally rim-enhancing retroclival and preclival collection, which proves that the brain is porous and that the patient will allows for the infection to cross from one side to the other, and also we can see they have got bilateral mastoid opacification, sinus opacification, and also a filling defect in the right cavernous sinus, and suspicious for a cavernous sinus thrombosis. We don't wait and wait for peripheral rim enhancement for children with collection. We assume that they are infected collections as soon as we see collections in children. Now, venous sinus thrombosis happens quite often in children, more often than you would think, especially with head and neck infections. So we have to know to look for them. And this is reiterated by case 2C, where we have a 4-year-old who had 10-day history of otorrhea. They had headaches, and now presenting with a sore neck, lethargy, fever, a new onset of squint, and a left sixth nerve palsy. Now, whenever we have a patient with infection, head and neck infections who present with ophthalmoplegia, we have to think about involvement of the cavernous sinuses. And with that in mind, when we look, we can see, now I haven't taken a picture to show that, but there is left mastoid opacification, there's an extra peripherally rim enhancing extraaxial collection, and there is filling defect in the left cavernous sinus. And when we go inferiorly in the skull base and in the neck, there is a peripherally rim enhancing collection in the paravertebral space, in the parotid space extending into the parapharyngeal space. In the parapharyngeal space, there is no rim enhancement, but it's still thought to be an infected collection. And this patient went on to have a drainage of this. What is cavernous sinus thrombosis? Cavernous sinus is a complex dural venous sinus which lies on either side of the pituitary. It contains locules. It contains the internal carotid artery in the middle. The cavernous sinus also contains the cranial nerve 6, which passes close to the internal carotid artery, and in the middle of the cavernous sinus, making it vulnerable to involvement in the event of cavernous sinus thrombosis. Now, along the lateral wall of the cavernous sinus, you have cranial nerves 3, V1 and V2, and the cranial nerve 4 as well. So when there is involvement of the cavernous sinus in any disease pattern, you will notice they usually have some form of ophthalmoplegia or the other. If you have lateral rectus palsy and Horner's, then cavernous sinus pathology should be foremost in your thought process. What are the other complications for head and neck infections? IJV thrombus. You can have IJV thrombus, and in this first image, there is contrast in the IJV, and then there is no contrast opacification, but at the sigmoid site of the sigmoid, it re-opacifies. Whenever we see IJV thrombus, we look for septic emboli into the lung. You can also have the infections extending outward of its primary site of pathology. So there is a little mastoid collection in the retroauricular region. You can have venous sinus thrombosis, as we talked about. We can also have extracranial, extraaxial collections, intracranial, intraparenchymal abscess formations, and so on. If we don't know about this, then we won't know to look for it. Any mid-phase infections will have run a risk of cavernous sinus thrombosis. Now, case 3 is somebody who fell on a metal pike. When we saw them in the scanner, there was only a tiny little metallic fleck in the submental region. They had a broken jaw. But if you look at the image, this is not to talk about the trauma, but to show the extent of the facial planes and how interconnected they are. You can see that it's gas extending from the level of the skull base all the way to the mediastinum. So the neck spaces are all kind of interconnected, or they can all speak to each other, so to speak. So with that, let's go to the neck spaces. It is beyond the scope of this talk today to speak about the neck spaces in detail, but we divide them into suprahyoid and infrahyoid neck. And in the suprahyoid neck, the most important part that I'm going to talk about today is your parapharyngeal space. And the infrahyoid, the retropharyngeal space extends from the level of the skull base to the mediastinum. The space behind the visceral space and anterior to the prevertebral space is your retropharyngeal space. And there is a fascia called ala fascia, which we can't see on imaging, which divides the retropharyngeal space into two, with the retropharyngeal space proper anteriorly and the danger space as well, which extends all the way to the mediastinum and is a source or a conduit of infection to reach the mediastinum. And what is the parapharyngeal space? Parapharyngeal space is a fat-filled space. It is important because if there's an infection in the parapharyngeal space, then it is a deep space infection, and it can go to other spaces. Okay, and the other importance of the parapharyngeal space is its relation to the surrounding space, that is a masticator, parotid, carotid, prevertebral, pharyngeal mucosal space, and so on and so forth. So any mass lesion in these spaces can distort the parapharyngeal space, and if we don't know the source of the infection in any of these spaces, or the mass in any of these spaces, the distortion will allow us to find that. For example, in the first image, this is the right side of parapharyngeal space is nice and clean, and it's fat filled. On the left, it is abnormal, it is stranded, and it's distorted. It is distorted and pushed to medially and posteriorly. So the lesion is thought to be in the masticator space, which is pushing it in this particular direction. Now, the inferior image shows the right side, left side of parapharyngeal space nice and clean. The right side is barely seen, and it is distorted, and it's pushed anteriorly and medially. So this makes the lesion, or whatever this is, most likely to arise from the deep space, deep parotid space. So once you know which way the parapharyngeal space can move, it gives you an idea of where the original lesion is from. With that in mind, let's look at this case number 4. You can see there is a multiloculated collection in the parotid space, because that is a parotid space, and the contralateral parotid space looks okay. There is an extension of this peripherally rim enhancing collection to the parapharyngeal space on the right, which distorts the oropharynx and pushes it medially. Okay, and you can see that it's extending into multiple neck spaces and into the mediastinum. So it proves it is again going to reiterate that neck infections can go to the mediastinum, and our imaging should extend all the way up, at least till the carina. Case number 5 is somebody who presented acutely unwell with a floor of mouth swelling and a thick swollen tongue. They were somebody who presented as an airway emergency. They needed an emergency tracheostomy, and we tried to drain what felt to be a floor of mouth abscess, but it was still not reducing the swelling. So they went on to have a CT scan, which showed this large floor of mouth collection, and they had collection at the pre-epiglottic space as well. Their tongue was thickened edematous with this collection infiltrating into the tongue muscles as well. So this is somebody who needed emergency airway access, and once they had the airway access, then we went in to find out what needed to be done to treat the problem that gave forth the airway access issue. Now, We have other forms of infections which are maybe not quite as emergency, but needed to be sorted urgently. For example, the submandibular duct calculus. You can see there is a dense calculus in the left submandibular duct with a dilated peripheral enhancing duct extending all the way to the submandibular gland, which in itself is enlarged and inflamed. But if we were going to talk about head and neck infections, we'll be going down a rabbit hole, and that is not the aim of the game here. So we'll come back and reiterate the teaching points that I hope is useful for you. The head and neck infections can spread intracranially, they cross facial planes, and they can spread into the mediastinum. So anybody presenting atypically with abnormal neurology or unwell output of external findings, think complications and image accordingly. Infraplatysmal injuries can benefit from cross-sectional imaging, so think about that. If you cannot see the base of your wound, or if you think the wound is crossing platysma, I know that traditionally you would take them to theatre, to Neck Explorer, and so on and so forth. But think about imaging. If the patient is stable, maybe we can help. Patients with airway compromise may benefit from imaging after you have intervened to save the airway. Hopefully, these are a few points that has been reiterated for you. I'm quite happy to take any questions.
That's great. We have a Raj Bhatt the lecture as well, so we can put lectures, then we can take some questions for whole radiology. Thank you.
Hello, my name's Raj Bhatt. I'm an interventional radiologist. I work in Scotland, in Dundee. So I'm just going to give you a brief overview of the involvement of interventional radiology in head and neck emergencies. Interventional radiology emergencies throughout the body deal with either hemorrhage control or sepsis control. In the head and neck region, sepsis control doesn't really come into play because most of the collections and things like that in the head and neck are dealt with by surgery rather than by percutaneous drainage. So the most important emergency that we might have to deal with, albeit not very common, is hemorrhagic emergency. And the things that we sometimes get involved in are intractable epistaxis, carotid bleed or carotid blowout, trauma bleeding, and sometimes postoperative bleeding. We do sometimes get involved in tumors. They might not always be as an emergency, but sometimes tumors do erode into vessels and bleed torrentially and might become an emergency. So the mainstay of treatment, apart from the carotid blowout, where we use a stent or a stent graft to cover it, is embolization. So embolization, as you're probably all aware, it's a procedure of using various materials like particles, plugs, coils, or sometimes fluids that can be released specifically and targeted through a catheter to block off a target vessel. So it is not a shotgun effect of blasting something with multiple particles from a distance. It's a very selective getting a catheter into the target territory and embolizing quite selectively so that the problem is sorted and try and avoid collateral damage as much as possible. So we use a variety of specialized equipment, but the most important one is the thing in the picture there, which is a high-end interventional imaging C-arm, which essentially is a live X-ray and takes angiographic pictures, similar to what's used in a cardiology cath lab. So what are the materials that are used to embolize? So coils, which are on the left there, are the most common things that are used. Coils are made of either stainless steel or platinum, nowadays mostly of platinum, and they're covered by this helical fluff, which is thrombogenic. So the purpose is to get your catheter or specialized catheter into the vessel that is either bleeding or causing the problem, and then deploying the coil through the catheter in that place. In theory, what it does, it acts like a clip. It's very similar to putting a surgical clip from the outside of the artery. This just goes from the inside. So it does not go and cause tissue damage, but it clips off the artery. It's very useful in bleeding problems where focal artery is bleeding. Now, coils can be either detachable or non-detachable. When you say detachable, it means that sometimes we have more specialized areas like AV fistulas where you don't want the coil to fly off into some dangerous area. So you push the coil out, and when you're sure it's in the right place, then you secondarily detach it with a secondary mechanism. And non-detachable coils, once they go into the catheter, they can't be pulled back. We have to push them out and deploy them. The stuff on the left, these are plugs. So they act like coils. They block the vessel off in a focal point. They go through these catheters, which you have already put into the right place, and just block the vessel off. The plugs can work as a single entity, whereas a coil sometimes you need multiple. And depending on the anatomy of the vessel you're treating, depending on where it is, you can choose which one you want to treat with. The other things that are used for embolization, these are called particles. Particles in this particular instance are made of polyvinyl alcohol. Now, these are showered into a particular territory and they start blocking off capillaries, and they are intended to cause ischemic damage. So they are not used for focal bleeding problems, they're more used for tumors. So you can get a catheter into the main vessel supplying the tumor, put particles in and embolize them. By definition, you can imagine that if the particles, when they're flowing, they come back and they can go into other places. And especially in the head and neck territory, you have to be very, very careful that they don't end up going up internal carotid or various collaterals between the external carotid and internal carotid circulation to end up in the brain causing a stroke. So you can imagine the difference. So particles in the head and neck territory are not used very often, used in very specialized circumstances, mainly by very experienced people. We can use other things which are liquid embolics, like glue. Glue is essentially the same kind of glue that you use to sometimes close a skin wound, but they are injected through a catheter. They're not that user-friendly, but can be used. The same gel foam or cellulose that you use to pack wounds to get hemostasis can be chopped into little pieces, mixed with iodinated contrast, and injected through a catheter to get hemostasis from the inside. And that's sometimes very useful in some emergency situations. It's quite cheap, very effective. So moving on to a few examples of how we can help. The number of times an interventional radiologist is asked to take part in a head and neck situation as an emergency is very few. I would say in our sector maybe about once or twice a year at the most. But in specific circumstances, it can be quite useful. So in this particular case, this patient fell off a ladder and had a distraction injury. Funnily enough, she never had any fracture, but she had this massive expanding hematoma and getting some stridor. So on the CT scan, you can see a large hyperdense soft tissue area, which is a hematoma. And you can see that the airway is being displaced to the other side. So you can imagine that if it becomes bigger and bigger, there might be airway compromise. So that was the pre-contrast scan. So looking at the scan with contrast, when you do it in arterial phase, that's the internal carotid artery. That's a blob of contrast outside an artery. And you can see angulated reformats. You can see the extermination of contrast. That is the thyrocervical trunk. So for some unusual reason, the patient has distracted and pulled the thyrocervical trunk during a fall, ruptured it, and is actively bleeding. So you can imagine that this hematoma is only going to get bigger and going to cause problems. So the options are obviously urgent surgical control in the neck area, which I can imagine might be difficult with an actively bleeding source like that, but obviously possible in highly experienced hands. But in this particular case, we were asked whether we could try and embolize this. So that is us having access into the artery from the right arm, a catheter placed in the subclavian artery, an angiogram performed. So you can see that's a thyrocervical artery, a small branch of it has ruptured, and there's bleeding coming outside. That is the vertebral artery going up there, and that's the carotid artery going there. So you can imagine that's quite dangerous country to some extent. If you're trying to put something in to block it off, it accidentally comes back, it might fly up the carotids and cause a massive stroke. So that's a further angiogram trying to open up the oblique, trying to get an access into it. And that is our microcatheter inside that little bleed. And so what we've done is that we put some coils inside the bleed, and that's a plug used to plug off the artery. So the final angiogram shows normal carotid and vertebral arteries, but the bleed has stopped, and this patient did quite well. The hematoma became stable after the bleed was embolized and did not need evacuation, did not need any airway support after that. The second case I have is a patient with an oral tumor. The patient had an oral tumor involving the base of the tongue, which was deemed to be not operable, but was planned for radiotherapy only. But the patient started bleeding from the base of the tumor quite a bit. And on examination, on oral examination, there was a biggish ulcer and there was a constant ooze coming out of the bottom, which is quite frank red in color. So a CT angiogram was performed, which shows the tumor, and you can see the arteries quite close in it. And it was these two branches, which were likely the lingual arteries, which were heading towards the tumor, which were feeding it. So obviously urgent resection of this massive mass was not an option. So we were asked to see whether we can try and help in this case. So that is the catheter placed in the common carotid artery with an angiogram, which shows the internal carotid and the external carotid branch, and those are the lingual branches going out right there. And now one of the lingual branches cannulated with a microcatheter. So that's the main big catheter, which goes into the bigger arteries, and then a smaller microcatheter goes into smaller arteries. And then you put coils to block off the lingual artery. So there's another branch which is also going very close to the tumor. So that was also cannulated. And you can see these wiggly platinum coils in both arteries. And the final run, there's complete stasis. So the patient did very well after this. The bleeding from the tumor stopped, and the patient continued to have radiotherapy. I think the radiotherapy was palliative, but the bleeding problem stopped, and the patient could have a better quality of life during radiotherapy. Epistaxis is obviously a common problem which can be easily solved in most cases. Anterior epistaxis, obviously, I don't need to tell an audience of head and neck people how to treat that. You've got various kind of ways of treating it. Posterior epistaxis, also we have various ways of treating it. Intractable epistaxis that cannot be stopped by local means. The options then end up being ligation of major supplying vessels of the external carotid artery or the mesenteric artery, anterior abdominal artery, and I've seen in literature that various options of even endoscopic ligations have been discussed and reported. They're all valid options, but embolization of a focal branch is also another option that needs to be considered. In this particular case, this is a picture which we do so rarely that I failed to find examples that I had done about 4 or 5 years ago. So I got some images from a journal. So you can see a focal bleeding point here coming off a branch of, I think it's a coronal artery there, and that's been embolized successfully with a coil and stopped. Important to remember that use coils for bleeding, that will stop the bleeding with very minimal extra damage. Whereas with particles, they might reflux, they might go into internal branches, might cause quite a lot of collateral damage, or might cause facial ulcers. So coils are the way to treat this. Just an example of the nasal angiofibroma, which was causing a lot of bleeding. And was embolized with particles. This is obviously done in experience centers to avoid any reflux going up through collaterals into the brain, and you can see the stasis of blood, and that usually stops the bleeding. So that's the end of my talk. So to summarize, interventional radiology is not used very often in head and neck emergencies, but can be quite crucial in some circumstances, and it's important that head and neck surgeons and head and neck people think about it, think about interventional radiology options, and come and ask an opinion in certain difficult cases. It can be used mainly for hemorrhage control, less likely for sepsis control in the head and neck region. Thank you. Happy to answer any questions. Thanks.
Brilliant.
Thank you, Anu and Raj. I think we are short of time. We have one question. Raj, it's for you. They say, ask, what's the rate of stroke do you give for, when you're dealing with epistaxis?
The number of patients treated interventionally for epistaxis are so small that it's difficult to give an actual number. But if you're treating distally in the external carotid territory with coils, the rate of stroke is very small in that particular case, in epistaxis. It's when you start using particles for tumors, then the rate of stroke is slightly higher.
Okay, there's one more question. Is embolization possible for angiofibroma with blood supply from branches of internal carotid artery?
Yes, it's not impossible. It is always possible. And with these complex tumors, they need to have extensive angiography in the first instance, both in the external and the internal carotid territory, to try and look for what the blood supply is, and need involvement from people who deal with the internal carotid territory, like interventional neuroradiologists as well, before it's treated. It's like an AV malformation in that territory. Yes, it's possible, but it needs proper angiography more often than not with general anesthetic to evaluate that.
Okay. I think, thank you, Raj and Anu. I think we are running to coffee break time, so I think we'll close the session just now.
Brilliant. Thank you very much. Take 10 minutes for a coffee, and I'll be playing a few more reps video. Then we will have 2 more lectures, then followed by a panel. Thank you.
play through, and I can pause wherever I like. I can use these buttons to go by frame. As you can see, the vocal cords moving slowly. I can use this to go slow motion, and I can vary the speed of the slow motion, anything between 1 frame a second and of a maximum of 15 frames a second. Should I wish to view the mucosal wave, we have another function which we can use called montage. I can then size and position my aperture here, so just like framing, and then I'll ask it to create a montage. This now creates a 10 frame sequence, starting hopefully fully closed and all the way through to fully closed again. If I didn't quite get it right, I can use the little wheel on my mouse to walk through the sequence to get it absolutely correct. That we can open 2 exams at once. So if I now open this exam, I have them side by side. So for instance, this could be a pre and post operation, pre and post speech therapy, or pre and post treatment, whatever that might be. This also could be saved onto the report as a side-by-side image. Should you So here we're going to show you D-range expansion, which illuminates the distal image in 3 different steps. So low, medium, high and off. And we're just watch the distal image as it gets brighter. Very useful in the ENT setting when you've got maybe a lot of AP constriction, or maybe even something like an infantile epiglottis, and you want to be looking at the vocal cords. What we're hoping to show you in this small sequence is the series of iScan settings. Here's iScan 1, which will hopefully help you to detect any anomalies in the patient. iScan 2 will now identify the extent and the perimeters of that anomaly, and then as it flicks through into iScan 3, this may give you an idea as to the nature of that anomaly.
Hi, my name is Sam from Pravika. Thank you for the opportunity to be a part of this exciting meeting today. For this short 3-minute session, I'm going to introduce you to Pravika, Silenar, and some of the evidence available to you in treating drooling in children with a neurodisability. Prescribing information for Silenar is available during this session. Pravika is an independent European pharmaceutical company based in Manchester, and we are leaders in the licensing of medicines through the Pediatric Use Marketing Authorization Process, or PUMA. Pravika is committed to developing and licensing medicines specifically for children through age-appropriate formulations containing minimal excipients. In February 2017, Pravika launched its first PUMA licensed product, Silenar, a formulation of glycopyrronium bromide specifically designed for pediatric use for the symptomatic treatment of severe sialorrhea in children aged 3 years and over with neurological disorders. Before the launch of Silenar, most clinicians tended to use the hyoscine patch to manage drooling in the absence of a licensed medication for the pediatric population. While hyoscine is licensed for travel sickness in children over 10, it does not have a license for sialorrhea. The clinical evidence available recommends clinicians move away from the patch and advocate the use of glycopyrronium bromide as the first-line treatment of chronic drooling. The main UK-based study comparing glycopyrronium bromide and hyoscine was conducted by Parr et al. This was a 12-week, multi-center, single-blind, randomized control trial with 90 children with neurodisabilities who had never received medication for drooling. After randomization, the dose of both medications was titrated to achieve optimum symptom control over 4 weeks, then a steady dose was continued to week 12. The results showed both medications were effective at reducing drooling. However, tolerability was a key difference between the two medications, with 82% of patients remaining on glycopyrronium bromide at week 12 compared to only 55% on the hyoscine patch. This was as a result of hyoscine producing more problematic side effects, leading to a greater chance of treatment cessation, leaving the author to conclude glycopyrronium bromide should be the drug of choice. In summary, Silenar is a licensed medication available in the UK that is specifically designed to treat chronic drooling in children and the only glycopyrronium bromide to have been accepted by the SMC. Silenar's concentrated solution allows for less volume to be swallowed. It is also designed to contain minimal excipients and can be administered via a feeding tube. There are also tools available to support its use for clinicians and carers. Thank you very much for your time.
Welcome back after coffee time. So we have lecture from Carlos from Spain. He's going to share his experience, particularly complications related to microvascular reconstruction. Thank you.
Good morning, everyone. My name is Carlos Chiesa-Stoma, and I want to talk today on behalf of me and my colleague, Jose Angel Gonzalez Garcia. We are head and neck surgeons in the reconstructive unit of the otorhinolaryngology head and neck surgery department in Donostia University Hospital, Spain. We are ENT doctors and head and neck surgeons, but we decide to move on in this amazing field, and we really appreciate this invitation to talk about emergencies in head and neck reconstruction today. This is our hospital. Of course, you're welcome here when you want. This is me and my colleague and mentor and friend, Dr. Gonzalez Garcia, doing a fibula free flap, one of our favorite flaps and one of the most amazing microsurgical techniques described for our field, because with this we are able to fix a really difficult and deal with a really difficult situation in the past, like reconstruct the mandible. And of course, everyone loves to see this, like a really nice radial forearm flap for a tongue reconstruction, or a gracilis free flap for facial palsy, or a fibula, and have really nice results doing free flap surgeries. But of course, as the name of this dissertation, sometimes we need to deal with some emergencies, and I think this is a relative term because it's more about complications. But we want to try to summarize this today and try to share some recommendations. We don't have any conflict of interest to disclose, and well, we want to start with emergencies on myocarditis and local flaps. About this, it's important to consider donor site and recipient site in both kind of flaps. Local or myocarditis are also in free flap surgery. We need to consider donor site emergencies or complication and recipient site emergencies or complication. The most common are for sure hematoma, seroma, infection, or suture dehiscence at the donor site, and of course in the recipient site is the partial total flap necrosis, hematoma, seroma, infection for sure, suture dehiscence, fistula formation, or bone exposure. What is the main emergency? For sure, the hematoma is the main one. It's the most difficult. We have active bleeding. We need to fix it. To do this, we need to apply some measures. And the main is the surgical revision in the OR. The other ones are something like more like relative emergencies or complications, because to fix it we need to have patient and we need to fix some things. Here you can see a flap necrosis of the supraclavicular flap in a patient who was operated for a squamous cell carcinoma of the external ear canal, invading the temporal bone. For example, this is a patient with a resection of a oral cavity carcinoma. We use a pectoral major flap because it was a patient with a really hard disease and a lot of comorbidities. And as you can see, the skin of the pectoral major flap at 24 hours after the surgery, it's suffering. This is blood congestion, and this flap, this skin was dead, and we need to remove it. We were lucky because the pectoralis major muscle is really good support for any reconstructions, and we can use a skin just taking the skin from the abdominal skin graft from the abdomen. We can fix this defect. Here you can see another supraclavicular flaps with the partial necrosis of the skin component. We remove the skin in the subcutaneous tissue and use a skin graft. As you can see, as you know, local and regional flaps has a high rate of failure compared with the free flaps. Here's another patient. It's a total laryngectomy, a salvage total laryngectomy. A patient with two radiotherapy for a larynx cancer and an oropharyngeal cancer, and despite we use a pectoral major flap to try to improve the healing in the surgical site, this was not enough. The patient suffered a really hard complication. Of course, this is not an emergency, it's not acute emergency, but the previous one are acute emergencies because our necrosis, and in the first 48 hours you can see it. Here's another patient, another case. You can see that the most difficult situation was this. Was about the necrosis of the pectoral major flap. This is an old patient, or an old woman. This patient needs a revision surgery in the donor side because after the surgery was a bleeding in the breast. It's impossible to know now if the necrosis of the flap was secondary to a bad surgical technique during the elevation of the flap, or was secondary to a necrosis in the revision surgery of the donor site. But this is the result. Then we need to make a backup flap to fix this problem. And here another one. This is a patient that after 24 hours after the surgery, you can see a necrosis of the pectoral major flap. We use a supraclavicular flap for another intention, and this was a pectoralis major flap in all women to fix this, to try to fix this defect. But sometimes the tension, or also in women's, the perforator are not good as in the men's, because the breast generates some anatomical differences. As you can see, this flap is really suffering. The skin is dead, and we need to remove it and put another one there. You can see a video, and when we have a patient, the flap is not good. If we come after the surgery, 24 hours of the next week, and we see this, for sure we have a problem, and we need to fix it. And to try to avoid or to minimize the risk of emergency, we need to take into consideration some points, like the proper flap design, following anatomical landmarks. We need to take into consideration the proper undermining of the donor site, and also in the surgical site, in the recipient site. We need to take into consideration in local flaps skin vectors of tension and relaxation, because we need to consider this to avoid skin necrosis. It's important to perform a delicate flap elevation to try to avoid pedicle traction, because if we track the pedicle, we can generate damage in the adventitia. It goes in favor of thrombosis. And we need to avoid a skin muscle damage, trying to secure with sutures and a skin from the skin to the muscle, And then we can perform every time a skin pinch test to know is the blood is coming to our skin and to our flap. Then it's important to consider the amount of subcutaneous tissue, because the bulky or it can generate an excessive tension, and this can be really bad for the flap. It's important to perform a meticulous hemostasis before closing at the donor site and the recipient site to avoid the problems like I showed you before, because we never know. Using local flaps, if you have a problem in the donor site, your main flap in the recipient site is at risk. And it's always important to consider the nutritional status of our patients, because there's a higher risk of fistula formation in the future. This can be a relative emergency in some kind of patients. Just some statistics. Of course, the pectoralis major flap and latissimus muscular flap are really common. Over complication rate of donor and recipient site is over 30%. Flap loss is rare but can occur. Total flap loss, of course, in pectoralis major muscle, skin loss can be some more common. Donor site exclusive complications are rare, but recipient site exclusive complications are higher, and the same for latissimus dorsi flap. About perioperative complication, remember always the flap design and the surgical technique are the most common issues according to our philosophy. But then you can consider some systemic issues that can make your patient more prone to suffer this complication. Of course, the hematoma is the most dangerous complication. The maximum risk is the first 48 hours. You need always to consider hepatic disorder, coagulopathy, or medication that can increase the risk of bleeding and hematoma. And the risk of infection is really rare, but diabetes, the presence of a severe hematoma, or not be careful with the surgical site can be related with the risk of infection. Then it's important to consider that some patients, this is not an emergency, but always be careful with your patient, because cosmetic issues are important for someone, and sometimes in the postoperative period you can see something like a trapdoor deformity, and you need to know that this can be normal when you use U or C shaped closure for your incisions, or when you left redundant subcutaneous tissue, or the lymphatic drainage is good. And also the hypertrophic scar. Here you can see some. This is not an emergency, but it's a local flap complication, local flap retraction, and we need to fix it with a free flap. And here you can see some patient with a really cosmetic nice result, but it's good from a surgical perspective, but not from a patient's perspective. And sometimes you can fix this with some, for example, liposuction, removing the fat to improve the cosmetic result, like in these cases. Remember, if you suffer an emergency like a bleeding or an hematoma, and despite you can fix it, the flap goes bad, the next step is correct breathing, use antibiotic, and think in your next backup flap, because sometimes this flap is just dead. About emergencies on free flap, this is more important chapter, because this is less common, but are really deal complications. Free flap success is in expert hands, of course, is near or over 95%. But at least 25 patients will have at least a one perioperative complication, and the flap revision success is just 60 to 80%. This is the reason why we need to summarize some key points to avoid or minimize those emergencies. It's important to have to know anatomy, not non-head and neck anatomy. We are talking about anatomy from other sides of the body, like the arm or the leg or the abdomen. And then we need to know, it's important to perform the test to check the vascular status, as the Allen test in the rattle from flap, Doppler, when we use other kind like flaps, like for example the ALT, or for example make an angio CT. Sorry for the mistake. This is in Spanish, not in English. An angio CT for the leg. It's important the proper flap design following anatomical landmarks. It's very important and delicate flap elevation to avoid the pedicle vascular damage in the flap. The microvascular technique is very important. Remember that to have a proper inflow-outflow in the flap, you need 1 to 3 millimeters. The pedicle orientation is really important. You need to avoid traction, kinking, or twisting of your pedicle to avoid thrombosis. And vessel preparation is very important. If you are not careful with the adventition and intravascular clots removal, you can suffer acute thrombosis. And remember to use always heparinized saline irrigation. Then, despite the age is not considered a contraindication, remember that when you cut your vessels, your flap is not anymore in control of the situation. It's all about the systemic condition of the patient, and always take into consideration previous radiotherapy, because your donor side vessels can be your recipient side vessels can be damaged. And of course, the most important thing in this, at least in our case, is a meticulous hemostasis before closing a donor and recipient side, because this can be a really bad complication. For sure, we consider that the best way to avoid any emergencies to have a really to train in the surgical lab. Remember, as in the local flap, for sure, hematoma is the most dangerous complication. Seroma infection and Crohn, suture dehiscence and sensitive or sensorial alteration can be considered emergencies or complications for the patient. But remember, when we deal with dissection for free flap, we have extremities at risk, like the leg or the arm of the patient, or also to generate a iatrogenic malformation if we are not careful. Remember that we have a risk of partial or total flap necrosis. It's acute risk. Hematoma seroma in the recipient site, and now I'm talking about recipient site. The suture dehiscence, fistula formation, bone exposure of osteomyelitis, and flap necrosis. Here, this is a case. This was a radial forearm flap for oral cavity reconstruction. One of the hemoclips in the pedicle was lost. The patient suffered an hemorrhage with an hematoma formation. The flap started to suffer. We see the neck, the increase of the size of the neck and the flap suffering, and we decided to to make a recent surgery, and we found this. This is a big hematoma in all the neck, as you can see. We need this patient suffer a thrombosis of the vein. We need to cut the microvascular suture, use a Fogarty catheter to remove all the thrombus inside the vein, and then make a new microanastomosis. File this. But for example, if you want to check your flap to try to make a proper follow-up during the first 48 or 72 hours, you can use this. Sorry. And if here you can check this generate as Doppler. This is inside the neck. This is inside the neck, as you can see here. Is like as elastic with a detector, and you put over the artery, and it's really good for check the evolution of your flap. Another option, in case you use a radial forearm flap for total injectomy, you can use this. It's like a tutor. This is like you can check here. Sorry for the image. Here you can check if it's bleeding. Remember, red blood slowly. This is good. Good. And then you can use, for example, the Doppler. This is my colleague, Dr. Gonzalez. Here. This is the artery. And here you can make. Sorry. And for example, check, this is the Doppler, post-operative Doppler. This is the vein, artery and vein. And of course, despite you do it everything well, or you try to do it you can suffer a complication like this. This is a cubital arm flap for tongue reconstruction. You see, there's no bleed there. It's a patient. And this is a bad situation, and you have two options: revise or not revise. If you don't revise that flap, this is the result. Of course, this is in your learning curve. It's changing every day. This is an emergency. We decide to wait because we consider, okay, maybe it's just because this part of the skin is not good, but not. Don't try to avoid this. If this is your fault, this is your complication. You need to move on, and this is the result. 48 hours after this is the result. Is a dead flap. In this way, you need to consider another type of complication like this. This is a patient some weeks after a fibula flap surgery. He comes to the emergency room with this. This is a fistula formation just over the surgical plate. Or for example, this is a patient that comes to the clinic because he started to suffer a hypertrophic scar formation in the donor site, the renal foramen flap. And well, remember, in the recipient side, complication can be really important. Remember, monitoring is crucial in the first 72 hours after surgery. External skin monitor is possible. Vascular occlusion, pedicle thrombosis are the main reason of flap failure. The venous failure is the most common. It's more common at least than arterial failure. Hematoma formation, it's common in free flap surgery if you don't perform a proper hemostasis. Recipient vessel failure, it's not common, but remember, sometimes we deal with vessel depleted neck and we need to go, for example, to the internal mammary artery. 50% of flap revision it's need to perform in the first week after surgery in high number in big hospitals, and prompt revision is always mandatory when you perform a free flap, because if you don't do it, your flap just have 10 to 12 hours of ischemia to recover. Then your flap is failed. Here we have another nice surgical result, but during the follow-up, remember, every flap make some retraction, and this is another case. This is a good patient. This is a good result, but the patient don't eat properly, and for us it's not the best. Treatment, in any case, revision surgery always. If you have any doubt, remember, revision surgery, and for sure antibiotic if you consider necessary, and heparin, of course. Finally, our philosophy starts here. A flap failure starts in the OR, not in the war. Is not is your fault. If this fails, it's not any other one. And well, thank you so much for listening to this presentation, and thanks for the organization for invite me, and have a nice day. Thank you.
Thank you very much, Carlos. It's a wonderful talk, and it is. I don't do this kind of operations, but I do rely on plastics. But there is a question in Q&A. Would you mind just type when you have a time? That will be great. Then now we move on to Mr. Ian Nixon's talk, management of kind of carotid blowout, which is a very sensitive topic. Thank you.
Good afternoon. My name's Ian Nixon. I'm one of the ENT consultants in Edinburgh. I've been asked to speak today on carotid blowout. So I'm going to take us through a bit of terminology. We're going to look at predisposing factors, prevention, potential treatment and outcomes. But then I want to spend some time focusing on practical considerations, some clinical scenarios, and then summarize. So when we talk about carotid blowout, or as it's called in the literature, carotid blowout syndrome, we're talking about the result of necrosis of arterial wall in head and neck patients. generally they're head and neck cancer patients. Don't have to be, but generally will be. And it can come from the internal or the external artery. And of course, the branches of the external artery is actually quite a common source. Now, there are different types of carotid blowout: a threatened, an impending, or an actual carotid hemorrhage, something called an active blowout. And a type 1 or threatened is where the carotid is seen to be exposed either clinically on examination or on cross-sectional imaging. Impending is where sentinel bleeding episodes happen, and this is the classic prior to a major bleed. And obviously, active bleeding is where it's a rapidly fatal, large hemorrhagic event. So again, depends on how you categorize it, but the majority of carotid blowouts are said to be active. Very few are so-called threatened, where you notice it on imaging, but impending, 20% present with sentinel bleeds. And you have an opportunity to think about how to manage those rather than having to be swift with a type 3 carotid hemorrhage. So how often do we see it? It's pretty rare, and I think it depends a little bit on the scope of practice, but it's said to be up to 5% of patients who undergo a major head and neck oncological surgery are going to be at risk of this complication. That rises to 20% in patients who have previously been irradiated. Now, although that's true in studies that have looked at it, I have to say that seems a little high in my experience. And it's more commonly a kind of end-of-life event in the kind of scope of practice I see. But if you look at the literature, which is flawed, up to a fifth of patients who have previously been irradiated and undergo a major procedure are at risk of this. So what predisposing factors can we identify? Well, the end point, as we say, is necrosis of the wall of the great vessels. Radiation causes damage to the vasa vasorum. There is obliteration of the small vessels that supply the wall of the arteries, and that therefore places those patients at higher risk of blowout. Radical neck dissection devascularizes the arterial wall and again places patients at higher risk. That's certainly thought to be true in comparison to, say, selective neck dissection, although it's, as you can imagine, not conclusively been proven. If you get a bacterial infection, so an abscess in the neck or a postoperative wound infection, or indeed a fistula where salivary contents is present in the neck, that can cause thrombosis within the vasa vasorum, and again, the same end outcome is seen. And so if you look for these factors in groups of patients who had carotid blowout, it's very common that there is an infective element or they have a fistula, and it leads also to soft tissue necrosis. If you treat patients with high levels of carotid involvement, it's said to be over 180 degrees, and there you're thinking, stripping an artery of its vascular supply by carving a tumor off it, places patients at higher risk. And if patients have active ulceration, either of the skin or internally, those patients are at higher risk because of the proximity of the mucosal and skin surfaces to the great vessels. It's worth mentioning that patients who are re-irradiated are at a much higher risk. We don't do that very much in the UK, but those patients who are re-irradiated are said to be at extremely high risk of blowout because of the cumulative effects of the high doses of radiation. So can you prevent it? Well, it's controversial. Clearly, you want to avoid infections, you want to avoid fistula. And one way you might do that is bringing in local muscular flaps. Sternomastoid flaps over the great vessels were popular at one point, but there's not very much evidence that they help. Free flaps have been shown to reduce fistula rates, so presumably they reduce the incidence of blowout, but it's again not been really proven. So there's a suggestion that by bringing healthy tissue into the field, particularly in the previously irradiated setting, is beneficial. So if someone presents with a carotid blowout, what are you going to do? Well, a type 1, we said, threatened, is identified on CT many times. So you've already done the investigations. Whereas a type 3, really there's no time for investigation because the patient is actively bleeding and maybe bleeding heavily. And so it's only the type 2 presentation where patients have had intermittent bleed where you might have time to stop. And generally you get cross-sectional imaging, CT angiography, that seem to be the mainstream these days, to allow you to identify the source of bleeding and make a treatment plan. When you're considering your treatment options, there's the option of open ligation. Endovascular approaches with interventional radiology are potentially available depending on where you work. But one of the main treatment approaches in real life is best supportive care. So if we think first of all about open ligation, by this I mean opening the neck, finding the bleeding source and tying it off. It's going to be most appropriate in a post-surgical patient. So you take the example of someone who's had a glossectomy neck dissection and they have some bleeding from the neck and a fistula. Well, you're going to need to sort the fistula out anyway. So likely they have a neck infection and quite likely they have an external carotid source. And so quite easy to go in and tie that off. But if you go and tie the common carotid off, there are high rates of neurological complications, as you can imagine. There's no time for things like balloon testing in that setting. So it's most appropriate, as I say, for these post-operative patients and least appropriate for patients who have residual malignant disease encasing arteries, because in practice, it's very difficult then to manage that patient, particularly in the re-irradiation setting. Their necks will be difficult to deal with, difficult to operate on. But in a situation where there's no interventional radiology support, that may be your only option. So it depends a little bit on your resources available. What about endovascular options? Well, this has certainly become the mainstream over the last 20 years in centres that can offer it. But you can only offer it if you have the expertise available. And indeed, if you look in Edinburgh, we do have these available, but the guys who do it are not on call overnight. So it has to be during the day, and that's obviously less than half of the 24-hour period. Overall, they've shown improved outcomes versus open ligation, but again, you can imagine the evidence is retrospective. It's not great. If they're used for type 1 and 2 settings, one option is you can balloon occlude the carotid system, and you can then tell whether the patient is going to tolerate that. And that can be a good option if they have a decent circle of Willis. Of course, most of our patients are smokers and don't have that. And so you're left with two choices. You can embolize, by that we mean occlude, and you occlude vessels, but there's the risk of neurological complications. Or you can use covered stents that really try to block the hole but keep the blood running. And as you can imagine, if you block things off, there's higher rates of neurological complications. And if you just cover the artery, well, the actual disease process is unchanged and blood is still flowing, so there's higher rates of rebleeding. And so it really depends on where exactly the bleeding is coming from, and if it's coming from the common or internal carotid and the patient doesn't manage a balloon occlusion, then really a covered stent's your only option. What about outcomes? Well, it's the mortality range is variable within the literature, from low rates at 15% right to 100%. And it depends on things like if you account pre-hospital bleeds, which is almost impossible to survive a type 3 carotid blowout in the community. But there's definitely significant morbidity. At least 20% of patients who have a blowout have permanent neurological sequelae. In fact, only a third don't have any long-term side effects. And the duration of hypotension is the most significant predictor of morbidity. Because, of course, it isn't the fact that they blow out that kills them. What kills them is the cerebral ischemia that results from the event and leaves them with so many of them with neurological problems. So what about best supportive care? I said that's often going to be the treatment of choice for these patients, but you can't just rush into it. You need to explain the situation to the patient and family. Ideally, you do this before an event happens. So identifying patients at risk, identifying those with sentinel bleeds, and being clear and kind in your explanation of what is going to be a very frightening event for a patient and family is critical. You need to discuss the options. You can use anxiolytics, pain relief, and basic things like towels to try and minimize the horror of the event, as well as expectation management, so it doesn't shock the family too much. You can warn them what's going to happen. And one thing that's critical is documentation of discussions, because what you really don't want to do is a patient to have made a sensible decision that they would like best supportive care, and then for them to be aggressively resuscitated and operated on potentially against their wishes. So it's important that information is shared across the team. So I want to just turn to practical considerations, because what I've talked about there is a kind of theoretical framework for an approach to managing blowouts. But really, you're going to be constrained by what experience you have, what resources are available to you. If you are in a hospice setting, you may have no resources other than anxiolytics, morphine and midazolam, and towels. Whereas if you're in a large tertiary center, you may have interventional radiology, general anesthesia, anesthetics, and so on. So it will depend on the situation you find yourself in. It obviously depends on the type of blowout. You have more time in type 1 and type 2 setting to get investigations. It depends on the disease state and the trajectory. If a patient is riddled with metastasis, there may not be much point in being aggressive. It depends on the patient condition. A moribund patient with a blowout, it may be the kindest thing to do nothing. Whereas somebody with a great performance status, you may be more aggressive. You've got to consider the treatment aim. Some patients will be on a curative pathway after major surgery. Some patients will be palliative. Some will be palliative but have reasonable options. And you've got to think about that too. But overall, you've got to consider the patient wishes. And that's critical, so that patients are identified early and wishes clearly documented and discussed with the family and communicated to the wider healthcare team. So in the last few minutes, I just talked about some examples. So a 79-year-old male with a local regionally advanced hypopharyngeal cancer that's metastatic to the lungs is on a treatment pathway which is palliative, has no access for enteral nutrition, performance status 3, but being managed in a side room, and the nurses start to report that he's coughing up a significant amount of blood in his saliva. So I look at that and think that realistically, that's a patient has a very short lifespan ahead of him, particularly given the fact they have distant metastasis, they can't swallow at all. And really, this patient's going to live for a number of days, possibly weeks at worst. And so in practice, I think the right approach here is best supportive care. His performance status is poor, he has advanced disease, and his short-term outcome is extremely poor. So I don't think it would be appropriate being heroic in that situation. In contrast, we take a 59-year-old male who's had a total laryngectomy with primary closure for a local regionally advanced cancer, which still has a curative option. He developed a salivary fistula during his recovery, which has been managed conservatively, but suddenly there's blood seen coming from the fistula output. Well, I think this is a very different example. This patient has a surgical complication, there's bleeding, and they have a good performance status, presumably following laryngectomy. So I think there's time at this, if this patient can be managed, a CT angiogram would be useful to identify the source of bleeding, and then consider surgical intervention. You can address the site of hemorrhage, you can cover the area with a pectoralis major flap, and they're going to go on to need radiation treatment if they want to stay on a curative pathway. And so in practice, managing these complications to get them to that in a timely fashion would be reasonable. So I think in this example, we're going to be more aggressive, and we're probably not going to go for an endovascular approach, because there's surgical things you can do that address more than just the bleeding. This, I think, is a complex one. A 60-year-old female presents 2 years after chemoradiation for local regionally advanced P16 negative squamous carcinoma of the oropharynx with an initial complete response, but now a recurrent neck mass. On CT, there's disease encasing the carotid and communicating with the skin. Overall, the patient's performance status 1, and a decision has previously been made to commence immunotherapy. 1 month following the first cycle, sentinel bleeding is noticed from the skin at the level of the carotid bifurcation. Now, this is a very difficult problem because the patient has a recurrent disease. They are likely to not live long. The P16 negative, which is a poor prognostic sign, but they're well enough to have immunotherapy. And about a fifth of patients, 5% of patients will have a significantly good result with immunotherapy. And obviously the team treating them made that decision, and the patients made the decision that they want to go ahead with that. So it's complicated. They're being managed palliatively. They're fit. A small percentage of patients go on to have a good response, but the majority don't. I think the carotid encasement's a poor prognostic sign. It's very unlikely this patient has a surgical option. They've had chemo rays, they've got recurrent disease in the neck. Opening that neck is not going to be a good idea. You'll never manage to control the bleeding and control the disease. So in this situation, it's important an individualized decision has got to be made between the patient, the oncologist, and realistically interventional radiology, because if you're going to do something here, it will have to be endovascular. So this is very complex, and I think immunotherapy presents this difficulty where patients are palliative, and previously we would have said there's nothing you can do, and this patient would be the same as our first example. But now these are fit patients with options, and it makes management of end-stage disease extremely complicated. So carotid blowouts are the gravest of complications in head and neck management. It's very important to identify patients at risk. Communication between clinicians, the patients, and the wider team managing them is critical. Clear documentation has to be used so that patients' wishes can be respected. You've got to balance factors related to resources available, the overall patient condition, and the tumor stage and progression. Short-term outcomes are poor, but long-term outcomes in this setting are terrible. It's important to be realistic with patients and families, and above all, respect their wishes. And many patients will not want to undergo major procedures in an attempt to control the inevitable demise. So I hope that's a useful thoughts about carotid blowout, and I look forward to questions.
Thank you very much, Ian. That's really wonderful talk. And if there is any questions, please write it in Q&A. Ian can type the answers. Now, I would like to invite Mr. Omar Hilmi. He's going to share a panel, which is a very important and common emergencies in ENT. Omar, over to you for next 40 minutes. We are just running 2 to 3 minutes late, so still you have 40 minutes. Thank you.
Excellent. Jay, thank you very much. Just let me organize to share my screen. So we're very fortunate today to have an excellent panel here. Can you see the screen okay?
Yes.
Good. So may I introduce your panel who are going to talk about emergencies in head and neck, the pharynx and esophagus. On the first hand, we have Professor Qureshi from down in Darlington. Good to see you again, Q. Next, we have Miss Sumaya Siddiq from Birmingham. And joining us, I believe, is going to be Mr. Pradeep Patel, who is an upper GI surgeon based in Ninemwells Hospital in Dundee. Is he there?
I think he will join. I think he's in the middle of the operation, I think.
Okay, okay. So, first case, we have a patient. He's been out. He's pleased his football team won. He's been out with his mates. He's a non-smoker, but he decided to have a bit of a competition. They went to the local steakhouse and he reckoned he could eat a steak in one go. And his mate said if he could do that, they'd pay for the entire meal. He's come in, he's got complete dysphagia to solids and liquids after attempting to do this. There's no airway compromise. He's otherwise well. Qureshi, what's your thoughts on this case and what are you going to do?
Well, you've given a history of a boneless bolus. So if the patient has got no immediate acute symptoms, I would assess first, and then we'd see whether we need to intervene. And then the question that you've put up on the screen, medical treatment or surgical management. Now, traditionally, we all go down the route of Bascopan and diazepam and historically even papain. There is no evidence that is better than just spontaneously the bolus passes. So I would prepare for an endoscopy within 24 hours if the bolus doesn't go down. That would be my plan.
Okay, and how long are you going to wait?
Well, like I said, within 24 hours, if I can arrange it today, later in the day or whatever, I might do it. But I would try not to go beyond this sort of time frame. Because some of the literature which is available, and there's not a lot of randomized trials and stuff, show that between 60 to 80% will go down with or without any medications.
Absolutely. Ms. Sadiq, any thoughts?
Yes, I mean, I'd have to agree in terms of timing of intervention. So within 24 hours. In regards to medical treatments, there was a Cochrane database review published in 2020, which showed very clearly there is no clear evidence for any of the medical interventions that we prescribe to date. And I used to do it as a registrar. I don't as a consultant, but it's one of those things you did as a knee-jerk response to food boluses. And I think in regards to surgical management, it very, from my perspective, depending on obviously unit, but in my unit, in a young chap like this, you don't know where that bolus is, and it's probably quite low in the view of the fact that they don't have any overt signs of any upper airway distress or drooling, etc. And I'd like to do a procedure which is both therapeutic as well as diagnostic. So I'd push him more towards the route of a flexible esophagoscopy for that food bolus rather than a rigid, knowing that I may not reach the limit with the distal end of the esophagoscope, and it'd be probably more traumatic.
You've stolen things away, because I was going to say, how are you going to do it? So you'd go for the flexible?
I would go for the flexible. I think if it's a high food bolus at the level of the cricopharyngeus, you've got a lot of drooling, respiratory compromise. That is an area that the gastroenterologist will always struggle with. So a rigid for that area is probably more suitable. But otherwise, I would always put food boluses towards a flexible approach.
Okay. And would you do that yourself, or do you do just rigid?
Just rigid myself. We've got a very good service with the gastroenterologist in terms of obtaining the service within 24 hours for food bolus removal.
That's very good. That's very good. Qureshi, do you have any experience with using flexible esophagoscopy in this situation?
I'm afraid we've been spoiled by upper GI, and I fully agree with Somya that if it's a higher bolus with symptoms of aspiration and coughing, I'd be more inclined to do a rigid. Otherwise, no, I haven't done one myself, a flexible one. And if it's lower, it would be the best thing to do. One point I want to make, I know this patient is 28 and he probably has no other medical history. It is very important for people who will be doing fiber optic flexible endoscopy to have a clear idea about any history of, say, hiatus hernia or eosinophilic esophagitis and stuff like that, because they'll have to be a bit careful if they're going to push the bolus down.
This is what I was going to ask. I mean, with the fiber optic scope, obviously they sometimes do push the bolus down into the stomach and alleviate it that way. If you were going to go for a rigid scope, if you did feel it was in the post-cricoid region, any specific concerns in that territory that you'd have? What level would you bottle out at with the rigid scope?
Difficult to say, but I mean, most often it's usually stuck at the cricopharyngeus area. And it is said that there's a physiological weakness in that area where the striated muscle and the smooth muscles meet. So that's where you usually get stuck. I mean, many that I've done is you try and take it out. You've taken half of it out piecemeal and then to push the rest of it down, and it passes away. That's what happens.
Okay. And Mr. Sadiq, say you do feel it's in the post-cricoid region, you go in there, you take it out, the patient's anesthetized, the muscle relaxant's down, you get there and it's disappeared. What would you do? Would you chase it down to the bottom, or?
No, I think you'd go as far as you can in terms of the length of your esophagoscope, and it's about 25 odd centimeters or so from your upper incisors. I think you're running into danger territory if you're just going to go beyond that point. You can get longer rigid esophagoscopes, but you're going to risk there's a potential high risk of perforation. If you can, with your gastroenterologist at that point with the patient asleep, get a flexible done so you can look at the rest of the esophagus into the stomach to make sure it's gone past the gastroesophageal junction, because that's the other point of narrowing where you're potentially concerned that it may still be sitting. But I think, you know, the rigid esophagoscope limits on length are, I think, the crucial thing, and the natural narrowing with being the aortic arch and then the left bronchi, branch of the left bronchi from the carina, and then this gastroesophageal junction. Usually the aortic arch is sort of the limit of the rigid esophagoscopes. Beyond that, I think you've just got to be sensible about excluding the bolus further down with a flexible approach.
Yeah, I definitely agree with that. I'm sure you do, Qureshi, that beyond about 25 centimetres, it's getting to be a bit of a circus act, and we're better off handing over to either upper GI or gastroenterology. I was going to push this further with our colleague from upper GI and ask him what he would do if it was stuck at the OG junction, if he'd approach it through the stomach, going through the abdomen to get them out, which they have sometimes recorded, but we haven't got that benefit, so I think we'll move on. So similar presentation now, only we've got a 68-year-old lady. She's got moderate dementia. As you can see, she's a nursing home resident, and they've just noticed that she's refusing to eat any solids, and she's been complaining about a sore throat for about 3 or 4 days. And they just commented in the background that, oh yeah, we seem to have lost her denture at the same time. And they're wondering if the two could be linked. So she's been seen in the emergency department, and they've got this this X-ray, and they say sort of came to us, and we can't find a problem with this, but the radiologist seems to be getting a bit excited. Qureshi.
Right. Well, this is a completely different scenario from the previous one, and we need to be a bit more keen to intervene, which would start with assessment of the patient. So have we landed a patient who's already got a complication, i.e. crepitus in the neck? So we do a good assessment first. We do an X-ray. If there is any suspicion of a complication, a contrast-enhanced CT scan would be in order to do. My aim would be to try and intervene, if there's no complications, to try and intervene as soon as possible. And you're talking of hours. And if there are complications, obviously we have to then assess what it is and where it is, and if possible, identify if there's a tear, where it is. So yeah, it has to come out as soon as possible.
Ms. Sadiq, anything on top of that?
So you can see on the lateral soft tissue, you've got loss of lordosis. You can see the esophagus, the upper cervical esophagus, which we shouldn't normally see on a lateral film. And then you've got some radiolucency within that. So, you know, until proven otherwise, in view of the history and obviously lost denture, you know, lady with dementia, there's a denture there. And so plain chest X-ray would be appropriate, but the crucial thing is determining whether you've got a potential perforation. And if there's a high suspicion clinically of that, in terms of when you examine the neck or any in terms of early sepsis markers, then definitely you would need a CT contrast imaging of neck and chest to ensure what you're potentially going to be dealing with when you go in with a rigid esophagoscope to have a look. And again, emergent management, you know, as soon as possible. You don't want to leave this too long because you'll get a frank perforation and subsequent sequelae.
Yeah, no. How long do you reckon we can leave a case like this?
You can't really. I think you've got a lady with dementia, so the usual feedback that you'll get from the patient will be extremely limited. You'll be going very much on clinical signs and symptoms. So as soon as you get the appropriate imaging, you want to be proceeding to theatre to remove that denture. You've got to remember it's going to have either a clasp or it's going to have very sharp acrylic edges to it, and more likely to cause a potential perforation of the esophagus.
Yeah, no, give me a full denture any day. Partial plates are horrible. Qureshi, do you anticipate, I mean, clearly, do you think this could be removed flexibly with a flexible esophagoscope? Or would you take this out yourself?
I would take it out myself. I get a better view, and it's usually quite high. So, I mean, the flexible endoscopy in a very high foreign body is a difficult task anyway. and with a rigid endoscope and having a big view, because if it's stuck, sometimes you may have to use a shear to cut it and take it out in pieces. And as Soumya has just pointed out, the edges, the wire, all these things have to be identified and taken out, assuming there's not a perforation already.
You mentioned the shears. Have you used them recently, and did they work?
I've used them once in my consultant career.
How long ago was that?
About 10 years ago.
About 10 years ago.
Because let's also add that these foreign bodies are not often seen. Okay, so the occasion I had it, I just felt that there was too much tension to take it out. I had a good view. I went in class, and I did manage to divide. I got both the pieces out.
Well done.
Direct vision.
Mr. Siddique, have you used the shears?
Yes, I've used them twice, one unsuccessfully and one did work, but it was very much, I had to use it multiple times to try and break off the clasp and also one of the sharp acrylic edges. It does take time, it is not easy. And I think it's more the fact that the leverage and the length of the beak is quite small, so you actually can't necessarily go through a reasonable distance. So you're literally nibbling away at it to a point where you can get safely small aspects of that foreign body within the distal end of the esophagoscope, so you can bring it out safely.
Do either of you have any top tips about how to use the shears? I must admit mine is to make sure it goes down the esophagoscope, because they don't go down all of them. Agreed. How about yourself?
Agreed. And the problem with this is it's a balance between, you want the largest esophagoscope that you can safely introduce down, so that you can actually bring the foreign body within it. But at the same time, like you say, large enough also to introduce some of these larger shears. And then you end up occluding your view sometimes, because you're trying to grasp the foreign body, but at the same time, it's partially occluding the lumen of the esophagoscope.
Definitely. No, not an easy situation. And these are the sort of things that can progress on to perforation. If you were worried that you'd created a perforation at the time of removal of this, how would you approach that, Qureshi?
Right. There's certain steps that you need to take at the time when you're there. So I would try and get an NG tube down. I'd put the patient on broad spectrum antibiotics and PPIs. And obviously the patient would need to be very closely nursed to make sure that we are not progressing, and keep an eye on the nutrition. Basically, that would be my immediate first line of management.
Okay. If you saw an obvious perforation in the cervical esophagus when you were doing this, would you go for a primary repair, or would you go for conservative? To both of you?
Yeah, it would depend on how big it is. It would be very tempting to leave it if it was less than 2 centimeters. If it's very high, leave a tube down and observe. But at the same time, if you've got expertise around, on a small tear, you can put clips.
Okay. Is that endoscopic or open?
Endoscopic. I haven't got any experience of that.
Okay. Ms. Siddique, is that something that you've experienced of?
Yeah, I think it depends where the perforation is, how high it is and how accessible it is. And if it is accessible, I would try and primary repair that. And yes, clips. I have had gastroenterology come in and support me once, where they used the flexible esophagoscope and used clips. It was slightly more inferior than where I could reach with microlaryngeal instruments, and so they put a clip in over their laceration. I think if you can, it's advisable to. Otherwise, as mentioned earlier, you're observing that patient very closely and a low threshold to take them back to theatre if they develop sepsis.
Yeah, absolutely. And if this case started to migrate distally when you were removing it, and ended up just above the OG junction, who would you call? Cardiothoracics or general?
Just above the gastroesophageal junction, you said?
Yeah.
it would be general for me at that point.
Qureshi?
Same.
Same. Okay. I thought we were having a general surgeon with us today to be able to discuss this with us, but we'll move on. Okay. So we've gone through all that. And the distal esophageal tear, well, we can't discuss that with them. Next case, 75-year-old lady. She's non-smoker. She's in for routine elective surgery. She's got a history of recurrent chest infections, regurgitation. We know she's got a pharyngeal pouch, and you've got her in for stapling of the pouch. Or would you? Would you do a stapling or would you do an open procedure? Ms. Sadiq?
So, I mean, this is multifactorially based in terms of which approach. Obviously, her age, comorbidities, and the size of the pouch, and also the ability in terms of her neck extension, if she's got kyphosis or prominent osteophytes, and mouth opening, will determine which way you're going to do, whether it's going to be an open or a endoscopic, rigid or flexible approach. And I think those details need to be very much included in that in the decision making towards an open versus an endoscopic. I've grown up in the era of predominantly endoscopic approach. I have done open approaches during my training, and I think it's a balance in terms of the comorbidities of the patient and the accessibility. The data on this is very disparate in the sense that when patients say they have improved symptoms, but yet they have a radiological recurrence, it doesn't necessarily always correlate that that is a failure. I mean, it's more based on what the symptoms of that patient is. And so I think the data sets on open being better in the sense that recurrence is less so has to be taken with that in mind. So I would go with an endoscopic approach, stapling approach for this, as long as the pouch wasn't too large. If it was over 5 centimeters and you're looking at double layer stapling, which probably has increased risk of perforation, then you might be counseling her for an open approach if she's fit for it.
Mm-hmm. Qureshi, anything to add?
Only to say that don't do a barium swallow after you do your stapling.
Yeah, I think it was Kim RC and Farhan Hassan did a paper on that a few years ago and showed that they're all still there and the radiologists tell us we failed. But as Ms. Sadiq said, it's dependent on the symptoms, not the radiology. Okay, so this lady unusually actually had a full set of teeth. It used to be easy in the old days with these pharyngeal pouches. They were all edentulous and you could get in there easy, but she did have a full set of teeth, but she had good neck extension. So you've got her in, you've decided to try for a stapling first, and we get in there, and this is the appearance. The stapling's been done, but there's something seems to have gone wrong. We can see the esophagus here, but there's a sucker here, and there seems to be a hole. What are your thoughts, Qureshi?
Right. I haven't got much experience of the stapling of these pouches, but my thought would be we have to deal with it ASAP, right? So if we have the expertise to deal with it as we are looking at it, then we can do it endoscopically. I think Vin Polari has written a paper about his experience on it, but that's not many. But if you don't have the expertise, I would open the neck and repair it.
Okay. So open the neck. What side of the neck would you open up on to get access to this by choice?
By choice, left side.
Yeah. Just a bit more access between the nerves coming up. You're less likely to prang the recurrent angial nerve on the left, supposedly. Ms. Sadiq, any thoughts?
Yeah, I mean, as with all of these things, prevention is better than cure. And I think the key is when you're placing the stapling device is just with your 0 degree endoscope, really being careful where the inferior extent is of your staple. Mm-hmm. Bearing in mind that when you do engage the stapling device, there's a pull-up of the party wall. And so these are some of the results of why you might end up with a tear. And I've been in a situation like this myself, and I have repaired it through endoscopically, because it usually is a small tear, so you can do it endoscopically in place for vicral sutures, and then put an NG tube down, put them on antibiotics, see how they go for the next 48, 72 hours. And because that's a lost opportunity. And I think in a 75-year-old to go straight to an open repair, I personally would try this first and then see how she is in the next few, in the next day or so. And obviously then if I do need to go back in, then I know, it's going to be an open approach.
Okay. And neither of you feel that a conservative approach, or, well, they say conservative, of just putting a nasogastric tube down and putting a nil by mouth and antibiotics, you feel that something that size, probably not a good idea?
I think if it's very small, and by that I mean, it's like almost like a punch perforation of the tip of the stapled device, then potentially if you can't reach it or access it, then you can. And many cases do very well just with that approach, as long as you put NG down and allow time for that to heal. But it's just, I think with her comorbidities and she's 75, it's worth a try if you can do it at the same sitting.
Okay, right. And how would you repair it? You mentioned Vicryl. How are you going to get it down there?
So I've just used the microlaryngeal instruments. The laser set has crocodile forceps, which are quite the lumen's quite broad, and the tip's easier to actually utilize as a suture holder, and then you just use another one to draw that through. I don't use anything specialized as such. I know they are available, but that's what I've done in the past.
Occasionally I'll go and raid the laparoscopic surgeon's armamentorium and get things from in this sort of situation. And this is another appearance of the stapling device actually didn't deploy properly. You got the crimps, but the staples didn't actually deploy through, which is why you've got the tear. So it's sort of dropped back. And this is looking straight down towards places that you'd rather not go. So we've already answered all of these. Definitely not conservative in this situation. We want to do something. We're either going for open or endoscopic. And exactly as you said, Mr. Deek, in this case, I went for endoscopic repair, Vicryl, got it closed up, kept her nil by mouth, got a barium swallow at 72 hours. And actually, she never looked back after that, which was fortunate. How about if it had started to leak and she'd then got an abscess in the area around it? What should we have done? Qureshi?
Fine. So if we've got an abscess there, we've got to evaluate that with a scan. And then we've got to look at the prospects of exploring a decompression. So she might need an external approach. I would do a cricomyotomy.
Okay.
And because it's a delayed wound, I may not be that successful closing it after taking the pouch out. So I might put a T-tube decompression there. And I mean, I don't have the experience, but there may be a thought of putting a triple lumen tube down to decompress the stomach and take the tube out from the neck, from the perforation, and let it heal, and obviously drain the abscess.
Okay, Mr. Deek.
So yeah, very similarly in the sense you obviously want to get urgent cross-sectional imaging with contrast to assess where the abscess is, and if it's extending down into the mediastinum, because then you'll decide whether this is going to be something you're going to manage on your own, or you're going to need thoracic surgeons to help with percutaneous drainage if needed. And yeah, if it's ISO to the neck, then yes, and obviously an open approach with debridement and closure, but also local muscle flap to reinforce that area. And again, whether you need to divert at this stage will really be dependent on the extent and the edges of the laceration. If they're epithelialized, if they're necrotic, and it's going to be very difficult, then potentially you're also going to have to look at alternate nutritional routes of feeding if you're concerned in regards to that. But otherwise, obviously an NG and ongoing enteral feeding through that route.
Not a very happy situation for any concerned, really, is it? Okay. Any top tips in terms of feeding regimes or things like that? Would you go for a peg tube? worried about the nasogastric crossing over the area, or would you just go straight for nasogastric?
I put a nasogastric if it's localized to the neck, and I'm doing it.
I must admit, on the ones that I've had with abscesses that I've acquired, I've always wanted them to have a PEG tube, so I didn't have the nasogastric over the area because I'm concerned about ongoing contamination. But I've got absolutely no evidence for that. It just feels right to me.
I think it also depends on, is this a contaminated field extending down into the mediastinum? And if you've got pleural collection and you're having to have VATS procedures to drain, then yes, you may want to think about long-term alternate feeding routes in that scenario also, because nutrition is key to ensure that you're going to get appropriate healing in a timely manner with this case.
Correct. If it's beyond the neck, I'd go for a PEG. That's what I would do.
Okay, fair comment. Right, now I was hoping we were going to have the involvement of an upper GI surgeon with us, but I'm not sure if he's on. Jay, can you enlighten me?
Yeah, no, I think he's not there. I think, but thank you very much for finishing the panel on time. Actually, in fact, you saved me around 8 minutes, but you have some job, and there are a lot of questions in Q&A, which is a very good thing.
Good. Well, let's see what they are then.
You can kind of type the answers because I have to play the last 2 rep videos and before I finish. And thank you very much, the last panel. Thanks a lot. I really appreciate all of you. Thank you very much.
Okay, thank you very much, Jay.
Thank you, Jay, and well done. Very nice.
Thank you.
Thank you, Omar.
Hello, I'm Andy Plumpton and I am the ENT Business Manager for Seven Healthcare Technologies Limited. We're delighted to be supporting the Scottish Head and Neck Conference once again. Seven Healthcare, for those of you who are unfamiliar with us, are a medical device distributor based in the UK, focusing on head and neck surgical specialties, and within the field of ENT, most notably surgical voice restoration, tracheostoma care, plastic and reconstructive microsurgery, and more recently, injection laryngoplasty. The first product I'd like to focus on is the voice prosthesis placement surgical kit from Blomsinger, used for primary or secondary placement of sterile voice prostheses, and is the only kit currently available that allows a surgeon the chance to puncture the party wall, to then crucially size the tract they've created, and then using the catheter to dilate and anterior grade place a sterile voice prosthesis of the appropriate diameter and length in an atraumatic fashion. Blomsinger are also at the cutting edge of tracheostoma care and have launched 2 new lines, next generation products for tracheostoma care. The StomaSoft laryngectomy tube range for gentle but secure management of stomal stenosis, and the HydraFit adhesive housing range that contains a hydrocolloid base plate in varying shapes. These base plates can be applied directly over the surgical site and can help to aid healing, reduce infection, and also, most crucially, allow for the placement of a heat and moisture exchange cassette to enable the patient to commence pulmonary rehab promptly after surgery. Outside of the sphere of laryngectomy, we're delighted to be the UK-based distributor for Renew Voice, a calcium hydroxyapatite implant for injection laryngoplasty, management of vocal cord paralysis. This can be injected in outpatients using the percutaneous needle, via the cricothyroid or thyrohyoid membranes, or in theatre using our transoral needle. We're also delighted to be the distributor for Cogent Surgical in the UK. Cogent have a range of single-use disposable bipolar forceps, in particular the coag-focused single-use bipolar forceps that has a high dielectric coating on the lateral surfaces of the tips that focuses the RF energy more directly between the tips for a more concise zone of coagulation, and this can be seen on the video shown here. You can see here the thin line created by the focused forceps, preventing that thermal spread. And finally, we're also the distributor in the UK for Synovis. Synovis produced the coupler device and the flow coupler device used for the anastomosis of veins and arteries, normally encountered in microsurgical procedures and free flap reconstructions. There's a host of literature available to indicate the benefits of the coupler and the flow coupler, including use in management of vessel size mismatch of up to 3:1, reducing the time of anastomosis to roughly 5 minutes per anastomosis, but most importantly in reducing thrombosis and free flap failures. Our local area manager for Scotland is Andrew Dobson, and his contact details can be seen here. He'd be happy to help you with any inquiries.